DABS is what about the prevalence of anemia, burden of anemia, and eventual anemia.
Check, 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 mic check, check, test, mic check, testing, mic check, 1 2, mic check, check, test, mic check.
कहाँ यार में दूसरे के हॉल का है।
या किसी हॉल से आ रही है आवाज।
हाँ अपने आपकी नहीं है।
Check, check, mic check, test, mic check, test, mic check, testing, mic check, test, mic check, 1 2, mic check, test. बढ़िया हो गई।
ठीक है।
एकदम क्लिस्टर क्लियर हो गई।
Hi everyone, good morning. I hope everyone is rested from the day one of World Health Summit. Welcome to day two. We are starting our session on tackling maternal anemia for healthier pregnancies. And I would like to invite our moderator for this panel, Dr. Godar, on the stage.
Yeah, good morning everyone, and greetings and welcome to day two, show one of the World Health Summit regional meeting in Delhi. For those of you who were here yesterday, we had some very stimulating sessions as well as exchanges. And we'll continue that dialogue even this morning. And the focus of today's session is how do we deal with anemia? Something that affects more than half the population, at least across the globe and in India as well. What's even more critical is the anemia among the women, both prior to conception, during pregnancy, and the postpartum period. For the simple reason that anemia in this population is not restricted to them alone, but influences the offspring and has a transgenerational effect. Iron supplementation orally has been around for decades. But if we look at the rates of anemia that get reported, we haven't really made much progress, both in terms of identification as well as prevention and treatment. So we continue to invest in looking for alternative, innovative solutions, both in terms of diagnostics and treatment. Intravenous iron has been explored as an alternative to oral supplementation for a long time. The more recent IV iron formulations have better safety profile as well as can be administered in a single infusion, thereby ensuring, or rather avoiding any concerns about compliance and receiving the full dose of iron supplementation. So what we'll try to do this morning is look at some of the recent evidence as well as look at what is the policy framework that we have right now, what changes may be needed, how do we engage partners, and what programmatic challenges are there for scale up. So we are indeed honored to have a very distinguished panel sharing their expertise and wisdom this morning. I invite the chair of this session, Dr. N.K. Arora, onto the stage. I don't think there's an audience which doesn't know Dr. Arora. He has been a pioneer in public health epidemiology for decades and has been a mentor for a number of young investigators over the years. So thank you for accepting to chair this session this morning. I request Dr. Angela De Silva, nutritional advisor from WHO CRO, which I believe would be a key partner in looking at solutions not only for India but the entire Southeast Asian region, which has the maximum burden of anemia. I also take this opportunity to invite on stage the immediate past president of FOXI, Dr. Jaideep Tank, who has been involved in a number of initiatives of the ministry in terms of formulating guidelines and policy during his tenure, and he continues to be associated with those initiatives. So thank you for making it this morning. I also invite Dr. Reema Mukherjee from ICMR. And ICMR has perhaps the most critical role in all this as the apex body in formulating not only the research agenda for the country but also helping the ministry in formulating guidelines and taking up implementation research activities. So welcome Dr. Reema for this session. And finally I invite Dr. Kapil Yadav, who heads the National Center of Excellence on Anemia Research at the All India Institute of Medical Sciences. And not forgetting Dr. Kirti Iyengar, who represents women's health, sexual and reproductive health and gender equity portfolio of SIF, which is actually supporting this session as well as which has supported the rapid ion trial, which will sort of form the core for the discussion for the panel. I would be presenting the rapid ion trial results, but before I do that, I think it's better to get a much broader perspective of the whole anemia scenario. And I don't think there's a better person than Dr. Arora to do that. So I invite Dr. Arora for the keynote address to set the stage and tone for this session. Dr. Arora, please.
Good morning, friends. Thank you very much, sir, and the GHS for giving me this opportunity. And early morning to see a good audience is also very heartening and encouraging and motivating. So as Professor Gaudhar said, in fact, anemia is world's biggest public health problem. Wherever you go, it is world's biggest public health problem. And the interesting part is that now over half a century has passed. The world, and particularly low and middle income countries, are struggling to get over this, and with very little success. So there is something, it appears, grossly needs re-engineering or refocusing. It appears, sometimes we say that I have dropped a coin somewhere but I am looking at somewhere else. I think something of that kind seems to be the issue. And particularly adolescent and maternal anemia is something which affects and impacts the society immensely. mother is obviously affected, the fetus is affected, the family is affected, the next generation is affected, and the whole I think it is the way it is influencing the economy of the family, society, and the country is something where even estimations are difficult to make. Maternal anemia particularly has to be seen in the social context. I think the ecosystem in which the mother and the adolescent girl is growing up. So it is, if we just look at it as a biomedical problem, and I think it is there that we are missing the target. And so this social and cultural and ecology is something which needs to be looked at more carefully and dissect out where are we going wrong. And within the same environment, we find 50% are not anemic, but 50% are anemic. So there is something which we have all focused our all energies on those who are anemic. But I think it is equally important to find out those who are not anemic, why are they not anemic? It's equally important. We look at exemplars. We look at exemplars in terms of which state or which country is doing better. But I think within the community context, one important dimension is to look at also those factors where anemia is prevented or not occurring in half of the population. Who are those? The other important thing we have just done, we have completed a systematic review of, one is etiology of anemia and the other is micronutrient status. And recently a lot of good studies have been done by several groups within the country. Micronutrient deficiency is so rampant, and many times we look at just iron deficiency or in isolation or a solo mechanism, but we know that all micronutrients interact with each other and how they are leading to a kind of a state which does not respond to the usual supplementation and the other measures. We are also forgetting one important dimension, and which is dietary diversity. And dietary diversity again is very contextual. Recently we have done a study across 3 sites in rural Haryana, peri-urban Uttar Pradesh, and tribal Meghalaya. So dietary diversification, when we look at, it has to be seen in a very contextual manner. What people in East Khasi Hills eat and their definition of diversity would be different the way a rural Haryana mother is consuming or in peri-urban Uttar Pradesh. Because food habits are different, and accordingly, and therefore when we looked at the data and used FAO cutoffs, it does not match anywhere, neither with anemics nor with non-anemics. That at what point the sensitivity specificity is almost 50%. You can flip a coin and say this may be the cutoff or not. So this issue of social cultural ecosystem plus the food ecosystem, and the third is the wash dimension, because we know that the absorption is immensely affected, and most of the times we are blaming the health system. But the NFHS 5 says that 92% of women were given iron folic acid prophylactic. Despite that, nothing has happened. So there is something. We keep on blaming adherence is poor or compliance and all those things. But even then, the needle has not moved. So what I am trying to say, that when we are discussing, please look at the other dimension of this whole issue. coming to the health systems, I think we have done a evaluation of the Anemia Mukt Bharat in 15 states very recently. And one of the preposterous finding, I would say, that there is practically no focus on treatment and tracking. So when half of the population is anemic, even if I give, I need to track them, because beyond anemia there are other factors also. So if after 2 months or 3 months, if the person is still anemic, we need to do something. We have to find out whether it is a compliance issue, whether it is an issue of absorption issue, or whether it is an issue of something else is also there, that things are not moving. And the program is practically not focusing. In fact, I would say the energies are getting diluted. According to the current national program, I see almost 50-60 people sitting here. All of you should be taking iron supplement every day for rest of your life. That's the program. Is it possible? No, it is not possible. But those of us who are anemic must be treated, followed up, and see that we become non-anemic. So there seems to be some steps to be taken so that the focus of the program changes. And at least when we are looking at it, we were evaluating the antenatal program as part of another activity. And we found that although the lady was diagnosed as anemic, but she was not given treatment. She was just given single dose of IFA every day for next 30, 90, 100 days kind of thing. And so the ANM forgot. So while we may say that we have to reach the last person, we are reaching 92% is not a bad coverage. But when I am not focusing on what is to be done, I don't know whether we can ever move the. And finally, recently technology has come in. We need to use and leverage technology for monitoring. Hemoglobinometer is a very welcome step. And I must say that most of the states now have on the program, hemoglobinometers are there. There are hiccups. Technology does not come overnight. It takes time. I do not know, many of you who are little younger than me but not very young, you will remember that when we had first time gas cylinder in our house, our mothers also used to keep it covered and use it only for making tea or boiling the water, milk kind of a thing. That is the way. It's a natural phenomena. We did it for 3 years, 5 years. Today it might be done at least for first 1 or 8 years. It is just that induction and introduction of technology, when it is done, it takes time to get mainstreaming. So hemoglobinometer is coming. I think technology will improve, but it has to be used in a manner that it helps in monitoring, tracking the anemia, which is not being done. So if I have 50% anemics, and if I have to test them every month or every 2 months, I need to have strips which are sufficient for them. But I have only strips for one-time testing for all my population. So, so the program has to work on that. So overall, I thought I will share some of the concerns and some of these gaps in our thinking process, which I would request the panelists, distinguished panelists, to think and discuss about and try to find some way forward. And it is important we have a funding agency as well and the global technology team, that how do we move forward. Many of us are part of this global technical group also. And the way forward has to be thought through in a way which is different from what we have been doing all these years. Thank you very much.
Yeah, thank you, sir, for setting the stage for the session. So what I'll present is the findings of a recently completed study. Okay. led by my group from the Women's and Children's Health Research in Belgaum, called the Rapid Iron Trial. The trial was implemented in 3 districts of Karnataka and 1 district in Rajasthan. A community-based trial, and we started recruitment right towards the end of the second wave of COVID and worked through the next 1.5 years in completing recruitment and enrollment. And I think this is perhaps the largest community-based RCT of single-dose IV iron. And the context is, as has been already mentioned, that iron deficiency is an intergenerational state and perpetuates from one generation to the other generation. So we need to fix this. And the more severe the level of anemia, the more adverse the outcomes. So the best perhaps possible time to intervene is before the woman actually conceives, because anemia is not something that she develops after she gets pregnant. It's something that she carries into the pregnancy. But this trial focused on the pregnancy anemia, and we're looking at whether the supplementation by oral iron, as per the current standard, 60 milligram elemental iron twice daily, compared to a single dose infusion of 2 IV iron preparations. How does it fare in converting A to the non-anemic state? And we also were interested in newborn outcome in terms of whether it is able to reduce the rates of low birth weight. And you're all aware that it's difficult to tease out IUGR versus preterm, so therefore it's a sort of a composite outcome. So 2 primary outcomes. And we chose 2 IV iron preparations because those are the 2 which are currently available in India and are marketed in India. At the time the trial was conceived and implemented, both the preparations were costing the same. Of course, last October, FCM went off patent and therefore the price equation has changed considerably. The generic FCM becoming available at a much, much lower cost. But the logic was, let's use both that are available, and if we are able to prove that IV iron is beneficial, we may be able to help in driving the cost down. So that is the rationale for using ferric carboxymaltose and ferric derisovmaltose as the 2 IV iron preparations. Both can be given as a single dose infusion at the rate of 20 milligram per kg body weight. We identified the women not only based on the hemoglobin level, but we actually measured ferritin and TSAT to establish that they do actually have iron deficiency. We got the gestational age confirmed by ultrasound. We ended up screening a good 40,000 women to recruit 4,368 to to the trial. We are able to partially blind the IV iron administration. Only the pharmacist preparing the infusion knew about which IV preparation was being administered to the woman. The provider was blinded. And we looked at the delivery outcomes. Of course, we had intermediate follow-up as well to look at both non-responders as well as compliance to oral therapy. 4 academic partners were involved, and we also involved the Model Rural Health Research Unit of ICMR working in Raichur district as a partner in the implementation. The identification of the pregnant women and all of the follow-up and outcome measurement was done both at PHCs and at the community health centers. But the IV infusions were done only at community health centers. We didn't take the intervention below the level of the community health centers. I mean the IV infusion. Oral was given at the PHCs as well. Now these are the primary outcome. As I said, we had 2 co-primary outcomes. So when we looked at the low birth weight by treatment arm, there is a small but significant difference between IV versus the oral arm, an absolute reduction of 4%. When we looked at the conversion to the non-anemic state, at first look it appears as if there is no difference. And when we saw the results, we were also wondering as to what's going on. And then we started looking at what happened during the course of the study from the time of recruitment till delivery. So when we did a sensitivity analysis by excluding those who received pre-delivery blood transfusion or a non-study iron, mostly IV iron, at the beginning of the 3rd trimester, because they were not responding to the first line IV iron or oral iron. So when we excluded them, then you see that there's a significant difference in the rates of conversion to the non-anemic state between the IV group and the oral group. So we had an overall non-responder rate of around 26%. That is, even after iron supplementation, the anemic state did not go away. It was more so in the oral arm than the IV iron arm. And almost all the non-study iron that was given pre-delivery to non-responders was FCM, IV iron. A small percentage got oral iron. And the proportion which received non-study IV iron was much higher in the oral arm than in the 2 IV iron arms. We also had a couple of significant benefits in terms of reduction in stillbirths and early pregnancy losses with FCM compared to the oral group. What is also interesting was in any of the 3 arms, the iron underloading was not fully prevented, whether it is oral or the IV iron. And therefore, prenatal iron deficiency in the fetus carries to the postnatal iron deficiency in the infant. We looked at the trajectory of hemoglobin change and the ferritin change during the course of the pregnancy, and what you see is clearly the IV iron arm did better until we assessed them for non-response and gave an additional dose of IV or oral supplementation. And as I said, much of the supplementation was IV. So what's perhaps more important is in the critical window of the second trimester, the fetal brain is deprived of iron, and that has long-term consequences based on published literature. Whether it is schizophrenia, whether it is autism, or neurological development. So it is this window that we really need to focus on, not only in terms of correcting the maternal anemia, but in terms of preventing the long-term consequences. The reason I'm bringing it up here is the current approach of treating severe anemia in the third trimester might probably miss the window of opportunity to protect the fetal brain when it is most important, that is in the second trimester. So the question that we need to look at is it time to shift the IV infusion from the third trimester as a rescue therapy to first-line option at the beginning of the second trimester. In terms of safety of administration of IV iron, because this comes up in almost every forum. So as I said, we restricted the infusions to the community health centers. The administration was done by the nursing staff, and they were trained for it, but the infusions were conducted under the supervision of a physician or an obstetrician. We made sure that emergency medicines such as prednisolone or hydrocortisone are available, and every woman was observed for at least a half an hour after the completion of the infusion. And single dose IV infusion has to be completed within 20 to 30 minutes. So it's a fairly rapid infusion. There were infusion reactions, but mostly flushing and self-limiting. Slightly higher rate in the FTM group compared to the FCM. There were no hospitalizations. Only one case of anaphylaxis related to the IV infusion was there, but even that was managed locally. Only 15 out of the nearly 3,000 women who received IV iron could not complete or did not receive the full dose. The infusion had to be stopped. I've said this earlier, so I'll not repeat what I've already mentioned, that we are not only looking at the correction of maternal anemia, but also looking at the iron loading of the infant and its impact on the developing brain. There have been two other recent RCTs which have also looked at FCM. They did not show much benefit. The possible reason as to why we did not see the same kind of results was this was initiated in the third trimester, much smaller sample sizes. Iron deficiency was not confirmed by ferritin and TSAT measurements, It was purely based on hemoglobin assessment. And perhaps the context is different in African countries compared to South Asia and India. So I think it's fairly safe to conclude, based on the results, that a single dose of IV iron at the beginning of the second trimester is good, and FCM appears to protect low birth weight and IUGR. We don't know exactly how this is happening, but we need to explore it. So we can consider IV iron as a first-line treatment. Single dose is safe and effective, but infants in all arms were still underloaded at birth. And therefore, we need to look at whether to go with a higher dose in the first time infusion or a repeat dose at the beginning of the third trimester. So that's perhaps the research question that needs to be addressed in future research. And that's the team that was involved in the trial, a huge team, a massive effort, tracking deliveries all over the district at different time points, getting blood samples. So I really acknowledge the contribution of each and every member for the implementation of the trial, and of course SIF for the support. So that's the trial. So now I open up the discussion for the panel. I'll start with Kapil. You have been part of the, as the PI for the National Center of Excellence, you have been part of the ministry initiative in introduction of FCM as a option for the treatment in third trimester. So what are some of the issues that you are working on in terms of developing guidelines, training materials, SOPs, and sort of give us a sort of a big picture view of where we are right now, and what's the direction that we are taking.
Thank you, sir, for excellent presentation. I think setting the context. As far as AIIMS and NCRA's role is concerned in IV iron as a strategy, basically what we were engaged was bring this as one of the options for anemia control in the program. So historically the understanding was that IV iron has to be, I will not like to specify it as a molecule specific intervention because a lot of new innovation is coming, newer molecules are coming. So historically it was primarily limited to tertiary care centers, that too in a intensive care setting. That was understanding. So our team's role had been to sort of translate into public health programs and show the safety of this intervention per se, from bringing, taking it out from tertiary care center, medical institutions to secondary care and primary care, because that's where the maximum number of cases are there. So that advocacy, and that was based on research and use by our own team, both in community setting as well as in the hospital setting. So I think right now newer molecules are the first line of treatment that are used for at least for severe and moderate anemia of pregnancy. So that advocacy with the policy makers, with the program implementations, with the technical groups, that was one component that NCRA was involved. Second component came into when it was sort of accepted by the government that this intervention does work and can be translated into program, was capacity building. So various levels of capacity building was done at medical colleges, at district centers, at district level hospitals, at primary healthcare centers, and we were part of team that developed the SOPs for various intervention. Third area where we were actively involved was overcoming the hesitancy around using a newer intervention, because historically iron infusion is linked to IM dextran, and most of the medical textbooks still carry on that hesitancy that it leads to anaphylactic reaction and all those things. So a lot of effort went into engaging with the primary caregiver, and making them realize that these were sort of associated with a much earlier versions of the molecule. Now the newer molecules, even IV sucrose, FCM, diisomaltose, are much safer, and we learn to differentiate between what is known as infusion reaction and anaphylaxis reaction. So once they start using, and there are a lot of benefits. Once you start, like in AIMS now, their OBGY department primarily uses ferric carboxymaltose as this thing. So postpartum hemorrhage has more or less has disappeared as an entity, because that is what the impact of this intervention is. That obviously there are certain health system issues, the costs are involved, the management aspects are involved, but I think these are the areas where our team has been working. Thank you.
Yeah, thank you. I'll come back to you again. Dr. Dima, you represent ICMR, and ICMR has a huge responsibility, not only in terms of developing the research agenda, but also guiding the ministry in terms of policy. So what are some of the recent initiatives within ICMR in terms of both research priorities as well as activities related to programmatic implementation around anemia? I know there's been a major effort at, number one, collating data from data sets around the country, and pooled data analysis activity is ongoing. But besides that, what is ICMR's thinking in the management of anemia?
So thank you. So yes, one of the activities that we are doing is we're trying to understand the etiology and the prevalence of anemia. So there is a large activity where we are pooling the data sets of studies that have been done on anemia from across the country, and we're trying to understand through secondary data analysis that what are the causes, what is the etiology, etc., in the various age groups. The other thing is that the results of the DABs, now renamed as Sampada, will be released hopefully in another month's time. But what is encouraging to know is that after the reclassification of the cutoffs for anemia that was done by WHO for the second trimester, the data from the DABs, or the Sampada as we call it now, is showing encouragingly that in pregnant women, the prevalence of anemia is around 8 to 9 percentage points lower than what we had, what we knew of it earlier. But we will still wait for the formal results to come out. So DABs is one thing that was carried out, was an extensive research activity, and the results are going to be hopefully released by next month. The other thing that we were involved programmatically was in, like Gowda sir and Dr. Arora were also part of it. We had this intensive brainstorming to understand that what are the newer strategies, or how should we re-strategize Dr. Kapil was also a part of it, re-strategize the Anemia Mukt Bharat program, so which we kind of called it AMB2, and that is where the concept of test, track and treat came out, and the requirement of, requirement of devices or technology to enable this test, track and treat, so non-invasive hemoglobinometers, etc. So we sat with Neeti, with a lot of experts, and we made a kind of a package which we are also trying to test through a very large implementation research on anemia, which has got funded and which is going to start off hopefully in later part of the year in across 5 or 6 states, where we're trying to understand that what are the strategies which will ensure improved adherence, which will allow the frontline workers to test, treat and track women. In the same, are in sync with the AMB, because algorithms that you use in a hospital setting are obviously different from what you will use in a program settings, where we have the restrictions or the limitations of the health system that we are review, we've put together an anemia treatment algorithm for pregnant women. And we are now in the process of taking feedback on that algorithm from CHOs and medical officers working in PHCs who are seeing the ANC clinics, to trying to understand if they feel that, you know, certain aspects of the algorithm make it difficult for us to implement. So that is the other thing we are doing. Besides that, we've been validating non-invasive hemoglobinometer, because we understand that without, like Sir said, without being able to test, treat and track and identify the other non-iron causes of anemia, we may still be hitting a roadblock. And finally, I think we must be aware that we have just taken out an EOI. There's been a technology transfer of the point-of-care ferritin testing from Cornell. And now we're trying to identify partners who can develop this point-of-care ferritin. And we feel that it will be a very huge advantage to have a point-of-care testing for ferritin within the program, because you will be able to identify people who are contributing to this anemia outside, the cause of iron. So, sir, in summary, this is what we've been doing at ICM.
Yeah, thank you. Again, I'll come back to you for the second round. When we look at NFHS data, there's another number that we should be a little concerned about, and that's the uptake of spacing methods. The general pattern among our population is to have children at as early as possible and close the family and go in for permanent methods of contraception. So there's hardly any interpregnancy interval for the woman to recover from the iron depletion that happens during pregnancy. Dr. Kirti, you head the portfolio in SIF, which is looking at contraception as a possible intervention that can help address this. And there's also this issue of heavy menstrual bleeding among adolescents, which also leads to iron depletion. So what are some of your initiatives and thoughts on how we could address this?
Thanks, Dr. Rauder, and thanks all the panelists for sharing your very insightful comments. So, Shruti, would you like to present the slide? Yeah. Yes. Okay. If you can go to the next slide. I'll just use 4 to 5 slides, to convey my message. So I think as like Dr. Rauder, Dr. Arora, all of you have spoken that the prevalence of anemia continues to be high in India, and over the last several decades we have had many efforts. However, we are still not able to make a huge difference, both among non-pregnant women as well as among the pregnant women. It is close to 57%. Next slide. Yeah. So if we look at the causes of iron deficiency and iron deficiency anemia, this is from the FEDRO statement, which has shown that actually the symptom of heavy menstrual bleeding is a lead-in cause of iron deficiency and iron deficiency anemia, although other causes also exist, but heavy menstrual bleeding is one of the biggest causes. And in fact, like if you see the highlighted part, what is being said in this brief is that heavy menstrual bleeding may exist in as many as 50% women. And it's not unique to India. This paper is for global data. Even from Europe, studies have shown that the heavy menstrual bleeding is very common. But what is more important is that it is frequently normalized. And that is a risk factor for the development of iron deficiency. It's normalized by women as well as by healthcare providers. We who work with the healthcare system, we know how often our providers take an anemia seriously, because it is so prevalent, so it's not really taken very seriously. Next slide. Yeah. So I think we discussed as to what are the various strategies which are being used for the control of anemia, especially iron deficiency anemia. We have been using the approaches of supplementation, fortification, biofortification, dietary diversity, and of course we also heard about very important role of intravenous iron. It's not only the oral iron. However, so far, globally, very little attention has been paid to the issue of heavy menstrual bleeding. So like there is a leaky bucket and you keep on putting it supplements and diet and everything. However, the blood loss is actually much greater than the intake. And that is, many studies have shown that. and that there is a close linkage between heavy menstrual bleeding and anemia. However, there are no overall, it's not unique to any one country, that overall there are hardly any strategies to control blood loss at the public health level. And we probably need to see whether we should also consider that in our anemia programs. Next slide. Yeah. And because I was asked about the role of contraception, if you look at the studies on the association of the role of contraception, especially the hormonal contraception and anemia, you find that there is plenty of data which is available. There are like studies from 51 low and middle income countries which has shown that women who used hormonal contraception had lower odds of anemia than women who did not use a hormonal contraception. There are studies from other low-income countries, and based on the DHS data, this analysis. For example, the first study mentions that those using injectables, oral pills, or implants had odds ratio of having anemia was 0.6, close to 0.6. It means 40% less chances that they would be anemic. So this is, and there are many more studies. So which basically what they all conclude is that the hormonal contraceptives, especially injectables, oral pills, implants, but also what is not mentioned here is hormonal IUD, which is actually has even bigger role. However, it was not captured in the DHS trials, but there is plenty of research. I'm keeping the time, I'm not present in those, which offer a lot of protection. Next slide. Yeah. And if you see the effect of different methods of blood loss control, then it's not that everybody needs a contraceptive. So if you compare to the women who are using no contraception, the need for daily iron intake among the women who are using proper IUD is 50% more, because as we know, proper IUD leads to increased menstrual bleeding. Those using NSAIDs for blood loss control have 25% less need. Those using tranexamic acid has 50% less need. Oral pills users have 60% less need, but those who are using hormonal IUD, that is LNG IUD, have 96% less need for additional iron supplement, additional iron intake, which basically shows that, like, coming to the next question, that how while providers in the family planning clinics or any clinic are looking at women, they should look at the effect of different contraceptives on what they will do to women's anemia levels. Next slide. Yeah. So actually this implications for family planning programs, we had a consultation a couple of months ago in which lots of experts on this issue had participated, and this is a synthesis of those recommendations, which said that health programs need to consider the impact of different contraceptive methods on anemia, and they support the scale up of different methods accordingly. For example, in India right now, the use of hormonal contraception as per NFHS 5 was 0.5%, while the use of sterilization plus property plus all the other methods was the major, like if you look at the method mix. So we probably need to have greater use of hormonal contraceptives in India, where the prevalence of anemia is so high. It was also recommended in this expert group meeting that for women who are seeking contraception, the healthcare providers need to, of course, test for anemia. We discussed that we need better testing. We need better testing not only for for anemia levels, but also for serum ferritin. But also, while they are counseling, they should consider what will be the impact of my counseling or the method I am recommending on women's anemia level. We know proper IUD leads to increased menstrual bleeding. We know hormonal methods lead to reduced menstrual bleeding. So at least we should have that consideration and counsel the woman accordingly. And similarly, the postpartum contraceptive counseling. In India, we have about 25 million births every year. And we have postpartum contraception is a very strong program. Lots of women receive contraception in the postpartum period. That is also a time when women need to be counseled properly during antenatal and postpartum period about various contraceptives. And this anemia angle has to be kept in mind. The guidelines need to have a little more focus on the non-contraceptive benefits. They are already very comprehensive. They do mention non-contraceptive benefits, but probably we could mention them, highlight them a little more. And of course, the long-acting reversible contraceptives, especially the hormonal implants and hormonal IUDs, they are a very promising approach for addressing heavy menstrual bleeding. In fact, they are used even for women who do not need contraception. I think Dr. Jaydeep can talk more about it. So these are the approaches which are widely used. Point of care testing, I already mentioned that they need to be there. As well as we need to have point of care, some kind of a diagnostic method to test which women have heavy menstrual bleeding, because right now there are no standardized methods that are used in the public health setting. Next slide. Yeah, very briefly, it was also discussed what should nutrition programs do. It was felt that we need to have better integration between nutrition and RM and CHA programs, so that there is better understanding as to how some of the maternal health and contraception interventions have an impact on anemia. Anemia guidelines need to integrate the blood loss control as a strategy. That was like unanimously, I think the whole expert group recommended that. And of course, then other activities such as greater awareness of the frontline workers, including Anganwadi workers and Ashas and everyone else, on what is heavy menstrual bleeding, anemia, and these methods need to become available at peripheral health facilities such as health and wellness centers also. But also at the community level, we need to understand why people are not reporting heavy menstrual bleeding, because they have normalized it. So what can we do to build the awareness? So I would stop here. Thank you.
Yeah, thank you. Dr. Jaydeep, you are the only one in this group, the panel, who actually are in direct contact with women and treating them. And you also represent probably the biggest stakeholder in terms of providers in India, the FOXI. So what do you think is the biggest barrier here? Why are we not able to crack this nut of anemia in pregnancy and childbirth? What your perspectives are?
Thank you, sir. Let me first say that I'm very thankful to GHS and the team for putting this together, and it is a privilege to be a part of such an eminent panel. You must remember that when I speak, I'm not speaking as a public health expert. I'm a practicing obstetrician and gynecologist, and some of what I say may sound even naive at times, but this is, I believe, the perspective of someone who is a practicing obstetrician and gynecologist. I think one of the first things we have to try and do is increase the level of seriousness with which anemia is taken in pregnancy. I have always felt that just because it's so common, I call it the banality of commonality, just because it's so common, we are so used to seeing women who are pregnant with low hemoglobin that we perhaps do not completely either comprehend or do not take the problem of anemia in pregnancy as seriously as we should. And I think for that to happen, perhaps we need to establish the linkages or talk about the linkages of the problem which anemia causes. And one example I always give is that of postpartum hemorrhage. One of the problems with PPH, of course, is the fact that the diagnosis of PPH is visual. Means we say that there's 500 ml of blood loss, 300 ml of blood loss, and therefore you now need to start treating the PPH. But sometimes what is not taken into account is the fact that a woman who has a low hemoglobin tolerates blood loss more poorly than a woman who has a normal hemoglobin. So 500 ml of blood loss is 500 ml of blood loss, but someone who's got a hemoglobin of 7 is going to tolerate it much more poorly than someone who's got a hemoglobin of 12. So perhaps this association of, in a way, the consequences of anemia is something which we perhaps have not been talking about enough. When you talk about consequences like long-term impact on fetal brain, etc., people think to look at it as an abstract, and I believe that's one of the problems with preventive medicine in general, that people don't really look at the impact it has in the long term. People want to know what's there in the short term. So I think the first thing I want to say is that we need to start taking maternal anemia more seriously, and we need to start looking at the linkages of maternal anemia with the consequences of maternal anemia more clearly. The second is, I think we tend to look upon achieving a good hemoglobin at an early point in pregnancy as an endpoint to the treatment. And I think that's a mistake, because anemia in pregnancy is progressive. You remember the old guidelines which said you need to have a hemoglobin of less than 8 to give parenteral iron. And I thought that's a problem, because suppose what is 10 grams at 28 weeks? Because of the progressive nature of the problem, will become 8 grams at full term. we don't really always take that into account, and in that way I feel we need to lower our threshold for the administration of parenteral iron to a much more liberal way of giving parenteral iron, because if we don't address the issue at 10 grams, she is going to enter labor as a anemic patient. The next thing I just want to say is that perhaps there is a generational hesitation in the use of parenteral iron. I don't like to say I'm old, but I'm senior. And I know that the people of my age or my generation have grown up in an era where parenteral iron was always taken with a little bit of skepticism or even cynicism because of the side effects that it caused. We don't realize now that IV-FCM is completely different from what was available in the earlier generation of parenteral iron. I see it in my family. My younger brother, who's 6 years younger than me, is also a gynecologist. And I find that he uses IV-FCM because he was trained in the era of IV-FCM. So that intergenerational hesitancy, I think, is something which we have to address. And we traditionally say that we need to train people who are young. I think for IV-FCM, you'll have to go back to the seniors, not the old, the seniors. Okay, and try and convince them of the fact that parenteral iron is really not the same that it was in your generation. And I think lastly, we will probably need a very large shift. I think we need to change the paradigm of how we treat iron. I always say that for women, one of the most unpleasant experiences of pregnancy is taking oral iron. There's hardly any woman who takes oral iron and doesn't have some side effect or another: gastritis, change in the color of stools, constipation, diarrhea, so on and so forth. Why can't we look upon this or the use of IV-FCM as something which alleviates this problem of symptomatic oral iron? Imagine a protocol where you say that, as you have done in the rapid iron, everybody just gets a single dose of IV-FCM and doesn't bother with oral iron at all. You're getting rid of one of the most irritating problems of pregnancy completely. So I think we will probably need to do something which is out of the box. We need to see a paradigm shift in the way we approach, and also ask women whether they would prefer to take a single dose of IV-FCM versus taking oral iron every day for the rest of their pregnancy. So I think, it's not really a very easy issue. Otherwise, it would have been cracked long time back. But I think we need to change the way we think about IV-FCM and have all these shifts in the way we administer it.
Yeah, thank you. I mean, that's a wonderful perspective. Talking about postpartum hemorrhage, there's a significant school of thought saying that rather than talking all the time about uterotonics, treat anemia, you will reduce the incidence of PPH significantly, because there's a direct connect between pregnancy anemia and postpartum hemorrhage. A great point, and thank you. Dr. Angela, you lead the nutrition portfolio in WHO CRO, and also perhaps are uniquely positioned in terms of bringing together partners and collaborators, and even initiating community outreach activities as well as part of your portfolio. So from your and WHO CRO perspectives, what do we do to take the Anemia Mukt Bharat program and improvise upon the implementation?
Okay, good morning. Thank you very much, and good morning to everyone. So, all my fellow panelists did give very important ideas and suggestions, and they come from a range of partners, private sector, I beg your pardon, public sector, academia, big philanthropic organizations. The ones that are missing are probably the smaller community organizations and the private sector. And we know that all of these have a huge role to play in supporting the government in order to implement the government's agenda. So if there were some very good examples given, starting with treatment options, devices that can be produced, also monitoring and evaluation. Also in terms of, like the panelists from SIF said, advocacy on actions such as heavy menstrual bleeding. We know that there's a range of causes and determinants of anemia, and there must be a range of treatment, prevention and treatment. If we take, a very good example is what the FOGSI experts said on IV iron. Yes, there is a use for IV iron, but there is hesitancy, and there's also further research that is needed. For example, in the private sector, it may be difficult, it's very probably not ethical to give IV iron without doing a ferritin assessment. But we all know that in the public sector, ferritin assessments are expensive. But there are newer methods coming up, such as spot ferritin, which could be used. As WHO, we tend to work on evidence-based guidelines, and most of our guidelines are informed by research done by other partners, research funded by governments, other agencies. And when these are brought together, we also look, when we develop guidelines that are adapted by countries, we also look at it through an equity lens. So whatever guidance that we provide must also be equitable, so that it is accessible not only to the higher income groups or private sector, but also to the public sector. And this is why sometimes our guidelines are a little bit late in coming. Very often partners, experts come up to me and say, why is WHO not bringing in these guidelines? But we look at a range of actions, a range of information before we promote these guidelines. Now, India is particularly unique if you look at the region, where there are many, many partners working in other, probably because of the size of the country and the population density. If you look at the other countries in the region, most of the programs, and India too, are government-led, but you do not get so many partners, so many experts, so many philanthropic organizations also working on it. One drawback that sometimes occurs, not always, is that the coordination between these different, for example, between the government and these different bodies, as well as coordination between the different bodies, are an issue. And for that, I suggest that government has to take the lead for the countries. The government has to set the agenda. Government needs to coordinate. Government needs to monitor and hold accountable all these organizations and agencies that work, and ensure that all of these work towards public good. Thank you.
Yeah, thank you. I'll do one more quick round of the panel before I open the session to you all. Kapil, as part of the policy group on Anemia Mukt Bharat, how do you see IV iron getting incorporated and integrated as part of the program?
I think a lot of program repositioning would be required if IV iron as an intervention has to be positioned as one of the main strategies for anemia control. And good thing is, while we were having discussion on AMB2 as compared to AMB1, the focus now has been more towards management vis-a-vis prophylaxis, and that's where I think IV iron becomes a very important component. Clubbed with management is your tracking. Basically, you catch hold of a person, and that's where the algorithm that ICMR team was leading what developed. Once you catch hold of a person with anemia, you don't leave till him, you resolve the anemia components, and that's where I think IV iron would be a very important component. Closely linked to that, I think, would be the diagnostic capability strengthening, both in terms of newer innovation with new science, as well as introducing them into the public health program. There are very, very exciting innovations, non-invasive anemia screening, point-of-care testing for ferritin has come. lot of new artificial intelligence based parameters are coming. Your peripheral smear screening by AI, we are doing right now, doing a research project on that. So these could be paradigm shifting, and if they are introduced in primary healthcare setting, secondary healthcare setting without any cost implication, I think these could be the mainstay of the program, and that's where I think IVRN can also be a very important sort of a, I would say, a catalyst for bringing about that change. Club with that, I think what we need to also focus is on the supply chain issues. We tend to sort of not take cognizance of these issues. The problem of anemia is so huge. 50% of your population is affected by anemia. So once you get into this mode of management, intervention, diagnostic, there are very, very serious challenges as far as supply chain is concerned. So you have to ensure that each and every primary health center, even now the Arogya Mandir, ARM centers have a sort of a continuous supply chain linked to these parameters. And lastly, I think one of the most important component would be monitoring and evaluation component as far as IVRN is concerned, because there's a lot of onus of the health system. Once you're giving a IV intervention to an individual, the individual becomes very closely tagged with the health system. So it's very important that we learn from other successful program. AFI from immunization is one important lesson, I think, and Government of India is right now sort of trying to develop a similar system for IVRN also, so that there is a confidence building and each and every case of sort of a adverse event is tracked, and that I think that's where I think IVRN would be a game changer.
Yeah, thank you. Dr. Rima, in terms of research priorities for ICMR, what are one or two key questions that we must be focusing on?
So during the evidence review and when we were formulating these algorithms or the guidelines, we realized that we need more, firstly, a lot of anemia in maternal anemia and otherwise is mild anemia. So I think there is limited research around the causes, the treatment of mild anemia, and I think which is really important, because in all age groups we saw that a considerable portion of anemia was mild. The second thing that we realized was postnatal anemia. Prevalence of postnatal anemia is quite high, and somehow the mother after the pregnancy, her motivation to have oral iron or the motivation of the health system to kind of track her reduces. So prevalences are almost as high as 70 to 80% in the. So that is another under-researched area that we are hoping to work on. The third, as I said, was identifying the non-iron causes of anemia, which we felt was through the point-of-care ferritin testing and other strategies. If we can identify the non-iron causes, and we need to work on that. And finally, NIN is also looking at linking the levels of anemia or HB levels with clinical outcomes, like what severity of anemia, what HB levels with what maternal outcome or what fetal outcome. So they are also trying to work on that. Besides that, the IR program is trying to look at things which are quite difficult to work on or understand, like issues like social determinants or adherence to, because we feel that oral iron is a very simple, non-invasive kind of a method which is available. So what is the way to improve adherence, or if you're able to, how do you improve counseling, how to build up some work around ensuring that that this very simple and easy method for prevention and treatment of anemia is correctly used by women. So a lot of work is also happening around small counseling modules and how to improve adherence. So roughly this is generally the breadth of what we're trying to work on now.
Yeah, thank you. Dr. Kirti, given the critical nature of contraceptive practices, how do we incorporate it as a strategy for prevention of anemia in the policy framework?
Thank you, sir. So I think I already spoke about some of the guidelines and the clinical guidelines and the programmatic implications. I would say that before we integrate anything into the any of the programs, I think we need some implementation research to see what is the impact of different contraceptives, different contraceptive methods on postpartum hemoglobin levels, And for example, there has been some research globally on that, which has clearly shown the differential impact of different contraceptives on the postpartum hemoglobin and serum ferritin levels. That has not been done in India. That would also help us to understand what should be the programmatic implications. Along with that, we should also see the not only the physical effect, but also the social, economic, and psychological effect on women's lives with all these changes and anemia. And of course, some of the other programmatic interventions, which I already spoke about training guidelines, etc. In addition to that, we also need to see that the women who are seeking health insurance, can we have more coverage of some of these long-acting reversible contraceptives in the health insurance programs? And I would stop here. Yeah.
Yeah, thank you. Dr. Jaideep, you have been involved in the development of the guidelines for the rollout of IVIN infusion, and so how you and the FOXY can support the states in terms of training and ensuring that the IVIN can be rolled out effectively.
Thank you, sir. I think one of the ways I believe that the guidelines will help is reducing the hesitancy. There was always a question mark on the use of IVFCM in pregnancy, particularly in the private sector, because there was really no detailed document from the government which said that it's legitimate and you can use it. So I think these guidelines are really quite important, and also I think they, in a way, would help us to shift the focus from anemia to iron deficiency, because I think we increasingly in FOXY now realize that anemia, by the time anemia occurs, iron deficiency is already severe in patients where anemia is because of iron deficiency. And I have always wondered whether it's time to now shift the conversation from talking about managing anemia to managing iron deficiency. Because if you do that, there would be a way to perhaps even prevent anemia by tackling iron deficiency early. So I think by leading these conversations and also by way of some public-private partnerships, where FOXY could help to fill technical resource or even human resource gaps in some instances, I think FOXY could play a significant role in partnering. And I will just leave you with this thought that public-private partnerships traditionally have really not been very successful. And we perhaps also need to look at why they have not been successful. It is my view that they have perhaps not been successful because they don't always create a win-win situation for both partners. When you say partnership, the situation has to be that both partners enter it feeling that they have won. And over here, I feel that it's skewed in one direction or another most of the time. So when we talk about how the private sector can help, I think this needs to also be a larger conversation around public-private partnerships.
Yeah, very true. I think mutual trust is critical to that. Dr. Angela, how do we tackle this at the community level? What kind of engagement we need to have with the community to make sure that the program actually works on the ground?
Okay, so at community level, there's very little acknowledgement of anemia. Despite all the social behavior change, communication, whatever strategies that are going on, unlike, say, for example, some of the other issues, anemia is not taken seriously. It's normalized, like the colleague from on the panel said. It's a normalizing. Heavy menstrual bleeding is normalized. The importance of dietary diversity for preventing anemia, iron deficiency at community level among the family is very, very insufficient. Not only in India, but in many parts of the world. Even in countries where iron supplementation is taken and iron supplementation levels are high, very often the reason as to why it is being taken, the reason for continuing postpartum iron supplementation is not really sort of internalized in communities. And for this, we can do a lot more with social behavior change communication. But one thing that I feel is with all the new technologies, digital, if you take social media, we know so much about, we work, all our social media, I'm not an expert on this, but Instagram, Twitter, whatever. Why don't we use those as public health agencies? We are still depending on posters and group sessions, but the world has moved on. So I think for anemia as well as for other undernutrition, overweight, obesity, and as public health professionals, we need to utilize and make use of the different various types of communication strategies that are available. The final point I want to say is whatever you do in terms of social behavior change, the environment must also be conducive for that woman. So if we talk about dietary diversity, if the woman doesn't have the capacity or the access to diverse diets, however much she may be capacitated, it's of no use. However much we promote health-seeking behaviors, say IFA supplementation or whatever, if the Anganwadi center or say for example HB testing was a good example, if we don't have that environment in place to support the woman in her changed behaviors or the community to change those behaviors, it is really not going to work. So we need to work parallelly on very sort of targeted communication, using new methodologies, new social, different communication channels, but also at the same time parallelly build the systems in order to support those changes. Thank you.
Yeah. So I think there's to be a dialogue and action together involving policymakers, practitioners, government and non-governmental agencies. So I think it calls for intersectoral collaboration for this to work. I'll turn to the chair, senior but not old, member of the team, Dr. Arora. You said we need some out-of-box thinking to solve this issue. So what are your thoughts as someone who has lived your life tackling these issues at multiple levels? So what are your thoughts on where do we go from here? What we need to do to make this really work?
Yeah, thank you very much. So thank you very much for very wise input from all the panelists, distinguished panelists. And I very carefully looked at rapid iron study, and we are aware of some of the other studies also. Repeatedly it is showing that if you look at from a policy perspective, the balance does not tilt heavily in favor of IV if oral is being done properly. And in all these randomized trials, the iron compliance of oral compliance of oral iron, we know it is very poor. Jaideep was insisting on that. But we need to have evidence, as Angela was saying, and Rima also is insisting. So I feel probably in the program setting where you are looking for the effectiveness, not efficacy. You were looking at the efficacy, but we need to look at the effectiveness of IV iron. And therefore, I would request the funding agencies and the development partners that implementation research at a wider scale is done, where instead of oral iron treatment, IV iron single injection or 6 injections with maltose, if that is used and to see the impact, I think that will give us ground level understanding, because there are too many other covariates which are kind of smoothened out when RCTs are being done. The second dimension and the important point of T3, test, treat, track, is also can be done better, when I'm giving single dose or IV and monitor it. And within 8 weeks, if things don't improve, I do a detailed investigation and as part of the algorithm, go ahead with it. The other thing, I'm sure some of you will bounce at me, and is to also do a study on mild anemia. If we can use a single dose there and see whether if there are any adverse effects or any kind of underloading, overloading, or it takes care of the underloading part also. Probably we need to move from there, because for moderate to severe anemia, it's not showing any major adverse effect. I'm not showing in terms of impact, but adverse effects are not there. Let us look at that part. The third dimension, which I thought was important, and that would require a proper, something like a rapid iron study, if similar is done for mild anemia. Maybe SIF is hearing that, and if it can be done, it may be very useful. But the most important part, which Angela said towards the end, this issue of social mobilization is extremely important. During our evaluation of the program, leave aside the community, leave aside the women of reproductive age, the families. I think even health workers are not very sure and aware and conversant with the seriousness of anemia as a problem. And this word of normalization, कि anemia तो सभी को होता है, that issue also, so that component is something which really needs to be taken up with full gear. And finally, coming on the nutrition part, this dietary diversity, this is an enigma, we need to sort it out. Thank you.
Thank you, sir. I know we are almost at time, but I think I can take the liberty of going beyond by a few minutes. If there are really pressing questions, please direct them to the panel, and please identify yourself and yeah.
Good morning, all worthy panel and all worthy delegates here. Let me introduce myself. So I am Dr. Vineet. I am working as senior consultant RMNCH for Government of Meghalaya. I am working on behalf of Gates Foundation. Earlier, I worked for 2 decades with the Government of Haryana, WHO, and many other organizations. So actually, anemia is one such topic. Like I'm talking about Meghalaya state. So it's a northeastern states where the problem statement of anemia is way too high. Like we have 70,000 pregnancies annually. So out of them, barring exceptional cases, anemia is a rule, right? And it is not limited to mild anemia. It is moderate or in many cases severe anemia. And most of our maternal deaths are attributable to anemia. So that is a problem statement. So right now I am talking of like we keep on like discussing our principal secretary, our MD sir, and all there are so many partners working there. So we all like keep thinking about how to solve this problem. So there have been suggestions like alternative regimens. Like some say that daily iron folic acid intake may not be as good as like interrupted iron intake because of upregulation or down regulation of like receptors in the gut. So from this worthy panel, I would like to ask a question about any such possibility where instead of giving daily iron tablet, can we switch to like 1 or 2 tablets a week or so? Or my question specifically is it going to be superior in some way? Is there any evidence as of now that we should be considering this possibility? So that is my one question. Thanks a lot.
I think post recognition of importance of hepcidin regulation of iron, there has been a lot of interest in alternate day regimens. But as far as therapeutic regimens are concerned, I think still the daily regimens are better as compared to alternate. For prophylaxis, we advocate weekly or intermittent regimens. Right now, some research is being done on sort of having a single dose and regimens as compared to twice a day or thrice a day. So that's where, but it has to be sort of balanced with the higher reported incidences of side effects because of combined doses. So I think that's where, programmatically we are not taking a call. We are still going with the daily regimens as far as this thing. But I think there is some amount of work needed to be done on it.
So just to add to what Dr. Kapil said, WHO actually has the guidelines for intermittent supplementation in the case of prevention of anemia. So the recommendations are there and they can be utilized, of course, based on government concurrence and agreement. Thank you.
Dr. Amita.
Dr. Kirti, I found that very interesting, when you spoke about, menstrual bleeding and kind of linked it to anemia. And also the fact that, you had put up that, for each contraceptive, what was it, whether it did lead to anemia or whether there was a positive or a negative effect to it. Considering that tubal sterilization is still the mainstay of our sterilization program, and of course, I don't think there is really that any evidence that it leads to excessive bleeding, but it would also be interesting to see, whether in that little table which you had, if that was also there to give us an idea as to, when you're talking about it, that whether, how that leads to it or doesn't.
Dr. Navita, actually some analysis was done on the basis of NFHS 5 data by IIPS, which did cover all the contraceptives within India as well, which showed that compared to the oral pills which were used as a baseline, sterilization and proper IUD led to more anemia levels, while injectables, like those who use an injectables, had lower odds of having anemia. However, since the baseline was oral pills, I did not present it. Ideally, the baseline should have been either no contraception or condoms. So, but there was a discussion in the consultation on that slide as well. But you are, like, as I said, we need to have more implementation research from India to see the impact of various contraceptives on anemia levels and the associations. Yes.
Well, I think the group for the next session is already here, so I think we need to wind up. I thank all my colleague panelists for the time and valuable contribution, and I thank you all for joining us. Thank you.
Good morning, everyone. We'll just start in a minute. We are waiting for our chair to join. In the meanwhile, I'd request the panelists and presenters to please join us on the dais. Thank you so much for joining this session. And we have this session on Zoom as well, because many participants working in tobacco control wanted to attend this session, because for India and probably the region, this is probably the first such initiative which is looking at AI-based interventions in both smoking forms and for smokeless tobacco. So with that intent, we have ensured that our colleagues in tobacco control can join us online as well. So it is available on Zoom. Therefore, whenever you want to make an intervention, please use the mic so that our colleagues can listen to your question and the proceedings. So with this, I will hand it over for our chair to start the session, and also she would be moderating the session and taking questions. And we would be having Mayank as our discussant after we have presented, because we would like to hear how this plan is actually converging with the ongoing digital health technology developments in the country. So over to you.
Thank you, Dr. Monica Arora. First of all, a very good morning and welcome to this very interesting session. Already the name is very interesting, AI-driven conversational solutions for tobacco cessation. In fact, this is one of the, I would say, very new and initial initiatives funded by ICMR. And ICMR is the apex medical research organization of the country. And now we have got a very strong extramural grant project wherein we are funding descriptive research, development research, delivery research, as well as discovery research. And this was funded under the intermediate grant, and taking forward the tobacco suggestions effort already has been conducted by PHFI, basically consolidating it and also leveraging the new digital space that India is harnessing on. We have a very esteemed panelist. To start with, Dr. Monica Arora, who is an acknowledged tobacco control expert. She doesn't need any introduction. In fact, she's synonymous, I would say, with tobacco suggestion, and particularly among youth, and how championing the cause for tobacco way back when. In fact, she happens to be my former colleague at PHFI. Before coming to ICMR, I was also at PHFI. And we do have Dr. Kithis, again, he's also working with ICMR on AI and health. So we do have one institute and one division entirely dedicated to digital health, given the importance. In fact, ICMR and the whole country is now mandated. How can we, because India is one of the leaders in digital technology, but how best we can use this digital technology for education, for health, and also in multiple sectors. And we also have Dr. Sharmila from Tata Data Memorial Center, and I can also see one of my, again, my form, I mean, I used to know him, Professor Vikrant Mahanti. We have worked together, because what I see is that public health is a small world and tobacco suggestion even a smaller world, so you see more and more people whom you know. And we do also have Dr. Mayank, who would be giving the final touch and giving his perspective. And welcome each one. Welcome to this very interesting session. Now I will request Dr. Monica Arora to start with her presentation, which is,
So I'll come on to that side, and this is a slightly tricky pathway to navigate. All right. So as I said, this is just a grant which has recently been awarded to us. We have started only in March, but our protocol paper is ready. We have worked very fast on our processes while we were getting ethics clearance and all. We worked on this particular protocol. We are calling it CARE, which is an acronym for a Comprehensive AI-Powered Conversational Interface to Quit Tobacco. This is one area where we had been reading a lot of literature, and it has huge potential, but not being leveraged because of number of reasons. So just to bring everybody up to speed with what is the tobacco burden for those who are not initiated in tobacco, I'm sure by the end of this session, all of you would want to work in tobacco control and tobacco cessation. So looking at the prevalence of tobacco use by Global Adult Tobacco Survey in India, I'm just quoting India figures, but this burden is uniform in the region. Southeast Asia region is unique from the world on tobacco epidemic because we have the burden of both smoking and smokeless tobacco, which is the chewing form of tobacco, or taking it as a snus or tobacco water. There are so many variants. So the smoking prevalence is 10.7 and smokeless is much higher. And that is true for many countries in our region. So overall, about 29% prevalence is, when we convert it into absolute numbers, it's huge. That requires that, yes, there are two strategies to have tobacco control. One is prevent initiation. Second is those who are using, help them quit. Only then the health system would be able to strike a balance. Otherwise, the amount of deaths and mortality, morbidity that is related to tobacco use cannot be handled by the existing health system, or for that matter, even in developed countries, the health system cannot manage the amount of morbidity and mortality that tobacco causes. This is one risk factor which impacts every organ of the human body, right from the hair to the toe. So we can name every organ. Also, there is huge demand for quitting among tobacco users. So again, according to GATS, among current smokers, more than 55% current smokers want to quit. And similarly, 50% smokeless tobacco users want to quit. So there is demand, but we are unable to provide the supply. And that's principally because of health system requiring strengthening. And till the time we don't have it, we have technology to take place of professionals, workforce, where individual attention is needed, and every human being may require a personalized attention when they want to quit. So what is the inadequate health system capacity? According to the literature, only few smokers and smokeless tobacco users have utilized pharmacotherapy or counseling support. Counseling support is the easiest way to quit tobacco. People do go cold turkey and quit tobacco, but support definitely improves their chances of quitting tobacco, to the fact that studies in UK actually have shown that just when the physician asks whether you are a tobacco user, that itself raises quit rate by 5%. So, you know, history taking itself is so very important, and we are not doing that. We all visit our health system, we go to individual physicians, and we know that's not happening. So there is low utilization for cessation, and tobacco use currently, as I said, is estimated to be causing 1.35 million deaths annually in India, and this is huge loss to our productivity and our economy. So an economic cost of close to 27.5 billion US dollar is something that we all need to stand up and pay attention to. Another important point is benefits of quitting. Within hours of quitting, the body starts recovering. So again, from the data, it is very clear it is reduced morbidity and mortality for sure with extended period of quitting, but improved respiratory health within for the lung functions has been noted in former smokers. Cardiovascular benefits, the risk of coronary heart disease is reduced by up to 50% within 1 year of quitting. So definitely an intervention which needs to be invested in. Cancer risks reduce, reproductive and perinatal health improves, and also tobacco users who are advised to quit tobacco, again among smokers and smokeless tobacco according to GATS, is available. But when we look at the quit rates, they are very low. And most important, we have to remember about the relapse. There is a very famous proverb saying, quitting smoking is very easy. I have done it 100 of times. So that again underscores the importance that tobacco cessation needs to be seen from a different lens. Operational challenges of the current tobacco cessation clinics, national tobacco quit lines. Many of you would have seen it on tobacco product packages. We now have quit lines available. But again, the problem is trained workforces available or not in these centers, whether people are coming for follow-up, or there is policy support available. There are social cultural barriers, low awareness, even if they are referred to TCCs, not being used. And we will hear more from Dr. Mohanty, as he has a national level picture. Similarly, for NTQLS, we have been informed that there is limited counseling available through NTQLS. There is lack of information that people want on quitting. There is dropped calls. We all know the quality of calls. Then people put their numbers on blocked. They don't want follow-up calls, so they block the numbers of counselors. So there is huge loss to follow up, and which can be utilized. Somebody calling NTQLS and nobody picking it up. A motivated user coming to the system not being attended to is a huge loss. So we need to capture each one of them, and CARE provides that solution. I will not get into a lot of details, but text message, mHealth, telephone counseling, all have been evaluated with limited success. Not to say they are not successful, but we can accelerate this success much more through AI-based interventions, chatbot counseling, making it individualized, providing motivational interviewing, confrontational counseling, and generative AI approaches that we propose to use. And my presenters, Dr. Kshitij, would be able to provide that much better. Effectiveness of AI-based tobacco cessation interventions in the other parts of the world, only smoking specific have been tested. Very small trials, and much more needs to be done. So the study overview, this is ICMR funded, investigator initiated grant, 3 years study duration, and study sites are our TCCs in Bangalore through NIMHANS, Tata Memorial. We have Dr. Sharmila with us, and in Assam, the B. Barua Cancer Institute. Clear objectives, we will co-develop this intervention, so not something top-down. We will work with the users on what are the needs and where the challenges, how the facilitators and barriers can be addressed. We will assess the feasibility, acceptability, usability, how to make it more integrated with individuals' needs, and evaluate as well this CARE intervention. Our primary objective outcomes would be successful quit attempts, as well as increased intention to quit among the users. And secondary outcomes are for the implementation research, acceptability, usability, and user engagement, and how we can better that. So the innovation is co-development and AI intervention. And key challenges we are addressing, we will be making it appropriate for smokers and smokeless tobacco users, rural, urban population, providing multilingual support, making it personalized, customized to context, user queries to be answered at their convenience, potential to significantly enhance the existing cessation services. It will surely do health system strengthening and also user-friendly, and once developed and tested, it has the potential to be replicated around the globe because we have 127 countries using smokeless tobacco, not just the region. We are now exporting this problem as well. So I'll stop here and I'll request my next presenter, Dr. Vikrant, to come up.
Thank you, Dr. Monica and Professor Vikrant Mahanti, who has, I remember, he was one of the few pioneers who started tobacco suggestion in oral healthcare settings. So, and he would be speaking on how important it is to have a tobacco suggestion models and how can digital advancement be leveraged in oral healthcare settings. So, what do you?
Yeah, I think I'm audible to everyone. Thank you so much. I think it's a very important platform that we are on, and it is important that we discuss more important things in terms of why exactly. One, we all know that the burden is high, but at the same time need to understand what is that in tobacco that keeps everybody hooked, and all the solutions over these years. Have they been really, in terms of data, I think there's a lot of evidence in terms of what is happening and where we are heading and why we are coming up with innovations. All that is there. But at the ground level, if you talk about what is still missing is something which we need to probe on and we need to look at. And I think other than sharing this presentation, which is very, I felt very run of the mill, which has most of the information taken from the internet as well as some, but I think more of anecdotal or more of information that we practice every day. We run a cessation clinic. I'm very happy to see Dr. Sharmila Pimple here. One of my initial inspirations were Dr. Pimple ma'am. When we started the first time in Siaga Dental College in 2009, she was the first one to conduct this cessation training program in that institution, and that is where the seeds were sown for me, where I continued my whole my professional career into tobacco cessation from there on. And I don't forget from where it's always nice to meet, and Gauravi ma'am also is here. I see ma'am here. It's so nice to see literally the people who have inspired me and as well as inspired many others across the country, to have them across, because over the years we have grown. Surely, yes, we have. The cessation clinic at Maulana Azad Institute of Dental Sciences started in 2011, and from there on in 2021 we started the National Resource Center for Oral Health and Tobacco Cessation. I think Monica ma'am did present a lot of data in terms of systemic health and its manifestations and data related to that. But something which was very evidently missing was the oral part, which is one of the most easiest and at the same time very evident part, which clearly shouts out that yes, I am a tobacco user, and that is something which we need to, and that is where the dental professionals come. 300 plus dental colleges with more than, I think, 27,000 graduates coming out every year, 8,000 postgraduates from dental colleges, huge human resource available. And similarly, if you look at all the other human resources in terms of medical colleges, they also started off now the cessation clinics in medical college, 700 plus medical colleges. So there is a huge infrastructure which is being laid down over the years. And NTCP is another program. The National Tobacco Control Program is one more program which has also strengthened tobacco cessation services over the years. The NTQLS is one more approach. M-cessation is there. Now the creation of NCD clinics is something which has also been instrumental in linking or integrating the common risk factor approach into tobacco, tobacco and other chronic diseases, non-communicable diseases. So what I'm trying to say here is, in terms of one, the approaches have been there. 2, the human resources have been there. 3, there has been a policy shift in terms of, when I started, I would always as ma'am said, we were the first few people to be speaking more of cessation, and the O, as always in most of the forums, they've talked about O being orphaned rather than O being an opportunity or offer. So now that that orphan has grown beyond it's come to ages, and I think that what Empower has really powered the offer category, and we have moved into such a state where now everybody is talking about offering cessation. Yes, cessation is not an easy job to do, because you sit with your patient, try to counsel, provide medication, run down follow-ups with him, try to integrate treatment, but still at the end of it you still don't achieve what you're trying to achieve. So what is that which is going amiss? That is what is we still have to look at. And when we try to individualize the strategies, it still doesn't work. After a lot of efforts, we have done it day in, day out, we do it. Even today morning, Dr. Gaurav was there in our cessation clinic. My hospital is just 5 minutes away from here. So we just walked down after seeing 3 patients. And even while seeing those patients, we realized that, hey, they will quit or not, we could make out that they just come for dental treatment and they don't want to quit. So that is what we have to understand, that we have come a long way. Data speaks that there is a huge need for cessation services. 71% of the population who are tobacco users are trying to quit without any support. Pharmacotherapy, again a big challenge. Availability is a question. NTCP is providing as much as it can, but the way NRT works and the way it it solves the problem is again creating more and more newer problems. And Madam would agree that nicotine is has become a new challenge for us in times to come. So we would now see the advent of nicotine pouches or herbal variations of various nicotine products. And and we already seen the advent of ENDS, the electronic nicotine delivery system, which is India took that very dynamic step of banning through the PECA, and that was a great move in terms of banning e-cigarettes. But still, availability is a huge issue. We all know that it is still available, but the government has to work out strategies of implementing. So I just wanted to talk about this one particular slide, because the other slides are all, I think, my esteemed technical experts who are there always speaking about them. But this is what is the most important aspect in terms of understanding the challenges. Till the time we don't understand these challenges, till the time we don't plan out any solution that we try to take out, is going to be a failure. Even the best of the solutions will be a failure if they're not implemented well, if they're not evaluated well, and at the same time, they do not evolve well at the end of it. If they don't evolve with time, evolve with need, evolve with data, again they will be a failure. So tomorrow again we'll have another new technology coming in, and again we'll sit across and we will debate that new technology in terms of with reference to what M-cessation didn't do, what Quitlines didn't do, and then what maybe AI could not do. A newer version of the technology from here on would try to address the same problem. So who's the one who is dodging all this? I think we ourselves are dodging it. So we have to be very realistic, we have to be very practical and try to understand that these are perspectives which I've tried to jot down in the morning. The patient is the center, or the tobacco user is the masterpiece. He's right in the center of all this. Why does he do it? What pushes him? The social background, the cultural pressure, or the economic burden in terms of and then other than that, the other aspects which are there, which have been listed and discussed a lot. But we have to understand that the tobacco user is one. Obviously, we are looking at implementation at very early level, at the school level, so that he does not start. That is something which we have to, and I think GYTS data has shown a tremendous impact. There has been an increase in the age of initiation, which is again a very good effort that the tobacco control has shown. So I think that is something which we have to understand, that we start early, try to see that the environment which is there is more promotive, more obviously not controlling, but same promotive in other aspects rather than tobacco. Next thing is what we have to do, and mainly the patients, what they feel is, they feel that, in our dental hospital, we feel that the patients just come for the dental treatment. They have a toothache, they have bleeding gums or whatever. So whatever their concern is, they come for that, and that is what needs to be solved. And beyond that, they don't need any support. They feel that it is my choice and I would deal with it. So patient perspective in terms of, what is their choice, leaving it to them becomes a big challenge also. At the same time, you motivate them, you counsel them, give them pamphlets to read, provide a very positive environment around, but still it doesn't work. I have a few of my postgrads sitting here. The day in, day out, they're working and trying to do this, trying to follow protocols, trying to implement it. But still, they would have stories to share when it comes to, what ultimately happened with those patients. The dropout is huge. And that is why I think where technology will be a boon. The dropout in terms of telephonic follow-up, we have a very closed user group wherein we follow up our patients continuously with our telephone. We have a number which is a part of our clinic, and we follow up those patients, see to it they visit for the dental treatment. They come and, at least 4 visits is what we target in 1.5 months to 2 months. And that is something which we have been successful. Yes, the quit rates are very poor in our country, hardly 4 to 5%, but in our case, we're a little bit better, but we have seen we have developed our own system where we see that the reduction is also an important aspect. Maybe that will lead them to completely quit. So we talk about 1, complete abstinence or self-reported quitting for 6 months. We talk about reduction in terms of 50% and 25%. Our 50% reduction rates are almost 34%, and our 25% reduction is much lower, though that's something which is it is between 22.5 to 26%. So that is our 25% reduction. So we've not still come down to a great level. Success rate overall quitting is around somewhere between 8 to 9%. So that is something which data from, I have data of around 5,000 plus patients, and we look at that and we come up with these figures. So that is something which you have to keep in mind. And then another aspect is integration. See, ma'am talked about a lot of systems which are required to. So here there is a dentist who's speaking, who's very passionate, over the years has grown and evolved cessation and been a part of this journey. But we need champions more in terms of TB tobacco, in terms of cardiovascular tobacco. We need champions in other streams of medical sciences where there are people who are taking this and together. And we need professional bodies like how PHFI has been in the forefront of youth and tobacco control. So we need bodies which could take up in a more sincere and systematic manner, obviously with evidence-based strategies trying to bring out changes. And most of the patients who visit us now, they want quick fix solutions. They say that please see to it that by tomorrow I should be able to quit the habit. So you have taken years to quit, develop this habit, and over a period of time we try it cold turkey, but it doesn't work again. That's again a challenge. If someone has to leave, they will surely. If they don't have to leave, they'll search for avenues of getting back again. Talking about data, because I think that is something which is a very critical factor, and technology will surely help us in bringing it. There's a lot of loopholes in terms of data collection. We still are struggling. At our institution, we have tried to ease out that, but we still don't have a common data template or a system in place where we could upload the information, capture the information timely, and see and evaluate that same data. We have developed our own inbuilt system, but still at the national level, that is still missing. And whatever data sets are given at the national level are very, very superficial and not providing any intricate details. Next, in terms of research, I would say low focus in terms of cessation. Again, that is an area because you're not able to come out with results. Dropouts are huge, so the funding is poor there. And next, in terms of secondary data, there's a lot of secondary data analysis which goes in, and that data is based obviously on a properly designed primary data. So there is still a gap in our primary data collection patterns. Our operational research is still lacking that strength and that rigidness, and that that could give us data which we could analyze properly in the times to come. So that is something which we need to understand. And health, as I told you, we need champions, but at the same time, people in the health system are burdened, and this burdened health system needs solutions like maybe AI could just aid in taking those 3-4 steps ahead, and then adding that counselor or the physical contact, which is very essential for our patients. Indian patients are still very emotional patients. They still require a human touch. They have not understood this logic of completely going to a machine. So the transition has to be there. We are working towards it, and I think the solutions are actually bridging that gap. Whatever the time and the available space is there, we are trying to bridge that. So that human touch is still required in most of our contact sessions and counseling. Any machine will not be able to provide that. So we have to bridge it as much as we can and be as practical as possible. And the system per se, burdened with population for sure, burdened with 28.6% of the Indian population consuming tobacco is a huge number. 266.5 million people consuming. So just imagine the burden of tobacco use in our country. You start and I don't think so we will be able, by that time we reach somewhere, there will be much more users added to the same pool. So that is something which, and obviously the policy decisions are very positive still. There have been a lot of changes with the ministry's focus towards cessation, and I'm really very happy that the ministry has taken great strides towards it. And we are one of them who, the creation of the National Resource Center itself is a symbol of their commitment towards cessation. Trying to address 300 plus dental colleges, 9,000 plus dentists under the National Oral Health Program, and trying to bridge the gap in itself is a great effort. And to be a part of that itself is, a lot of meaning. I think the AI intervention which comes up should also be, other than the premier institutions like NIMHANS, TMH and Barua Cancer Center, needs to also look into the dental or other health systems that are available who are ready to partner and try to implement it. So these are a few issues which I think are very important, and it is important that systems which are coming in time need to address these challenges per se. For example, availability of NRT is a huge problem. So if solutions by which can guide us about availability, not to the patient but to the healthcare provider, in terms of where are the stocks of NRT available, where is it being supplied, and where all the stocks are available, the real-time information in terms of the stock management, which is again a problem. But then in terms of if the AI-driven system can not only look at patient perspective but also start evolving further into a health system perspective, that would be great. So currently we are at the patient perspective, but then in times to come we need to look at a larger domain to address, and I think a health system perspective would be great, because you will not only capture data, you will not only capture the real-time availability of healthcare providers, but also training component, and all these components which I talk could become a part of the future models that we're trying to develop. So I think from here on, all these slides are very, just run-of-the-mill business, just information for all of you in terms of what are the strategies that WHO recommends. But it does not stop us. WHO does not stop us to limit ourselves to this much. As a country, as healthcare professionals, and public health professionals, we can go way beyond this. There are still lacking evidences of community-based cessation programs. I think we need to look at how communities can play a role in cessation. So that is something, because again, India remains a very, as I said, a very rooted country in terms of its behavior, in terms of its society, in terms of culture. So using all these platforms into developing a more integrated system would be a great option. So these are services, I think M-cessation, which ma'am spoke of, again has challenges, has a lot of issues. We need to integrate the NTQLS with AI and M-cessation. So we'll be looking at that in times to come. The digital landscape has changed since COVID-19. It's been a great boon. In terms of not in the right, I would not mean that COVID was a boon in terms of what impact it created on health and health system and the people, but in terms of what it created, how it started making us think about our own preparedness. That is something which COVID actually questioned, and that itself is what I'm trying to say, that COVID allowed us to start thinking more deeper in terms of what solutions could be possible. So I think that way, and we need our reach. Reach has to, we just completed a session with Northeast states of around 8 states and around 65 dentists. And the main problem with them was that, so whatever we do, our reach to the patients is next to impossible, because the physical distance, the patients don't come, and these are challenges which are there. So how do you balance? And that is where such technological interventions need to be, handy. So I think all these components, like all of you are aware of the Ayushman Digital Health Mission, you're aware of the telemedicine, the eSanjeevani portal. So there are a lot of channels already working. So we need to harness all these available resources to see what best can be done. So unless we don't, we will be still missing the point. So I've already talked about M-cessation. So it's been a successful, but obviously there are huge challenges in terms of its reach. This particular platform, I would say MyGov, has been good in terms of awareness and can be utilized to a great extent. And today social media is a big champion in terms of the reach. So I think should be made, if it looks at also awareness, it needs to look at integrating with other systems already in place. So this is for the training module. We are using the iEco platform now and developing this modules for for cessation, which is already in place. And there are a lot of mobile apps. I think that's what we are trying to work out with this particular intervention. So this is ultimate slide would be what AI could do is to work on all these aspects. And I'll not go into details because we have our experts waiting in line. I just quickly would just look at solutions more targeted to youth, more targeted to specific vulnerable populations. Like, you can talk about TB. Again, it's a huge burden in our country. TB, tobacco are the usual suspects together. So you need to target them. You need to look at cancer strategies and also look at targeting them as a common risk factor. And obviously, all these innovations need to be monitored and evaluated in times to come. So we also need to look at the civil society, a huge role that is being played by the civil society and as well as the private health system, which is almost 75% of our workforce, which we need to understand. We need to rope them in also into all these efforts. So these are a few examples, and obviously until unless the policy is not in place and the money is not in place, we don't have much solutions that we can move on. We can have funded research, but then in times to come, these funded research need to go to a population level for which a lot of funding is required. I think that is where the policy level change needs to come. So these integrations and strengthening capacity is something which we have to look at, and until unless we don't build our capacity that way, all the systems built on one side will fail. So it has to go on hand in hand, and that is where we can look at the changes. So tobacco, as I said, is not just a health issue. It is a cultural issue, it is a social issue, it is an issue in terms of obviously health, and at the same time it looks and affects the development of a country. And that is what we are most concerned about. If the youth fall trap to, we have the demographic dividend, that is the youth is on our side of our country right now, because other countries mostly are aging populations. We have a youth-driven population right now at hand. And if the youth is stricken with tobacco and other risk factors like alcohol, then we are obviously need to worry. And I think solutions are very important so that they can drive change and bring more development to our country. Thank you so much for your patient hearing.
Thank you. Yeah, thank you, Professor Vikrant Mahanti, and highlighting all the challenges. So it's more challenging for Professor Kithis to see how AI and ML can come to rescue to address these challenges in tobacco suggestion.
Thank you. Thank you for this invitation, Dr. Monica. I'm Kshitij. I'm a faculty at IIT Bombay. I'm a trained physician who was not good enough to stay a physician, so I started doing AI/ML work, and now I do AI/ML in healthcare work at IIT Bombay. And I also have this lab at IIT Bombay called Artificial Intelligence in Digital Health Lab. It's just a bunch of servers and students working on the servers. And I'm also currently working with the Ministry of Education in establishing the AI Centers of Excellence. Currently, I play the role of the sectoral expert in health and AI, as well as an acting chief project coordinator for this. So about a year back, when Dr. Monica contacted me to be a part of this thing, LLMs were and are still the rage and the talk of the town. So the idea was that how do we reach at scale? And the first thing that came to my mind when I spoke to her was that we need to harness the multilingual capabilities of large language models that come in. So I'll quickly run through this. India has around 250 million tobacco users. It's ranked second globally. India loses approximately 1% of the GDP every year because of tobacco use. There are tobacco cessation centers in district hospitals and dental colleges. There's a national quit line. And despite existing programs like Dr. Vikrant just talked about, the cessation rates remain abysmally low. So why is this so? Right? So we are expecting individuals to come and seek services. That is one primary problem. Second is there are long wait times. Even quit lines sometimes, because of limited manpower for personalized interventions, are not available. Third is there's deep-rooted behavioral drivers, right? There are varying levels of motivation, so it results in low predictability. And the blanket rule-based interventions, it's like one-size-fits-all interventions. While there is definite help or thought process towards doing it individually, it still follows this process. What I'm going to say is that AI can actually offer scalable, context-driven, personalized, evidence-supported solutions to individuals. And that is what I think Dr. Vikrant actually talked about extensively during his talk. So quickly running past through this, so there are AI/ML solutions for tobacco cessation. You can actually have predictive analysis. So you would like to know who will quit. It's an important question to answer. Who is quitting? Who will quit based on their profile? You have to monitor treatment, you can develop clinical decision support systems, you have wearable devices, and conversational agents is something that we'll talk more at length. The first question is, can we predict who is likely to quit and who isn't going to quit, right? This is an important question. So there's a lot of data available, right? For example, GAT surveys is available and LASI data is available. The clinic data, the state of change, addiction level data is available. There are several biomarkers that could also be taken, and nicotinine is an important biomarker. So using machine learning solutions, we can actually identify who is less likely to quit so that we can do targeted interventions. For example, we did a machine learning classification analysis of the GATS data, who could quit and who could not quit. Now, GATS data comes inherently with its own challenges, but that's where we are supposed to come in, and a lot of pressure put by Dr. Mohanty on us that we will try to solve those problems, right? So we have tried to do this. So we have used GATS data in my lab. I have a very smart PhD student called Dr. Rumani who worked on this. And what we found out is that there are certain features which are considered to be associated with quitting. For example, education status. It's considered to be associated with quitting, didn't turn up as an important feature in quitting, right? Then these intervention, like people who try to quit by themselves are least likely to quit. Is another feature that came out through our machine learning analysis. And importantly, to be able to, like these advisories that are given, right? What is the effectiveness of these advisories? Potentially very negligible effect. Probably because they are not targeted. Like, see, if we can get targeted Facebook advertisements, right, we can get targeted advisories as well. So that was the whole thought process that we were working on. So the key insights for such things could be that you can actually pinpoint relapse risk, understand enablers or barriers to quitting at an individual level, and then you can develop tailored interventions for high-risk individuals, so that you don't do a one-size-fit-all method, you actually do individualized solutions. But there are a bunch of challenges, some of which were alluded to Dr. Professor Mohanty. Like there's a lack of standardized data collection. Primary data collection is a big problem. But from a machine learning perspective, from an AI perspective, data that gets collected is highly categorical. It's a yes and no, mild, moderate, severe. Utilizing such data sets in a machine learning algorithm creates this problem of high dimensionality. And high dimensionality makes your models overfit. As a result of which we're actually trying to develop novel methods or work with novel methods like entity embedding, so that we can identify personas of individuals and try to cluster them so that we could see, can we give personalized interventions. And this is the kind of work that we not only do with this work, but we also do with, for example, identifying in a rural health setting, what is the persona of a household as far as the nutritional intake is there, right? There is a household which has regular meals with fruits, and there's a household that does not take regular meal and eats a lot of junk, right? So there are personas that can be associated with households, but there are also personas that can be associated with individuals. And utilizing such categorical data and then trying to make sense of it is something that we do in our lab. Now there are several remote monitoring services. I'll not talk about this. There are sensors, there are AI rings. There is this nudging triggering identification quit support solution that is present. Geotagging, for example, you can be tracked through your mobile phones. And if you're in your usual smoking spot, you can actually be told that, dude, you're here. Like, do something different. Right? So let's talk about large language models. And how are large language models going to be very different from chatbots? So traditional chatbots are rule-based driven, right? Large language models could be contextually driven. There is a large language flexibility that is available in large language models, and especially in India, there's a lot of effort going on. MeetY is actually doing this huge project right now with 10,000 crores, developing large language models for the country. The personalization actually is more dynamic in large language models. Also can also understand the context more strongly. And it has a scalability positivity because they can self-learn from the data. And there is some work that has already been gone, right? Like for example, there are improved quit rates when compared to emphysization methods. And we all might have tested with Florence and Sarah, the WHO AI agents that are being promoted as AI solutions. But these still fall short because they are not contextually personalized, and there is no deep behavioral coaching that is associated with this. So what is the ecosystem for conversational agents in Indian context, right? So the Indian population actually prefers audio, and there is sufficient solution now available in the country to develop audio-based speech-to-text solutions. The challenge is multilingual, but also there are several solutions that are available in the country, like Bhashni is there and Anumad is there. These are open source solutions that are present. And compute is I should stop saying compute is a problem, because compute is no longer a problem, because the Ministry of Information Technology is investing 10,000 crores in procuring compute. Now we have 16,000 GPUs available to be utilized for public use. So India has a very unique opportunity, right? The LLM-powered tobacco cessation system has a vibrant AI ecosystem. The language resources are now available. The audio and text tools are also available, so that we can support the human layer as well as integrate with the existing platforms. So this is the Developing Large Language Models Based Conversational Agents is ICMR intermediate grant that we have together. And what is the anatomy of an LLM-powered conversational agent? It is pre-trained on multilingual corpora. You can actually fine-tune it to specific solution delivery. But there is this problem of hallucination, and all of you might know about hallucinations with large language models, right? So there was, when GPT 3.5 was released, a very famous tweet came out where a guy asked GPT 3.5, what is 2 plus 2? And GPT 3.5 said 4. Then the guy responded saying, no, it's 5. My wife says it's 5. And GPT 3.5 said, oh, your wife is correct, it's 5. Right? So the point that I'm trying to make is, right? Yes. It's trained through humans, right? So yes, it is. So the point that I'm trying to make is, one should not confuse fluency with intelligence. Large language models are fluent, but they have to be trained in a particular way so that you can route your answers into a particular set of information only. And that's where retrieval augmented generation, or the RAG framework, comes in, right? Survankar is here. Survankar, I think, has been utilizing RAG frameworks for a very long time. So what does retrieval augmented generation do? So you have a language model. All of you have been utilizing language. Almost, how many of you have used ChatGPT? Almost everyone, right? So these are language models. What you put into a language model is called the prompt, right? You put inside it, whatever enter, it's called a prompt. And generally it starts generating responses. What you can do with retrieval augmented generation is that once the prompt goes in, you also tell the model, these are a bunch of set of documents from which your response should come. So I don't want you to respond from the bunch of knowledge on which you have been trained. I want you to only utilize the grammar abilities, but I want the knowledge to be generated from this bunch of document store that I'm going to generate, which will be retrieved. The relevant ones get retrieved, given back to the model to generate a response. So now you're actually trying to decrease hallucinations, because you're trying to say, don't generate from this entire corpus of information, just generate from this smaller set of textual information which are highly curated, expert identified. One important thing that we want to do in this project is to be integrating personas in LLM-based cessation techniques, right? So can be identified through simple conversations, a motivated quitter or an unmotivated quitter, or a person who is in a rural area or a urban area. The advice that you give is of course very different, right, for such individuals. And importance is to increase effectiveness. Can the response be tailored using user's readiness stage? And almost all of us have been trained. There's a pre-contemplative stage, and there's a contemplation stage, and there's an action stage, and relax. And the same advisory will not work with all individuals. So we need to first find ways to identify which stage this individual is, and then we should be able to give specific advisory depending on the stage of the person. So it's not only a language model driven process, but is also identifying the persona of the individual, which is very fluid, to be able to categorize that person at that point of time into that stage so that you can give specific advisories to that individual. So these are the stage of change which can be utilized for identification of persona building. And all of us have thought about this, right, and worked on this. There's a pre-contemplation stage and contemplation stage. And all these stages, a different advisory will work. A single advisory will never work on such individuals. So you can actually and all of you have this information where in pre-contemplation stage a particular set of advisory works, and if you are able to identify the individual in that particular phase of change, you can use specific RAG-driven techniques to retrieve only those documents that will work, only those advices that will work on this individual. And this is exactly what we want to do, because this we cannot do at scale just through human intervention. You require a digital intervention like large language models to be able to deliver this at scale. So what we are going to do is we are going to first identify the stage of change identification and build the persona of the individual. So this is something that we have been doing for other settings also. So you have a large language model, have a simple conversation with the individual which is tailored on that person's initial responses, right? It could be driven through their, it could be delivered using multilingual settings, and have an empathetic conversation with the user so that it is not robotic, and that is the problem that we see with Sara, right? It's very robotic, but it's not very robotic, so that you can actually extract the right information from the individual, which will help us identify in which stage of change that individual is. So now what you have done is you have used large language models and a simple 2 to 3 minute conversation, which is what Dr. Mohanty was talking about, a history taking process where you take a very simple conversational agent to identify the key features that will help us identify which stage that individual is in, right? Once you're able to identify the stage of the person and other personal factors, now we already know what type of advisory works on what stage of individual, then you can develop RAG-driven advices using large language models. And that's why the point that I'm trying to make is solutions are off the shelf available. We just have to put them in the right order. And in medicine, and Survankar and I, we always talk about this, medicine is such a scenario where solutions are potentially always available. We just have to put them in the right phase and right order to be able to deliver those solutions. So this is the summary that what we are going to do. We have a large language models, and we are going to work with open source models only, and they're coming very regularly day in, day out. Then we also have specific tobacco cessation manuals, which we know that in a particular set of individuals, what type of advice works, so that we can do persona identification. We'll validate, for an initial few months, we'll validate these human responses, and then use a RAG-based response from large language models. So this is the entire pipeline, so that then we can test it into the 3 settings that we are going to have. And with this, I will end. Thank you very much.
Thank you. Thank you. Thank you, Professor Kithis. That was very optimistic. I mean, we feel very now inspired. So now we will go to the ground reality with Professor Sarmila ma'am, how it is happening in her own tobacco suggestion clinic, AI-driven tobacco suggestion.
So good morning and good afternoon again, and thanks for the opportunity to present. Well, from the highly high-tech technology-driven presentation, I will get the audience back to the ground realities as to how we work and whether digital solutions are going to provide this, the right kind of a solution to us. Yeah. So, well, as we know the current landscape, okay, we are all doing the right thing that needs to be done, but it's not enough, as we know, and more needs to be done in terms of how we are going to penetrate the tobacco cessation services. So that's the current landscape for tobacco cessation services, as described by Dr. Mohanty also. And typically, the tobacco cessation clinics, which utilizes the rational emotive behavior therapy model for behavioral therapy. And here in my conversation here today, I'm not even going to touch about the pharmacological aspects, okay? Because, they are way too expensive, okay? The patients, I would still say patients, the patients are non-affording, and the entire tobacco cessation process and the implementation is behavioral model driven rather than pharmacological interventions. So we are using this typical 5 A's and 5 R's, so-called, for the counseling processes. And So then, yeah, today here we are to talk about, I mean, the failures, the challenges, okay? We are not able to reach despite the levels of intervention and penetration through the national programs, the emphasization initiatives, the various otherwise emphasization programs that are being used, the quit lines which have been introduced. But like, I mean, where lies the challenge? I mean, in a typical tobacco cessation clinic or at the implementation level, what are we facing actually? I mean, I can just broadly divide the challenges into intrinsic, that is individual, the health system driven, and of course, societal, cultural. And this, of course, I mean, all these matters and all of these have implications as to where the cessation failures are, where the challenges are, and the integration of all this, okay, and the consideration of all these aspects when we are even talking about the highest grades of digital technology which we want to evolve. For that matter, like, I mean, simple things of individual intrinsic factors, like, I mean, where does it arise from? How does it start? The psychological functional dependence of the the tobacco users in terms of tobacco boosts productivity, overall resistance to change, I mean, where they see, because they are not suffering, they don't see an urgent need for quitting. The time constraints in terms of, well, he's not diseased, like, I mean, how much time would we give in terms of, just trying to say that I want some kind of a support system and counseling, and I would need to reach out to the counselor, and during the, 9 to 5 hours or something like that. So, like, I mean, time constraints is the biggest thing. Belief, and therefore the belief that I can quit anytime, which delays the quitting attempt. Peer pressures, which reinforces the use overall, the stress workplace phenomenon, the social triggers which you could have. No immediate health consequences seen by the younger generation, of course, and that is how, I mean, they are the ones who have initiated, they are the ones who needs the cessation efforts, and they are the ones who are going to see this as, wherein the health consequences are not seen. So, no immediate action taken. Inadequate support system overall at work and family level in the process of overall cessation, quitting attempts. And even if you try to do it by the behavioral or the, pharmacotherapy mechanisms, we are not able to manage the withdrawal symptoms. And these are just the few, the prominent ones which we are, I'm trying to bring out when we are talking about the individualistic space. Health system factors wherein we all know, despite the attempts for penetration, permeation of tobacco cessation services, there is still lack of awareness of the cessation services, the access to facilities. Even if you talk about, the dental colleges, the medical colleges, the district level facilities, but how far they are. A district comprises of 15 to 20, 25 lakh population. And do you think a tobacco cessation center clinic, placed at a district hospital is going to suffice? So, we all understand the ground realities, and it's too inadequate. Lack of integration again of TCC setups in the overall healthcare system. We need to integrate, we do understand we need to integrate it at all levels of care. So suboptimal participation also of the healthcare workers in prioritizing tobacco cessation, even if they are trained to doing those kind of a thing. Lack of training skills, and these are evident at all levels again, despite the training efforts. Regular follow-up of the treated tobacco users is also, follow-up is a bigger thing, as we understand that behavioral cessation or behavioral therapy, tobacco cessation is not one time. It needs several attempts, okay, by the, the person himself seeking these services and the counselors approaching it. And the last part, which I'm not going to take it at all, because this is a huge, area of investigation itself, the nicotine replacement therapy, and it's a different space. We are not going to take it up here. And then the community and cultural factors, as we all understand, again, lack of awareness and education, cultural acceptance, as we know, we are a diverse country. Tobacco use and forms are as diverse, okay, within the country as the number of states, and within the states also there is diversity across. The single the number of districts, okay, that we have, okay, that much cultural diversity we would have in terms of the usage of tobacco, the product by way of which it is known, and the cultural integration of the tobacco use, okay, within this, I mean, by the people. So again, the misinformation, the misconceptions adds to the whole thing, and social norms and easy access to tobacco products despite whatever legislation, I mean, and the enforcements that we have at the ground level. So these are kind of, I'm just highlighting some of the challenges that we face on a regular basis in a typical tobacco cessation clinic. And then typically the emerging tobacco products, I mean, we have to we'll have to face these in a very specific way, because these are specific challenges which we have to deal with. I mean, we have to understand and deal with the situation as and when they are presented at the tobacco cessation clinic. Special groups are special groups, okay, and these are high-risk groups. I'm just going to, the time is too short to dwell on the kind of special groups we are otherwise dealing at the tobacco cessation clinics. But I will take just one group herein. Look at workplace tobacco cessation programs, okay. These are the places at times we feel that, I mean, it's a catchment population. You can go to them, you can train, I mean, you can sensitize the managerial level, you can sensitize the workforce, and I mean, they are the catchment population wherein you can go back again, and probably the success rates could be higher. Yes, the success rates are higher, no doubt, okay, but they have their own challenges in terms of the management accepting and wanting to undertake this kind of an initiative, the perceptions of the workers or the employees in terms of the fear and challenges they face, and the reassurance and approaches that we have to have. And then I mean, subsequently, like, I mean, in terms of the outcome, cessation, yes, but like, I mean, there were fears of disease, I mean, the consequences of the health, health consequences being told, and then the workplace management have to take action on the health consequences. I mean, they may be because of tobacco, they may not be because of tobacco, but so many other things, okay? So this was just one situation which I wanted to bring out in terms of special population. So addressing challenges we need to address in terms of all the morbidity and mortality that we are going to face in terms of tobacco epidemic as such. So the Empower policies are there, and the O that we are referring to help quit tobacco definitely has to be, occupy much larger space, and much permeation and dissemination has to happen for these. Now, practicalities of what we are talking about, digital technology, and what currently the situation is. This is, I mean, just the situation wherein we as a dedicated cancer center, the initiatives, or like, I mean, people, I mean, the departments or institutions focusing on tobacco cessation initiatives and taking it as far as taking it to the rural, to the high-risk population, but how far we can go. How far we can go in terms of the penetration. So these are just the glimpses, okay? You need to permeate into the rural areas where this demand, I mean, when the incidence, the prevalence of smokeless tobacco is much more in terms of its varied forms. The percentage where we are working today in the tribal belts and rural population of Maharashtra is more than 55 to 60%. I mean, this is at times not captured within some of the GATS data, in some of the surveillance data, etc. But it's much more. The permeation has to be there of tobacco cessation services, no doubt. But how far can we go in terms of the manpower? Okay, and reaching out to this particular population. So there are limitations. What I'm trying to say is, if we are reaching out, doesn't mean that, I mean, as a program, we are able to reach out, and definitely we need solutions and how we can reach out to them in terms of what best can be done using the digital technologies. So what I mean to say is, in a typical tobacco cessation initiatives, that whether it as a hospital level, whether it is a community-based approach that has been taken, quitting tobacco is a process. It's not a one-time event, and this is where how revisiting, whether the service is revisiting or the person or the patient himself revisiting, and I mean catching up on the counseling, the behavioral counseling that is required, and the whatever messaging, texting has to be done, the messages has to be delivered. Okay, how the digital solutions are going to reach out to this particular population needs to be seen. Counseling has to be an ongoing and adaptive process depending upon how we are going to feed into this particular data for digital technology. Relapse is a normal phenomenon, and it's going to be, I mean, it is manageable, no doubt, with the right support and ongoing motivational support, behavioral modification strategies, everything which is need to be, of course, customized to the cessation plan would increase the rates of success. So, concluding on the initiatives, ground level implementation, ground level realities, practicalities and rationale behind what we are trying to understand, the reach of tobacco cessation services to the population fundamentally lies with health system, I mean, as we know, which we need to integrate in terms of the measures, tobacco related measures, and integrate it at the standard of care. Easier to say but difficult to to deal with. So tobacco cessation, which has been integrated currently with several programs of tuberculosis, the non-communicable diseases program, the oral health program, but it still needs integration at several levels and permeation to reach out to the farthest population where it needs to be going. So we will see how our digital technologies with the practical implications of it's not just urban, rural, tribal, where the real need is, how we are going to reach out with the digital technologies. Thank you so much.
7? Okay. Yeah, thank you. I mean, that's a pretty challenge set for Professor Kitis. How are you going to manage all these challenges? In fact, his job is becoming more and more challenging, what I can see. So over to Dr. Mayank for now. You have, I think, the most challenging job, how to do a good synthesis of the two different perspectives, and you have 7 minutes. I think that's enough for you. Yeah.
Yes. Good afternoon, everyone, and thank you, Professor Arora. So I come here as an outlier because I am not exactly in tobacco control. I do work a little bit with digital technology. The last I read about tobacco control was probably during PSM classes in MBBS. So, but that gives me an advantage as well, because now I'm able to look at all this work with a complete clean slate, or at least reasonably complete clean slate, right? And I'm able to look at it from the perspective of a layman who's getting exposed to tobacco use every day, either themselves, through passive, or just through looking at what's happening. And it was really, really informative for me. I've made profuse notes here. Probably everybody saw that. And this really helped me because I was able to look at it from the perspective of digital health. I mean, needless to say, Professor Arora and then Professor Mohanty summarized really well what is the burden that we face today of tobacco use. 30%, around 30% is what you said. And that's pretty, concerning, right? And we need to do something about it. Clearly, prevention is one way, but cessation is equally important. And we face a number of challenges. That's what I could understand. There is lack of personalization. Professor Pimple went into that, that there is difficulty in scaling up. We do not have the required infrastructure, or we do not have the required trained infrastructure. There's so many challenges, right, that we face. And when I see this, it's perfect from a digital health perspective. Because if we look at what digital health aims to do, is to provide scalable solutions which are also very personalized, which almost seems counterintuitive, but that's what the purpose is. I mean, when I look at it, and we talk about the fluency of LLMs and conversations that Professor Jadhav talked about, it's almost like having a 3 a.m. friend, omnipresent all the time. That's what you need. Exactly, right? If I have a friend who tells me, don't go to this place, or you know what, this is not good for you, don't do this, maybe even scolds me at times, that's what's going to bring in a behavioral change. And that friend would know exactly what I would respond to. I may work with an empathetic approach. That may be better for me. What might work better for me may be something that's really strict and stern. And that heterogeneity is pretty much lost when we try to bring in like one size fits all approach. And that can be disrupted using the profiling that Dr. Jadhav talked about, and that would be great. So it becomes scalable. I mean, we won't disagree that almost everybody has a smartphone. Even people who don't have a smartphone today are gradually coming into this digital revolution. Internet penetration is huge in India. I mean, probably we are one of the better placed countries. Yes, digital literacy is a challenge, there is no doubt about it. But if we can address some of these challenges, clearly digital health for tobacco cessation becomes a very scalable and personalized approach. There's no denying that. Of course, it will come with its the need to have feedback, the need to monitor, the need to evaluate very well to keep our guardrails up. You talked about hallucination in LLMs. You've taken steps to correct that using RAG approaches, but at the end of the day, it will be very important to have all monitoring systems in place to make sure it's not causing harm or it's mitigating harm, right, in some way or the other. And finally, one of the advantages of digital health is its ability to bring in a very fragmented step-up approach. So you can have very small, simple solutions to start with. People will get some trust. I mean, you can bring in how effective it is, etc. There's going to be community involved. People are going to give their opinion, feedback. You're going to make it culturally, sort of contextually aware. I remember one of the projects we were trying to pick up with a sort of vulnerable population down south was exactly about substance use. They had smartphones, so there was digital penetration. And one of the ideas given by one of the community members was, why don't you integrate sort of awareness messages within folklore, which was the predominant sort of the occupation of most of the community, and plus young individuals were taught folklore from a very early age. So the point about youth that Professor Mohanty brought about, and then later Professor Pimble also brought about, youth need to be exposed and sensitized to the harms of tobacco, and digital solutions within something that's culturally very appropriate, integrated into something that's prevalent within the youth becomes important. That also brings me to integration with health systems, and I promise this will be the last point. So we've talked about ABDM, of course. We can also think about, I would not want to use the word agentic systems here, but something as simple as if you have a smartwatch, which is telling you when you're having some kind of a physiological sort of a need to go out and smoke, and then it combines to a LLM, etc. And the LLM that times gives you, or the app gives you a sort of a notification that, you know what, probably, I mean, it knows that probably you're getting that craving and let's do something about it. That's going to be a right action at the right time. I'm sure there are going to be challenges. We've already discussed that. There is ground reality that we need to consider. But definitely one thing is certain, if existing solutions are not as effective as we had hoped that they would be. Yeah, finishing off. So yeah, I'm just finishing off. So if existing solutions are not going to be as effective as we hoped that they would be, disruption through digital technology would help, and all the best. Thank you.
Thank you for that positive note and very well-crafted synthesis. Thanks, Dr. Mayank. Any questions from the audience? Oh, great. Okay. Okay. Yeah. So, yeah. So, can you pass the mic? Quick question, please come to the question quickly rather than setting the context and all. Yeah.
Thank you so much all the panelists for such an Hello, I'm Dr. Kanishka and I've worked in two sectors with the Government of India, public health, and I'm presently working with Indian Railways. So, coming to the question, I wanted to understand that what different agencies are doing. What I feel that the propaganda when we say that tobacco or addiction is prohibited goes against when we come to people reaching out to the clinics for the follow-ups. So I feel, what are we doing to bridge this gap? Because once we are propagating that this is being prohibited, that creates a stereotype. But when we create a clinic and when we access first people, okay, they come there when we attend when we arrange camps or something, but because in addiction following up it is very important. So what are we doing to bridge that or to make it normal among the society so that they can themselves reach out to the clinics? Thank you.
We can take maybe 3-4 questions and then all of us can answer, I think.
Hi, I'm from Vital Strategies, and my question is, how much learning and how much change will the LLMs do within your work, and how will it be documented in terms of how do you actually make it efficient and which model is doing the best? And I'm asking in two things. User personas. We learn a lot in social media marketing because we have strategic media campaigns on social media that your conversion regarding your call to action will be depending on your segmentation. And there's a lot to learn from lookalike groups. So that's one. How would the input from the user change the personas as it evolves? You learn more from them. Another thing is, how will, so you're using the theory of change model, and that's going to shape your intervention. I was wondering, will you be able to test it using at different behavioral change models, wherein influence from others, social norms, agency, other things outside intention can be tested? Because one of the limitations of the theory of change model is you don't know how much time a person spends in each model, but it's brilliant because they regress, right? So they go back and forth. But we cannot systematically analyze how long will it take a person to stay in one model. So my two questions are, how will your LLM adapt in terms of personas? Does it improve? Second is, can you test this in using other behavioral change models? Thank you.
Me? Yeah. Thank you so much. I'm Dr. Dhananjay Kakre. I work for an institution called Sathi. We are based in Pune. And thanks for the brilliant presentation. My question is, how do you embed privacy and ethical considerations in your entire model?
Good morning, ma'am. My name is Dr. P.S. Sagar. I'm an expert in acupuncture and traditional medicine. So the whole world is now talking about integration and sustainable solutions. So I would like to bring to your notice, there is a protocol developed in Lincoln Hospital. It's called NADA protocol, which is published, and even Harvard has done a documentary on that. So it's a very, very simple protocol which will shift the dopamine to the positive aspects of life. So it is helping all kinds of addictions, not only smoking, alcohol, even the behavior addictions. So it's a very, very interesting protocol. So just by stimulation of certain acupuncture points, you are able to shift the dopamine to the positive aspects of life and controlling. So my second thing, only few people come to us. I'm an expert in that addiction part. So only certain people will come to us, but 80% patients are not non-willing. They won't even come to us. And see, there are other aspects like phytochemicals, like herbal medicines, which can do the same part. So we are counseling the patient family members how to behave with them, how to take care of them, how to manage the withdrawal symptoms, and even how to induce certain herbal medicines through their food, through their aspects, so that even that is also working the same. It is shifting their dopamine. Gradually they are leaving. So there is a sustainable solution. in terms of acupuncture and traditional medicine. So I would like to bring to your notice so that this will definitely help in the society.
Thank you. Can we, the girl has been raising her hand for quite a long time, so can we go to her, the girl in the blue? Yeah, yeah.
Okay, so hi panelists. So you majorly you have talked about the behavioral model drivers in the form of tobacco cessation, and why is it like challenge in it. So I have a question based on that. That in the age where social media algorithms often amplify the influencer-driven tobacco lifestyle content, right? So how can we design conversational AI tools for cessation that not only support the users but actively counteract the cultural normalization of usage of tobacco?
Maybe we can start with the last, yeah, the social media influencer. Anyone who wants to take up that? Yeah.
So, thank you. I'll just try to answer all the questions simultaneously. First, I'll like to say that we'll try to walk before we run, right? So, we'll try to do one thing at a time, right? Because most of the time when you try to solve several problems simultaneously, you'll end up not solving anything. So the first question is, how do we do this lookalike analysis, right? And the large language model process that I talked about, it's only to collect data in a very non-intrusive way. But the clustering algorithms, unsupervised clustering algorithms, is something that we are looking at. We have developed it for other solutions. So I'm fairly confident that we'll be able to do this in an unsupervised way so that we can identify these homogeneous subgroups in this heterogeneous set of individuals, right? How all of these clustering algorithms will require features. The point that I was trying to make is that these features could be extracted through these conversations instead of these banal questionnaires, which has very low engagement. So that is the first thing that we are trying to do. The second question is the theory of change question that you asked about. And this is the baseline approach right now. What we really want to do is, once we identify them, since there is always set understanding about if a person is in a particular change state, we should be able to give specific advisory to that person. Whether that has worked or not is a feedback mechanism, which is not part of the large language model process, but the entire system that we are going to develop. So for example, like while my lab is going to develop the large language model in close collaboration with the team, we have an entire software team, which is also on board, who is going to develop this mechanism of monitoring to see that where that person is. So, and can we, when the person re-logs in, is the person at the same stage or the person has regressed to a different stage? So that is more of a systems problem than a large language model problem, right? Sir, to answer your question, the security and the privacy, twofold. One is you can actually add guardrails to the language models themselves so that you take care of the security privacy, but it's again a systems issue. For example, when you develop software stacks and software solutions, these are inherently normally included. So we can define those security concerns so that the privacy concerns that you pointed about will not be, will be at least tackled at that. Please correct me if that was the question that you were asking. And right, so it's again a very systems problem and not a large language model problem is what I'm. Yeah, we can talk about it. Yeah. So they say, right, if you don't clear somebody's doubts, you confuse them. That's the. And one final thing, if I could just answer your question, the social media influence thing, I truly don't know, right? And maybe Dr. Sharmila, you have thoughts on that, and maybe you could talk about it.
No, well, I was just wanting to add to the behavioral change model. Well, the study, the way it has been planned, includes qualitative as well as quantitative tools which are going to add to this behavioral language model. So this is how it is going to inform the model as to how we are going to integrate. Of course, like, I mean, this is a development phase, and whatever qualitative and quantitative data, I mean, which is going to be a very exhaustive interview process, considering the sample size, okay, we are going to pilot this particular things. And maybe, like, I mean, further when we are disseminating this tool now, and actually using this particular tool is going to inform us more in terms of the various behavioral patterns, whether we have missed out on that and whether we need to include more, the tool when it is actually being used, the developed tool, the first version of whatever protocol we call it, okay, again, which is going to be implemented, is going to inform us again to inform the model, inform the tool in terms of how we are incorporating the various behavioral patterns and capturing them well. If it is not sufficient, probably, we go into the second phase of, for protocol 2 or protocol 3, and that is how it is going to be developed. That's what the procedural formality.
Would you like to address some part? I do the social media if nobody takes it, but Vikrant, maybe you can do.
Yeah, I think the question on the behavior change is a very important aspect because the patterns that we see, obviously once we start interacting with patients, we start profiling them first of all in terms of how easy, what stage, and how we can utilize this particular patient with this kind of criteria into the next stage and then push him, and there is chances of coming back and forth. That's why it's not a linear model anymore in terms of theory of change. It is more like a spiral model. So that's how it happens. It spirals out and spirals in back. So we should also look at, I think, and this is a suggestion both from answer to you, at the same time a suggestion to the team which is working, that there are other models also play. Like we have a health belief model. So we have other models in place which are more of behavior models which take into consideration different other factors. So we need to understand that once the first model is developed, the feedback from that, and what are the shortcomings in that, and then we need to work on how solutions could be. So this is my take on in terms of the behavior change. The other question which I think talked about integrated medicine, I think yes, though that is beyond the scope of this particular domain, but yes, in times to come, different aspects of, and obviously evidence-based strategies in terms of use of integrated medicine surely will be we look forward to having that on board, because people from different walks of life need different types of solutions, and sometimes they follow a kind of like how we have multiple solutions and they all address the same problem. We need to have such kind of menu of options that we give in our cessation strategy which we have. So I think that also should be a good way forward, and I think most importantly is what digital technology is going to bring in terms of, as a healthcare provider, I would look at how much of my time is an intervention like this going to save, and how it is going to improve my follow-up rate, which one of the audience had asked. That follow-ups are something which are a big issue in terms of whether it is physical, whether it is distant follow-up, but whatever follow-up is something which we are very concerned about, and all the challenges that we discussed, we need to try to address and see how the system can, the technology can break even and bring these things on board. Thank you so much.
Just answering the social media question. So yeah. So yeah. So social.
We can continue talking outside. Yeah, please, ma'am.
Social media, I'll be really short here. So social media can have, so it can be used in a bad way, it can be used in a good way, right? Now you talked about normalization of something like smoking, right? At the same time, there are also instances where smoking has been shown, within the movies, etc. You will see the ill effects have been shown, but they have been negated because you remember only the parts where you want to remember, right? Now, if you bring in the personalization component of it, and you see how many times is a person likely to go and seek a fix after watching something which had incorporated messages, and then now tailoring your intervention around this. Second aspect of it, like I talked about, integrating a positive health awareness message with the same impact as a negative message within the social media. I think those are the two easiest low-hanging fruits I can think of. But of course, there'll be more innovative approaches that we've not thought of. So yeah, that's about it. I'll also just one quickly about the accessibility portion that you talked about. It offers a non-judgmental zone, which is very, very important when we talk about seeking healthcare. A lot of people, seeking TCC care, right? Because a lot of people don't want to go to centers from the fear of being stigmatized. So non-judgmental zones are important. Yeah, thanks.
Thank you. Thank you for being such a wonderful audience. So I think being round of applause to each one of us, and I can see many questions still there, and we are going out for the tea, and let's the tea can be more steaming. Yeah.
Hello. Hello, check one, mic test. Hello. Hello, check one. Hello. Hello, check one.
ये तो उसको बंद कर दो आप. Namaste, namaste. I think we need to stand out and tell everybody to come here. बंद कर दीजिए.
Ultra beats on the track.
Does everybody think? Should we start? People will keep coming in later. So, good afternoon, friends, delegates, and welcome to this session. I hope you all had a good lunch. And I know, post-lunch sessions are not the easiest, but we'll try and keep it interesting so that, you can keep some of the doors away. I think, this is, if you're ready to dive in with us and deliberate on this vital topic. And at the outset, I would like to thank the organizers, especially the Cochrane India Network, for giving us this platform to discuss women's health and well-being. I'm Dr. Namita Chindyok, and I'm honored to moderate this very crucial conversation, especially at a time when health systems across the world, including in India, are increasingly recognizing the need to adopt a more inclusive and gender-responsive approach to women's health care. So today, I want you all to reimagine the way we view women's health, not as a series of reproductive milestones, in terms of the maternal mortality rate, the fertility rate, the pregnancy outcomes, but as a continuum of care that spans an entire lifetime. Women's health has traditionally been viewed through the lens of motherhood, and significant resources and policies have focused on maternal health. As you all know, starting from JSY onwards to Suman, we have had so many programs and policies which is focused on maternal health, and justifiably so. We had a high maternal mortality, and I feel very proud to say that, we have done remarkably well and are on track to achieve the SDG goals. But here's the reality, that when we focus only on reproductive health, we ignore the many dimensions that shape a woman's well-being and fail to address the full spectrum of the health challenges that women face throughout their lives. Today we know that more women work, more women are financially, or I would say economically independent, and more women die of non-obstetric causes at any point of history. Women in India face high rates of cardiovascular disease, diabetes, depression, even osteoporosis, which is often undiagnosed and untreated. They also face structural barriers, limited decision-making power, economic dependence, systemic gender biases, all of which impact their ability to access care. So when we talk of a holistic approach to women's health and well-being, what does it look like? It means recognizing the interconnectedness between physical health, medical health, mental health, gender equality, emotional, social, and even economic. It should be lifespan-oriented, culturally contextual, and it also means providing services with dignity and choice. It means recognizing that an adolescent girl with PCOS and anxiety, when we deal with an adolescent girl who is dealing with PCOS and anxiety, or a 35-year-old who is navigating IPV and endometriosis, or a 50-year-old woman who is facing or undergoing menopausal changes, or a 65-year-old woman who is managing hypertension and loneliness, they all need and they deserve care. So I think there is a need for a paradigm shift, and women's health must be expanded to cover both sex-specific conditions, for example, endometriosis, menopause, or women-specific cancers, and general health conditions that may affect women differently. That is, they have a higher disease burden per case, for example, colon cancer, or disproportionately,
where they have a higher prevalence as compared to men, which could be depression or autoimmune diseases. And, you know, we have several examples where we do know that women, you know, they present differently with their health problems, they respond differently to management, they have problems in access, and even when it is reported in literature, you know, we see that, you know, women, it is not disaggregated by sex or gender. For example, heart attacks are a leading killer of both women and men, but women don't experience the typical symptoms which men do. And so we need greater awareness of these differences. Women also outlive men more than 5 years, and you know, you all must be aware of that. Everybody says, you know, you must have experienced it also in your friends and families, that women outlive men. But their healthy life advantage is less than 9 months, and they spend a significant portion of their lives in ill health. Women in general are more prone to anxiety, depression, phobias, suicidal thoughts and attempts. They utilize only 45% of services under government insurance schemes, and in some disciplines like cardiology, it can be even less, you know, 10 to 15%. So really their utilization of the programs, of the services is also not there. Even where cancer is concerned, we see a greater number of females affected than males, and we know that the burden of cancer is going to nearly double by 2030. Breast cancer is a leading cause of cancer deaths in women. Also, nearly 30,000 women annually die from cervical cancer, and a couple of days back, there was this big article in the Times of India which was headlined that 1 woman every 8 minutes in India dies of cervical cancer. So these are a lot of, you know, the problems which we face, and we have a very, very eminent speakers who are going to be talking about this, who are going to be discussing this, and who are going to be taking you through this journey of women's health, which is beyond motherhood. And I would like to invite them. To the dais. Sorry, that's the... So I invite Dr. Jaideep Tank to chair this session, and Dr. Tank is the immediate past president of FOGSI. He is the chair of the YGA Committee Asia Oceania Federation of Obs and Gynecology, past chair Safe Abortion Committee of FIGO. More than that, he is a celebrated physician, a clinician who has been very active all these years, and he has steered FOGSI and started very many newer initiatives in FOGSI, and we welcome you, Dr. Jaideep. I would like to invite Dr. Manohar Agnani, and he brings a very, very unique perspective to our panel. Dr. Agnani is a public health professional, former Additional Secretary, Ministry of Health and Family Welfare, with over 25 years of experience in public health policy and planning, health system strengthening, human resources for health, and RMNCH+N. So a very, very wide breadth of work. And yesterday he participated and chaired several sessions which I attended, and most of them were on safe motherhood, or I would say on maternal health. So it's going to be very interesting to hear from him about women's health, which is beyond motherhood, and also which really tells us about the breadth of work which he does. He is also the professor of public health at Azim Premji University, Bhopal. He has had awarded with many achievements, and most of all, he was the nodal officer of the COVID immunization program, which you know in India how successful that was. He has served as chairperson of the National Commission for Allied and Healthcare Professions, and besides all of this, he is also a gender expert. So we welcome you, Dr. Agnani. Dr. Prabha Chandra is a specialist in the mental health of women and girls, and she's a clinician and academic researcher for the last 30 years. Dr. Prabha Chandra has done a lot of work on women and mental health, on reproductive health, intersection of reproductive health and mental health, and she has been featured as a champion of women's mental health by the Lancet Psychiatry and past president of the International Association of Women's Mental Health and a visiting professor at the University of Liverpool. She has 18 funded research projects, which is extremely impressive, and has led the ambitious Sri Mano Raksha project of the Government of India. So we welcome her. And Dr. Poonam Goyal is again a clinician, a gynecologist, and she heads the Department of IV and Infertility at the Max Super Speciality Hospital in Delhi, and holds key positions in several professional organizations, including chairperson of the Safe Motherhood Committee for the Federation of Obstetric and of FOGSI. And she is the governing council member of the ICOG and executive member of the Association of Obstetricians and Gynecologists of Delhi. So with this very eminent panel who brings in different expertise from different disciplines, you know, we are, the way we've planned it is that you know, we are going to dive into 4 key areas where a more holistic, inclusive approach will be required. And this is going to be menopause care, mental health, NCDs and preventive strategies. Sorry, where is Dr. Oh, I'm sorry, Dr. Sitoya. I was looking for you. I couldn't see you. You were kind of hidden over there. Yes. So Dr. Sitoya is a specialist in public health with over 20 years of experience in health research and health systems, especially in community health and global mental health. And before moving to India, he served as head of office at the WHO Tonga office for 6 years. So he has a wide experience of working in WHO in several places, in Fiji also. And prior to joining WHO in 2011, he was the section chief of the Department of Psychiatric Rehabilitation at the National Institute of Mental Health in Japan. And he is the team lead for non-communicable diseases at the WHO India office. So welcome, Dr. Sitoya. I'm sorry I somehow, you know, missed you over there. Perhaps you was, you know, covered by somebody over there. I think we just lost you on that. So as I said, we are now going to be, you know, talking about more about these 4 areas, particularly in the Indian context, which is going to be menopause care, mental health, non-communicable diseases and its preventive strategies, and then gender equity and a gender-responsive health system. And our panelists will set the context. They will tell us something about the challenges and how they could be addressed. And then subsequent to that, we will have a further you know, questions and answers and try and understand from them how we can move forward on it. So the overall life expectancy for women in India is estimated to be about 70 years. And women in India, you know, have menopause at the age of about 47, 48. So they spend a significant portion of their lives in the post-menopause. And menopause is also called the invisible decade because there is widespread lack of awareness and understanding about its impact on women's lives. And Dr. Poonam Goyal is going to be our first speaker, and she will be talking about menopause and its the different problems women face in it.
Thank you, Dr. Namita, for setting the context. So life and health beyond motherhood, that is what we need to discuss today. A very common scenario: a 52 years old teacher in Delhi has not slept well in months, keeps forgetting words in class, feels bad, but she has to use the restroom very frequently, loses patience with her students, misses what fellow colleagues are conveying, and thinks it is just age catching up. She does not know it's menopause, and she is not alone. Over 1 billion women globally are on this path, and they are largely unsupported. So what is common in all these women? All of them are on the gateway of their next chapter, that is midlife. Menopause is not a medical pause. It is powerful transition that demands clinical attention, cultural recognition, and policy innovations as well. So why we should talk about menopause now? Now in 2025, more than 1 billion, and by 2030, over 1.2 billion women globally will be experiencing menopause. So the rising life expectancy, as Dr. Namita said, that now she passes almost 30 years of her life in this phase. Persistent clinical neglect is there, and there is cultural silence on the subject. From infertility to longevity, it is a public health responsibility actually which is being ignored. Indian Menopause Society in 2024 said that 31% of Indian women reach menopause before the age of 45. The regional disparities in menopause onset reflects both biology and healthcare inequities. Earlier onset in low and medium income countries, that is by 2 to 5 years, is there due to malnutrition and infections, and premature menopause globally is 3 to 5%. So clinical implications like immediate symptoms are vasomotor symptoms, hot flashes, night sweats, then sleep, mood disturbances, vaginal atrophy, and long-term risks are, that is, cardiovascular, osteoporosis, and cognitive changes. So women's relationship with menopause is actually very complicated. Sex can be off the menu in 51% of them. 42% say that they just not feel sexy or normal as they were, and partners are left feeling helpless. And 28% of the partners said that it is because of all this they are always fighting with each other. So Lancet Women's Health Series in 2023 called for menopause to be integrated into universal health coverage frameworks. The leading cause of diseases like cardiovascular, cancer, mental health disorders are both in men and women, but they have different underlying sex-specific risk factors. Like a woman's lifetime CV risk can be increased by early menopause, preterm delivery, gestational hypertension, and then there are psychological and socioeconomic risk factors, but the details are poorly understood. In mental health, anxiety and depression are increasing, and recognizing the need of different genders is important for the prevention. The menopause-related disease burden is underestimated, that is, DALYs we say, that is disability adjusted life years, means number of years lost due to ill health, disability and death. When you look at the global health data, the true burden of menopause is hidden. That's because the conditions like fractures, heart disease, depression after menopause are recorded separately without linking them to the menopause itself. As a result, the menopause remains under-recognized in health priorities and the funding decisions eventually. When menopause remains invisible in data, it will stay invisible in care also. So now how the research has progressed. In 2002, the WH1 trial started, which went for 20 years, then Replenish trial in 2023, gut microbiome trial, that was in 2024, and now in 2025, AI-based digital therapies have been approved by US FDA. So Replenish trial, the new combined bioidentical hormone therapies which improve the vasomotor symptoms, and they have a better safety profile. Now the WH1 trial, that is 20 years update is there, that is the HRTs are safe, but we should not miss the opportunity, that is under 60 years or within 10 years of the menopause, it should be used. Then gut microbiome, menopause axis, that is from the Lancet Endocrinology 2024, microbiota alteration contributes to CVD, osteoporosis and mood changes. Then these digital therapies like MenoGuide, which has come up in US now, giving the non-hormonal options. The cultural and the social dimensions. Are we empowering women through this transition, or we are letting them disappear from the healthcare priorities and our social narratives? Persisting stigma in 52% of the women, they do not seek help for symptoms. That is the Global Menopause Survey, which was done in 2024. Varied cultural perceptions are there. Like in Japan, it is a very positive perception. And there is too much medicalization of the thing in West. And it is a taboo subject in countries like ours. So in India, menopause is often viewed as a destiny of silence. The silence costs health, dignity, and productivity. Women do not stop living after menopause, neither should their health care. Every face tells a story. Let us together ensure no woman's health story is left unheard. Thank you.
Thank you, Dr. Poonam, especially for highlighting the lack of data on menopause. I mean, we know women experience symptoms at some point during the menopause transition, but this is rarely counted or considered within classification of health and disease. And if you see the global burden of disease data set, it currently captures the health burden associated with menopause under other gynecological diseases. So as a result, we really don't know what the prevalence of these problems is, or the symptom severity, or the disability weight associated with menopause. And also some of these symptoms, as you said, which are experienced during menopause, such as mood swings or depression, they are often associated with other conditions leading to misdiagnosis. So they are, put under other conditions and not under menopause. So and as long as if we don't know what the prevalence of the disease is, then the focus for that becomes less. We'll move to mental health, which is the unseen epidemic, again, which is a very significant yet unrecognized public health concern. And we know that women face many social, cultural, and systemic challenges that contribute to it. And Dr. Prabha Chandra, I think, will tell us more about it.
So I'm going to talk a little bit about the mental health issues, and the sort of my scope is both global and local. One of the important things we must remember as people who are interested in public health and planning services is that women experience a greater share of chronic morbidity-driven conditions, while in men, the disease burden is driven by mortality or fatal conditions. And this is like a clear boundary which is there, which if you look at the data, women have more conditions like low backache, depressive disorders, headache, anxiety disorders, other musculoskeletal disorders, and we are more and more seeing women who come with dementia and Alzheimer's disease. So their conditions are more chronic, so whatever we plan in terms of services has to take into account that. The sex difference in global burden of major depressive disorder, and this is the Global Burden of Disease Study 2019, and if you look at the disability adjusted life years, you will see that there is a distinct increase in depressive disorders from the time of adolescence. So at the age of 12, there is a split with the red line showing the rates of depression in women and the green line showing the rates of depression in men. So clearly there's a huge divide, with women having much more higher rates of depression, and this is what we see clinically as well. Again, if you look at the global tallies by mental disorders, sex and age, you will see again all the red lines on your right, that's the females. Depression and anxiety are much outnumber the rates in men throughout life. So it's not like only in one phase of life, throughout life. So people have wondered what could be the reasons for this. So why is it that women have such distinctly higher rates of anxiety and depression? Clearly the answer is in social determinants, and that is something that I think as health professionals we should really consider. But as I think Dr. Nomita also mentioned, syndemics are something that we don't look at. So partner violence and mental health disorders are syndemic. Gynecological problems and anxiety or depression are syndemic. So these are conditions that occur together. Comorbidity is a norm rather than an exception. And I think that's something that most health services, even in the best developed part of the world, have not paid enough attention to. Suicide is something that I want to highlight. So if you look at suicide rates across the world, there's something called the gender paradox. The gender paradox basically is that men have more completed suicide compared to women, whereas women have more suicide attempts compared to men. That's a gender paradox that occurs throughout the world. But if you look at this data on suicide rates by gender and age in different LAMIC countries, you will see that it's very, very different throughout the world, which clearly indicates that there are social issues which seem to be contributing. So if you look at, for example, the WHO European region, this is a very traditional knowledge about suicide, that men have much higher rates. So the red line is women and the blue line is men. So men have much higher rates. Let's look at the Western Pacific region. Rates are equal in men and women. Let's look at Southeast Asia and South Asia, particularly South Asia, particularly India, Pakistan, Bangladesh, Afghanistan. You will see that there is a point where the rates in women are much higher than in men. And this is particularly true in the young women in the reproductive age group. So, you can't generalize services. They have to be very local and focused. And this is something that has been of great concern to mental health professionals, public mental health professionals, about the high rates of suicide. In some states in India, the rate is completely reversed. You're getting 4 times the rates of suicide in women compared to men, clearly driven by social determinants. So I think this is something that, I thought I would highlight. A recent meta-analysis, one of the biggest social determinants is the experience of intimate partner violence. And it's come through flagging all through your life that this is the biggest risk factor for mental health problems. If you look at the global prevalence and mental health outcomes of IPV, a recent systematic review which reviewed 201 studies, 250, 599 women, 46 countries. If you look at the forest plot, you will see that it's clear that the relationship between intimate partner violence and mental health problems, poor mental health outcomes sort of, stares you in your face. And so programs like, was mentioned, the Stri Mano Raksha project, which is a project initiated by the government of India, which looks at training all one-stop centers in the country, which are about 750 one-stop centers for intimate partner violence, training the counselors in handling mental health issues among women who come to them for help. I mean, these are the kind of programs which actually have, will make a lot of difference. So I just want to end with a few points so that we can take the rest in discussion. We did a study where we looked at this, the current status of gender-sensitive mental health services from a sort of global view. We contacted experts in women's mental health and said, what do you think? How satisfied are you? What is the priority? How good are these services? And the domains that we looked at were first, and this is very important, creating an atmosphere of safety and respect. I think a lot of women will talk about not being respected by the health system. I mean, this is a big block why a lot of women don't go to take care, because they feel that when they talk about their problems, they are not heard. Gender-friendly structural arrangements, like shorter waiting times if you have small children, for special services for older women, meaningful access to care for self and children. Just as an example, a woman comes to seek help for a mental health problem to me as a psychiatrist. She brings a little child who's 3 or 5 years old, and there is no way that she can keep that child outside. She has to sit with me, with the child, cry and tell her about her problems, and the child is watching it. So, these are small things that can actually make a lot of difference, but unfortunately we don't really pay attention to it. So how many health systems or hospitals have a child care facility available where when a woman is getting a consultation, the child can be looked after? Small thing, but not happening. Involving women in planning of services, and this is why we need co-design, because women know what they really want. And if we do like top-down approaches to planning services, then we really are not listening to women's voices. The importance of women-specific information. Now, we really heard this wonderful talk on menopause. I mean, how many women who come to health services really know these are the kind of problems? So we don't have enough women-specific. There is something out there, but much, much more in all formats should be available to women. Gender-specific training of health professionals, even in the MBBS course or in the MD course, the training is not necessarily gender-specific. There is sort of just a tokenism which kind of talks about gender-specific training. We don't really have a module on women's mental health or women's health separately. And that is something I think one needs to focus on. And finally, a favorite of mine is gender data analysis. So when you look at hospital data, when you look at outcomes, we don't really look at gender segregated data. And now editors of medical journals are really, have been told, which is called the SAGE guidelines, that is sex and gender adjusted data. So every editor is supposed to actually ask whether we have enough data for each gender, and for some reason if it's not been included, then they have to mention why they have not been included, including in animal studies. And this is part of gender sensitive mental health care. And surprise, surprise, what we found was when we asked the experts, everybody across the world, high income, low income, said we are completely dissatisfied with the kind of gender sensitive women's mental health care that is provided around the world. So it's not a LAMIC problem alone, it's the problem across the world. So to sort of emphasize this, I think if we want to go forward, we need to train professionals in the interface of what we said, physical health, mental health, and reproductive health. And the moderator really brought that out. Like, you have endometriosis and IPV, you have PCOS and anxiety. Siloed care will not work. We in Bangalore have a clinic in a public health facility where we have the gynecologist, the obstetrician, and the psychiatrist and psychologist sitting together so that the woman actually gets that kind of holistic care. And that should become like the norm rather than an exception. The services should be non-stigmatizing and accessible, and like I mentioned, services for girls and women for violence and abuse should incorporate mental health, supporting women in parenting, recognizing the burden of caregiving for women at all ages and develop policies for support. Women are the majority caregivers. And caregiving is a very, very burdensome and emotionally draining issue. Very few countries actually provide any kind of support to women who do caregiving. There's no financial support, there's no other kind of support. That contributes to loneliness, which was discussed. Counter ageism, we just discussed it, using co-design, and invest on gender equity programs for young parents and adolescents, because we really need to start early. The sort of change that we see between men and women, boys and girls at adolescence and mental health problems, one of the major reasons is poor gender equity. So I think it's time to design a South Asian manifesto for women's health. We've been talking to the ministry about it, that it's high time we really do something. The European Manifesto on Women's Mental Health is a great document, and this is the QR code for that. It kind of outlines women's mental health in all its sort of the whole spectrum, and I think we should really take lessons from that. Thank you very much.
Thank you, Dr. Prabha. That was very informative, and especially when you spoke about safe spaces for women, they become so important, especially when women go to access care. And also training of healthcare providers on gender sensitivity. Somehow that has never been part of the curriculum, and we really need to kind of recognize more of these gender inequities and train our health providers on it. We move to the next talk, which is going to be by Dr. Satoya. We know India is witnessing a significant epidemiological transition, with NCDs now accounting for a substantial proportion of the disease burden. And women are experiencing an increasing prevalence of these NCDs, which necessitate focused attention on their health needs. And Dr. Satoya is going to tell us more about it.
Thank you, Dr. Nomita. Good afternoon. a bit overwhelmed and nervous to talk about women in front of so many women. Probably we need more men actually interested in this area to come to this session, and yes, like me, and so it's great that there are several people, men, coming to this session. Unfortunately, some of them is only here because they're my staff, but nonetheless. But thank you very much for the opportunity and involving WHO, and thank you, Cochrane, for organizing this session. So I was tasked to talk about proactive wellness for women, preventive health strategies. When I say wellness, my background is mental health. Obviously, for me, mental health and physical health comes together, but of course, Dr. Chandra has already made a good excellent presentation about mental health, so my presentation will focus only on the NCD area. So this is the global overview. As Dr. Nomita mentioned, India and the world is doing remarkably well in the maternal child health, also in communicable disease vaccinations. So people are living longer, and already 74% of people die from non-communicable disease. So 3 in every 4 deaths among women is from non-communicable disease. Cardiovascular disease leads the cause with 9.2 million deaths among women annually. But also almost 1 million women dies from breast cancer and cervical cancer, which is most preventable type of cancers. So this is the data from the Global Burden of Disease data. So it's the left is 1990 and right is 2021. So as you can see, more and more people are dying from NCD. So people are living longer, and yeah, so the rate and number of people dying from NCD is increasing. So the blue is from the non-communicable disease, and red is from the communicable disease. Green is from the injuries, etc. So as I said, cardiovascular disease leading cause, almost 30% of all deaths is from cardiovascular diseases, followed by cancer, chronic respiratory diseases, neurological disorders, diabetes, kidney disease, etc. So it's obvious that we need to go beyond motherhood, we need to go beyond maternal child health. So we need to work on NCDs, especially on prevention. So there's many risk factors we can categorize in several ways, but this is one way of categorizing. So traditionally, WHO focused on 4 behavior risk factors: tobacco use, physical inactivity, unhealthy diet, and harmful use of alcohol. But also there is metabolic risk factors, which increase the risk of non-communicable disease. One is overweight and obesity, also raised blood pressure, blood sugar, and high levels of fat will increase the risk of NCDs and also for complications. I've been living in Delhi for 2 years, and air pollution is a big issue here. I am from Japan. Japan also had a lot of issue with air pollution. We try to do a lot of regulation, and we have now when I go back to Tokyo, actually I can see a blue sky, which was, I think when I was a child it was much worse, but I hope sometimes, some good days India has a blue sky, but hope it happens more often in here, because it's 5.7 million it's estimated that die from air pollution due to NCDs. So this is data from India for the some of the risk factors. For tobacco and alcohol, India is doing relatively better compared to other countries. And also for women, it's less, both for tobacco and for alcohol. And I think India is doing very well in terms of tobacco control. Of course, there's room for improvement. But coming to unhealthy diet and physical activities, you can see that it's not going well. More and more people, it could be children, it could be adults, but this is from 2005 in gray, 2015-16 in light blue, and 2019-21 in dark blue. But you can see that the rate is increasing. This is the percentage of overweight and obese in India. So for women, in 2005 it was 12%, but in 2020 it became double, 24%, and it's increasing. So we need to do more on reducing unhealthy food. So to tackle the NCD crisis across the world, I used to work in the Pacific, which the situation was much worse. But India still has, a little bit of time to tackle this before it becomes a really a crisis. In Tonga, it was one of the most obese country in the world, which I worked for 6 years. The obesity rate was 60% and 90% were overweight. So people, men and women, both are dying a lot with NCDs. But I think there's room for India to work now to prevent future death. And for that, WHO has so many documents, reports, guidelines, etc. Sometimes there's too many, but this one is one of the key document. It's called Tackling NCDs, specifies another recommended intervention for the prevention and control of NCDs. So this summarizes the possible intervention. We call it a best buy. As a public health specialist and as a public health organization, WHO recommends most impactful interventions. Of course, there's so many good interventions, but we need to make sure that it's cost effective and has the most impact. And specific interventions are listed in this document. It can be divided into roughly 3 areas. One is health tax and regulations, so increasing tax for unhealthy food, tobacco, alcohol, and reducing tax or giving subsidies for healthy diets like fruits and vegetables. Restricting advertisement and reduction, elimination, including, for example, for trans fat. Reducing the use, it can be the front labeling of the packages for the food. Second area is intervention at communities and at schools. We should raise awareness at the schools and at the community. We should improve the environment. We should promote screening and vaccination at the community. And the third area is at the healthcare settings. We should control hypertension and diabetes, stroke and heart attack treatment once it happens, COPD management, and early diagnosis and treatment for cancers. Then the specific intervention is listed in this document. For this area, we have a C-Hearts initiative, which aims to reduce cardiovascular disease, targeting major risk factors. Tobacco, we have WHO Empower package. For salt, we have Shake package, eliminating trans fat using Replace, and strengthening primary healthcare system for better cardiovascular disease management, including hypertension and diabetes, through WHO's HERTZ package. It aims to cut premature NCD death, which is in line with the SDG target. Also specific for women, we have a global strategy to accelerate elimination of cervical cancer as a public health problem. We have 90-70-90 target, 90% of girls fully vaccinated by 15 years old for HPV vaccines. 70% of women are screened, and 90% of women identified with cervical diseases receive treatment. Similarly, for Global Breast Cancer Initiative, we have a target to diagnose at least 60% at make early diagnosis, timely diagnosis within 60 days after the screening, and 80% of treatment completion for those that became diagnosed. And also another area is gestational diabetes, which is a temporary condition in pregnancy when the body does not make enough insulin during pregnancy. 1 in 7 women has an issue with gestational diabetes, which increases risk of complications during pregnancy and delivery, and increased risk of type 2 diabetes for mother and child after delivery. So prenatal screening is crucial for diagnosis, and once diagnosed, healthy eating, regular physical activities, monitoring the blood sugar, and medication or insulin will be needed, which can reduce the risk of complication. when implementing these global or regional guidelines, it's important to adapt to the social-cultural situation. And I think because there's a lot of barriers depending on the country, depending on the state, depending on districts, or where they live. There's a different cultural barriers. So it's important to think about these kind of barriers from the gender lens. In some areas, gender norms restrict mobility for receiving services. Some place only men has the cars or motorbikes. Sometimes only the men has the phones and smartphones. And the educational gaps in terms of low literacy rate or health literacy will worsen NCD management and health-seeking behaviors among the women. And especially for elderly women, women has higher vulnerability due to physical inactivity. And also women often prioritize family health over your own health, delaying the treatment. So these kind of cultural barriers should be thought when implementing good activities. I want to talk about one good example, one good initiative in India, which decreased the treatment gap for both men and women, but especially for women, which is a very successful hypertension control initiative, India Hypertension Control Initiative, IHCI, which started in 2018 by Ministry of Health and Family Welfare in collaboration with WHO and other partners. So it's a very simple tool based on the WHO Health package. Basically, we made a very simple protocol at state level, which the busy clinician at the primary healthcare level can use, and made sure that very small number of types of drugs, are available at the lowest health facilities, at the Amandios, Ashman Health Sub-Centers, Health and Wellness Centers level. And a task sharing model. So we are training CHOs, community health workers, ASHAs, to be able to continue to treat the people who are in need of the service. So ASHA is going house by house, screening both men and women, but more women is at home. So we are kind of strengthening the capacity of ASHAs to make sure that all the women has screened and receiving treatment through a patient-centered care. And all of this is captured through the information system by NCD portal. Now it's expanded into what we call a 75 by 25 roadmap launched by the Ministry of Health, aiming to put 75 million people on treatment by end of this year, which is more than a country in many, 75 million I checked, and it's equivalent to the population of Thailand, which is a big country in itself. So it's a very ambitious target, but we are actually on track. We can see that since 2018, more and more men, but especially for women, are receiving treatment for hypertension, and also we have a similar trend for diabetes. And it's increasing exponentially. This is the data from the states which are using the NCD portal. There are several big states which is not using NCD portal, but I think more than combining hypertension and diabetes, more than 50 million or almost 60 million people are already on treatment. And we are also emphasizing not only putting on treatment, making sure that they're followed up, and they're making sure that hypertension and diabetes are controlled, so that they will not have a future, heart attack or a stroke, or reduce the risk of complications. So this is my last slide. So we need to ensure health equity for women. We need to empower them, support them with correct information and evidence, and to motivate them making their proactive decisions. But also we need to make sure that the environment is there to make healthier choices, including taxes and regulations. We should strengthen accessible health system for all. As you can see, if we make the system available at their community, more and more women can access the service. We should focus a little bit more on develop and implement service system for specific conditions, cervical cancer, breast cancer, gestational diabetes, etc. for women. Which you can decrease the treatment gap and cater for their specific needs. And most importantly, it's important to believe in healthier women in India and region and the world. Thank you very much.
Thank you, Dr. Stoyar.
Thank you very much. Informing us about the strategies and the initiatives taken by the WHO. And we know that, increased awareness of health hazards of obesity. I mean, your data was of 2019-21. I'm sure it's much more now. And we need to also support better nutrition for women. We will now move to Dr. Agnani, and I'm sure you are all going to look forward to his presentation, which is going to tell us something about health systems and also about gender.
Okay, thank you. So, being the last, there will be some overlap, and I'm not going to cover post-menopause only. I will cover the entire life course. So, you have a pre-birth discrimination, you have post-birth discrimination, gender bias, gender blindness, some benign neglect, and most of blindness part. So we'll try to cover all these parts. Although I was asked to cover the old age part more, we'll have some slides on that. Some of the data is old. We'll try to see how much improvements we have. This is IMR and U5MR, Indian data. If you see IMR on the left side, there are 10 states where IMR is higher for female than in male. Need not to say it has to be more for male than for female. So is the case with U5MR, and except in 9 states in India, and this is 2020 SRS. So things have changed for better. We do not have data to prove. Beti Bachao and Beti Padhao programs would have made some impact, but post-birth neglect, U5MR, you see there are differences. This is also an old slide, but then after that you have insurance schemes in place. This slide is showing the probability of dying in a hospital is higher for boys than for girls, and on the right side it is the reverse. Probability of dying at home is more for girls than for boys. Shows some neglect. Let's see more slides. Don't go into the details. On the left is a study which has tried to see the Ayushman, Rajasthan Bima Shah scheme, insurance scheme, state sponsored scheme. Look at the table. Up to 15 years of age, the admissions 33% female, 67% male. Overall, it is 45 and 55, and more than 50 years, which is a middle one, it is just 43% for women and 57% for men. On the right side, look at one of the prominent tertiary care public hospital in Delhi. You can make good guess. If you see age-wise sex ratios, up to 16 years, it is 1.93, 17 to 30 is 2.01. Overall is 1.69, and 60 and above is 1.75. That's the difference, and that is OPD. Then come on the blindness part. This is only a longish slide. Leslie Doyle, she argues that medical research continues to be based on assumption that men and women are physiologically similar in all respects except the reproductive system, and other biological differences we ignore. We ignore at each level, and consequences that we generate a knowledge which is gender biased, and femaleness cannot be equated with motherhood only. So this gender blindness part we'll see in next slides. Many studies in terms of this first study, individual aged 45 years and above, the proportion of 3 or more NCDs has been reported to be significantly higher in women than men. Second is saying at least one NCD, could be physical or mental, was found to be higher among women as compared to men. And the third is showing the relative risk of fatal ischemic heart disease secondary to diabetes, was twice as high in women than men. Hypertension was covered, but look at the prevalence. So Lassie study 1780, hypertension prevalence in 45 plus years women 59%, greater than men 41%. Treatment coverage was major gaps in terms of access and utilization for women. Control rates, which should be the outcome for any hypertension like disease, was just 13.3% in urban areas and 8.6% for rural women. And data, we have lack of gender data, disaggregated data for monitoring. Hysterectomies, there is a separate part how much hysterectomies are happening. I am not mentioning the states, but look at the prevalence among women between 40 to 49 years of age. And what they report is it's all for the reasons, menorrhagia, hysterectomy is done. It's not easy to understand. We have a rich panel of gynecologists sitting here. What it leads to? It leads to hypertension, diabetes, bones, joint diseases, cancers, mental disorders, leading to the unnecessary hysterectomies done on this. Then let's see this part, very interesting part. So, sorry, this keeps on switching. Sorry for that. This is showing that 47% of conditions that affect women disproportionately. Means what? Means they have a higher prevalence in women in comparison to men, 47%. And 4% is differently, means they have a higher disease burden per case in women than women. So that makes to 51%. Coming to the next slide, look at the R&D part, research, where we are focusing. We are focusing more on the diseases which are mortality related, cancers. While on the right side, if you see rheumatoid arthritis and other things where they are affected disproportionately, we have less research for women. Then if you see the priorities, gynecological diseases are less prioritized. Look at the number of cancers and all those things where we have more research priorities. But if you see the right side, endometriosis, menopause, postmenopausal symptoms and polycystic ovary disease, very less. So Delhi's, as Madam said, that they suffer more, morbidity is more, mortality is less. We have a neglect in terms of giving research priorities to those sufferings, illnesses where women suffer more. And if you see the impact of 10 most important conditions, they are shown here. Again, premenopausal syndrome and depressive disorders are top 2. All these things have been covered in the previous presentations, and if we really want to invest on these things, it can create an opportunity of creating $1 trillion for improving lives and economies. This is something about the data. We have half of the data which can be disaggregated between men and women, and whatever 50% data is available, out of that, women who suffer more are at the disadvantage is around 64%, while for male is only 10%. And for 50% we do not have any data. So some Indian stories. TB, we are the first country, not the first country, we are a country which have a gender responsive approach in the TB care, but still there are many things which are yet to be unfolded. There are variations in public private, less understood why some of the women are going to the private sector then to the public sector. Is it something stigma related thing, or the healthcare provide us behavior. We don't have evidence on that. And there is very little knowledge about gender differentials in post-TB care and long-term morbidity and mortality. So which shows there is a case for going beyond the orthodox approach of looking at the programs. This initiative I just thought that should make a reference to by in a Satara district of Maharashtra done by PATH. They tried to see all these issues which I covered in my presentation, that's reflected in a problem statement, and they wanted to have a women-centric integration of services, and they did a targeted outreach with referrals and follow-up care, and results were fantastic. Now with this, I really want to take you to the, if we take today's point as a to make a gender specific things and we look into the future, we want to cover the neglect part both in terms of biases and blindness. We will have to remember that our demographic is changing. So this is 2011 versus 2036. We will have more population in the middle age group and the older population. So we can't just avoid this fact. The risk factors will change and the disease burden will change. We are showing projections up to 2040. That should also be kept in mind. And reproductive age group will still be important. We just can't say that we just focus on reproductive age group, post-reproductive age group, because 54-53% population projections will still be in that age group. So although the pattern will change and due to declining fertility, the number of pregnancies and birth will come down, there will be hot spots in the country which are the high TFR states of Bihar, Jharkhand, Madhya Pradesh, Rajasthan, Chhattisgarh, UP and Assam. They will have more requirements for this. There will be new causes for maternal death which will need attention. Maternal anemia has been discussed in this conference very well. So because of the climate change, you will have increased miscarriages and abortions. There could be a possibility of increased vector-borne diseases and psychological issues, and infertility may become a priority because of the urban living conditions and climate change. So this is my last slide. Call to action, reimagining gender responsive health system. How to close this gap? They are saying that you invest more in women-centric research and R&D, strengthen the collection and analysis of both sex and gender disaggregated data, enhance access to gender-specific care, encourage investments in women's health innovations, and examine business policies to support women. Thank you very much.
Thank you. That was a lot of food for thought. And I think we will now just dive a little deeper into it and really try and understand what can be done. How should we move forward from here? And I would like to ask Dr. Poonam that, menopause impacts over 100 million Indian women. Yes. And we know this number is going to increase, as Dr. Agnani just said. Our population in the middle segment is going to increase because of our, the way the population is going to go. There is going to be a demographic transition. But when we talk in terms of the public health dialogue, menopause is almost absent from the public health dialogue. Why is menopause still a silent subject in India? And what can we do? What practical steps can our health systems take? And what can our other stakeholders do to offer better care and support for women?
So, very powerful question, but silence on it for past so many years. So, I think the first thing I think this is the taboo subject in India, that is, we have already discussed this, that because it is considered as a very natural thing, but natural does not mean easy always. So it is not considered as a disease. That is the problem. So now what we can do? First thing is that we should include this in our healthcare policies. We do not need to make a separate vertical for that. In the existing healthcare policies, this can be included. So that means there will not be so much of financial burden on the government if they just take this into the umbrella which they have already got. And the second thing is that we have got a real army of our ASHA workers, ANMs, GNMs, and they can be given a basic training about this, like we did for the your menstrual hygiene thing when we brought it. And I think we can train them and just make them aware so that they can screen the patients and they can bring the patient to the doctor for further, other things. Then we can create the awareness, like by the use of branding or celebrities. Like if Deepika Padukone can talk on depression and Amitabh Bachchan can talk on tuberculosis. So like that way we can bring, so that public is made aware of that she is in a problem and she needs some medical help. So, and then I think we can make more public aware of this by this branding, etc., and just creating the professionals, taking the professional helps like Foxy and all to do CMEs and to do public awareness programs about this. That way we can make a way forward.
I think we need to shift the narrative around menopause in, from silence and stigma to maybe open dialogue and a more proactive management approach.
We can even make guidelines for the workplace for the women, because our workforce, many women are in the same age group. They are a good workforce for our society.
Yes.
So we can make some guidelines for the workplace also.
True. I think also, for menopause, perhaps the first point of contact for the woman would be a gynecologist, and how Foxy and other professional organizations can really think of, when they have worked so much for increasing awareness about menstrual health, we need to also start increasing awareness about menopause in women so that, they can start talking more about it and accessing care. Dr. Prabha Chandra, we have the, as I said, highest number of depressive disorders among women in South Asia, and self-reporting of mental disorders by Indian women is extremely low. It's perhaps less than 1%. But as was mentioned by Dr. Poonam Goyal, it's very heartening to see now that, more people are talking about their mental health issues. Perhaps it's because of, Bollywood icons and other people who have come out openly and are talking about it. And at least I hear of more youngsters, kind of recognizing if they have a problem and going in for counseling and things like that. But there are several initiatives at the policy and the program level also. We have had a national mental health program, and then that went up to the district level when we had the district mental health program. We have a mental health care act, and recently we also had the national tele-mental health program, which is the Telemanas, which is to provide tele-mental health service through a very structured support system. But despite the existence of these national programs and policies, mental health continues to remain deeply stigmatized. and especially for women, and we know they face challenges in accessing services. How can we integrate gender-sensitive interventions that are culturally sensitive, more accessible, and less stigmatizing for women, especially in the rural and in the lower income segment of, the population?
Thank you. I think this is something that we have been, exploring for many years now, because like you rightly said, we in India at least we have something called the district mental health program, which the district mental health program, which is available in all districts, but unfortunately everybody doesn't access that. Interestingly, depression can manifest very differently in women. It doesn't necessarily have the same kind of clinical picture which you see in men. In fact, we are all protesting because in most women it's called atypical depression. So what is typical is more male, and anything more than different from that is called atypical depression. And women's depression manifests quite differently. It manifests more as physical symptoms, fatigue, excessive sleep and tiredness, feeling highly rejection sensitive. So the way depression manifests itself is different. So when we educate the public about depression, we really need to tell them that it can be very different in men and women, so that women recognize it much more. Also, one of the initiatives, for example, in Karnataka, in the city of Bangalore, is that something like neighborhood clinics have been started, which means that basically every locality in the shopping area has a clinic. And what is interesting is that in addition to all the medical problems that they see, they've also written depression, anxiety, mental health, which I think is a great step forward, because till now it was not being sort of openly talked about. The third thing, I think, like Dr. Poonam also mentioned, mental health interfaces for women in different places. Women hardly have time to go and see a counselor or a psychiatrist, or a psychologist. They are burdened so much. So their physical health becomes low priority, their mental health becomes absolutely low priority. So I think it's important that we see where all the interface can happen about mental health. It can happen in a gynecological office. So we have actually now working very closely with Foxy. We're focusing on maternal health, but I think maternal mental health, but I think we need to expand it to women's mental health. We have a big program where we are with Foxy and with the South Asia Federation, we are actually doing training for that group. Physicians need to know about it. Workplaces are one place where mental health problems actually surface a lot because of the kind of challenges women face. So the police, policy, everybody's working in silos, so things can happen. So you may have the best acts in the world, but if it's not enforced, if people are not aware of it, you're going to have problems. So I think this is one thing. You mentioned Telemanas. I just want to talk about it because it's my institution which spearheads Telemanas, and I work closely with the group. Telemanas is basically a tele-mental health helpline, which is 24/7 in all states of India, in all languages. You can ask for a gender-specific counselor. And we are seeing a lot of women actually approaching Telemanas. The advantage is they can do it in their homes. They don't have to go anywhere. They don't have to depend on the husband for transport. Sometimes it's simple things like that, like childcare transport, so even if you destigmatize mental health, unless you provide access, it's not going to happen. So these are things that we can actually easily do.
So it is paid, ma'am? Telemanas is
completely
free. No, it's free. So Dr. Satoya, we know that prevention is better and cheaper than cure. Yet screening for breast cancer, cervical cancer, diabetes, and hypertension, especially in women in India, remains very low. So what are the structural barriers that prevent women from accessing this preventive care, and how can we overcome them?
Thank you. I think for hypertension and diabetes, I think the service availability is increasing. But yes, there's still a room for improvement, especially for follow-up and control, because it's one thing to put them on treatment, but it's a different things to keep them maintain a good blood sugar and blood pressure. And also we are also, this is relatively working well in kind of rural India. It's working well, but we are doing a little bit more, we need to do more work at the urban settings. Actually, in urban settings, the control is actually less. So we are trying to increase the reach in the urban setting as well, utilizing the urban PHCs. But coming to the barriers, but especially for cancer screening, yes, there's a strong barriers, and despite a lot of trainings and advocacy is happening across India, the service, very few people are coming for screening for both cervical cancer and breast cancer. And I think it's from both ways. Barriers is from both the women and also at the healthcare workers. I think healthcare workers is just waiting for them to come, and they are trained, but they don't have confidence to do it, and so they're like hesitant to do it. So they're not really, is what when I go to the field and hear. And also so we need more proper training and more, make sure that they are providing services. I think monitoring is also lacking, so that, But also from the women's side, they're hesitant to come to the service. One, they don't know about the screening. They don't know about cervical cancer, breast cancer, and they don't know that there is a treatment. So I think it's important to raise awareness to them to decrease this gap. But I think one thing, I was listening yesterday, one panelist was saying that we need to make sure that it's a good service, especially for cervical cancer. It's intrusive. WHO is, promoting for DNA self-testing, which is less invasive. So we need to listen to women if they experience good screening in a hygienic place, with privacy, and the results comes and treatment is there. They will advocate to other women. So I think it's important to provide quality care so that they have a good screening experience, which will kind of lead to better understanding among the fellow their colleagues or friends, and to increase that there is service and it's quality. So I think it's, from both sides we need to do work. Also, yes, I think other things we mentioned, but we need to make sure that not only at the service availability, also not that only at the district hospital or CHCs, we need to bring down to primary health care services for both treatment and screening. So these kind of areas.
And I'm now going to move on to Dr. Ignani, and you have been for long at the helm of affairs in the program, and so I would really like to ask you is that, we have so many strong foundational health programs in India, which have been ongoing for several years, but they are very narrowly targeted. For example, our maternal and child health program. How can these existing programs be leveraged to provide holistic women's health? We have now this very large number of Ayushman Arogya Mandirs coming up. We have so many other programs, as you know, of whether it is our PMJ, whether and how can we integrate them?
So if I understand your question correctly, so we have a Ayushman Arogya Mandir to provide comprehensive primary health care. So the larger assumption was that there was a fragmented primary health care which was confined to RM and CHA part. We needed to go beyond because there was evidence and data to suggest that let's work on NCDs, let's work on mental health. There are issues around palliative care, geriatric care. There are issues around basic injuries, traumas, and others. So to make a comprehensive primary health care, it was envisaged that through the Ayushman Arogya Mandirs or the sub-health centers, the primary health centers at the in the rural areas and the urban areas, let's change this fragmented care to comprehensive primary health care. But in that process, probably people thought that it is the RMNCH part which was being ignored or has actually got neglected. And there is some evidence to suggest that if you shift a focus from RMNCH to NCD, and you have not made those investments in terms of the resources or training or creating additional HR, which was done in part, and making those linkages with the secondary care which you are wanting to point with the introduction of Pradhan Mantri Jan Arogya Yojana. So I think if you have systems in place, there are good examples in the country where the comprehensive primary health care is making linkages with the secondary health care, and these issues around women or gender and health, where whatever the programs and policies are in place are being addressed. But the larger question is that do we have all the programs in place? Are we thinking in terms of that women have different sufferings, they have more delis, they have more morbidities, their biology is different, we should need to plan differently for them? And should the same programs have the different approach of handling them? Do we need the capacity building only, or we should make some proactive provisions in the policy part, and how to monitor it? That's something which I think is a requirement now if we really want to move forward. And of course, yes, for that you need human resources also for that. So you will have to create those resources, train them, and start collecting more data so that the data will tell you more about how you are going ahead and what needs to be done more. So I hope that answers your question.
I think that was very comprehensively answered. I think we will now move to our chair and have some closing remarks from him.
Thank you very much, Dr. Namita, for including Foxy and Dr. Poonam Goyal and me in this session. I'm sure all of you will agree that it's been a very important session and a lot of very important insights have come out. I was just thinking it by way of closing remarks, whether I should summarize the session. But then I thought that's actually a waste of time because the speakers have said it all so well that I don't think repeating it is really going to add any value. I'm a practicing obstetrician and gynecologist. I'm not a public health person. So what I thought I would do is bring in a way, the human drama of reproduction into the room by telling you maybe one or two stories, if time allows, from my personal experience of working with women and patients and couples and families for now more than 35 years. I know that we are supposed to talk about things beyond pregnancy, but I've always felt that pregnancy is such a landmark event. And I don't think it's a landmark event only in a woman's life. I think it's a landmark event in a family's life. That I'll first tell you a story about pregnancy and one of my patients, and hope that it conveys the message or cuts across so much of what we've said today. So I used to have this patient. Every time she used to come and see me, she used to come with her husband, father-in-law, mother-in-law, father, mother, and sister-in-law. And every time I used to sort of examine her, I used to tell her that I think everything looks all right for now. The rest of the family would ask me questions approximately 15 or 20 minutes. And at the end of all of them asking questions, they wouldn't allow the woman to speak. They would keep on asking questions. At the end of it, they would ask the woman, "Beta, aapko kuch puchna hai?" And I could see that she wanted to talk, but she didn't really feel that she could after 15-20 minutes had already been taken off the consultation. So after 2 or 3 visits, I told the family that, look, I think everything's going well. I really don't think there's a need for all of you to come every time. If I'll see her, and if I think that there's a problem, I'll tell you, and then you can come down and we can talk. So next time only she and her husband came. I examined her, I told her everything seems fine. And she said, I asked her, do you want to ask me anything? You know what she asked me? And I think this in a way speaks to the pressures a woman, and particularly a pregnant woman in the modern age, live under. Now, starting from all those early morning WhatsApp messages in the family group, take care beta, don't take stress beta, think happy thoughts beta, and all those kind of things. And there's this constant pressure to produce the perfect result. You know, nothing less than a vaginal birth of a 3.5 kilo child who finally comes first in 10th standard will do. And when I asked her, you know, do you want to ask anything? You know what she asked me? She said, doctor, my co-sister, I believe that's a term for a sister-in-law, my co-sister's pregnant with me. And yesterday, she vomited 6 times. I vomited only 3 times. Does that mean her pregnancy is better than mine? And first I was amused. You know, I said, how can she ask such a question, you know? And then later on, I actually felt, so I don't want to say I sympathized with her, I don't want to sound condescending, but I really felt bad for her. You know, imagine having to think that if I vomit more, or if someone else vomits more than me, that pregnancy is better than mine. So I think that, you know, it speaks to the pressures which modern pregnant women face. And I think that those pressures and the experience of the pregnancy shapes her health, her attitude, her approach to her own health over a very, very long period of time. I also would like to talk a minute about fertility and infertility. The WHO said that infertility as an issue affects 8 to 10% of all couples in the reproductive age group. Given the fact that we have millions of couples, women and men in this age group, I've always felt that we don't take infertility seriously enough as a public health problem. Unfortunately, infertility is always seen as a problem of, in a way, plenty, or it's seen as a bit of an elitist problem. And I think this lens of looking at infertility and the challenges which couples face when they struggle to conceive are something which are underestimated. So again, a story from my practice. I know that we are almost out of time, so I'll finish quickly. And I'll tell you 2 stories here to illustrate, you know, the problems which couples face for infertility. I used to have this patient who used to tell me, doctor, can you please make sure that in this treatment cycle I become pregnant? Because every time I get my period, my mother-in-law beats me up. Have we thought about infertility from that lens? Another story about a couple who came to me, already having tried around 5 or 6 cycles of IVF, wanting now to go for adoption, but the previous doctor said that you can still conceive. So there's a letter that is required for adoption where a gynecologist has to say that this couple is unable to conceive, so they are fit for adoption. So the previous gynecologist said that, you know, I still think you can conceive, so I'm not going to give you that letter. They came to me, I encourage adoption. So I said, we'll be very happy to give you that letter. I gave them the letter. A year later, they had a beautiful baby girl whom they adopted. The husband wasn't doing very well in business, but once the baby girl came into this couple's life, the husband went on KBC. It's the Indian equivalent of Who Wants to Be a Millionaire. He won 50 lakhs. He won 50 lakhs, his business started doing well, and in the next month his wife conceived on her own. So I think there are all kinds of stories, and I think that bringing out these stories, it sort of illustrates the power of stories to make your point. I think it's crucial. Foxy is working on this. We are trying to make a compilation of stories, inspiring, sometimes depressing, sometimes very thought-provoking. And we hope that we can use the power of stories to leverage the health of women and improve women's health in pregnancy and beyond pregnancy. And finally, I think what we would really like for women's health to improve is the availability of information. You know, if you do a Google search for childbirth, you'll get approximately 29 million hits. 29 million hits for a Google search on childbirth. How can women be expected to understand which information is proper and which is improper? There's so much rubbish information out there. And therefore, it has long been sort of a, how do I say, a dream or that India, like I believe that it's there in the US, India would also have some kind of a way of authenticating the information that's available on the internet. Foxy would like to work on that. We would like to create a framework by which someone could say that this information's been vetted by a body of professionals, and therefore this information is authentic, it's affordable, and it's available. And I think that really is the key of making women aware and improving health through their entire life cycle. Thank you.
Thank you. I think Foxy, with its very wide reach throughout the country, has the capability of being able to not only work in the area of maternity, or what I mean is pregnancy, but even go beyond that and take up issues of women's health. And I think to just close this session, I'm just going to, based on what the discussion is, just going to go over some of the points which were taken up. I think we need to include women's health in our conversations. We need to talk about it. We need to advocate for it. We need to invest in woman-centric research to understand the sex-based biological differences. We need to include women in clinical trials. Presently, they are very underrepresented in clinical trials. We need gender-segregated evidence generation, whether it's in research or whether it's in monitoring. And I think this will ensure a more deeper and nuanced understanding of women's health problems, and also will help us, whatever the actions are, they will be data-driven then. Co-design solutions was mentioned. So I think it's the power of communities. We need to include women's voices when we design solutions and develop and pilot innovative models of care. Harness the use of digital health. We've had so many sessions on digital health, and I've been hearing throughout that digital health and AI are the new buzzwords. But we can use digital health in improving women's health, whether it is through telemedicine, whether it's through chat boxes, or whether it's just using social media. I mean, we don't understand the power of social media. It's not only those who are educated who are using social media. I see social media being used by, or even those who are in the lower economic strata. I think we need to, as we said, leverage our health programs so they are more connected, more inclusive, and more intersectional. And we need to move from silos into a more integrated approach. I think respect and empathy, which I said, it has to be at every touch point, whether it's a village health worker or it's a specialist in the city hospital. And it has to be an ecosystem approach involving multi-stakeholders. I mean, only if all the stakeholders involved get involved into it are we going to accomplish these goals. And as you mentioned, the EU has articulated a comprehensive and an inclusive strategy on women's health, and it has clearly defined goals in it. And sometimes, when you develop strategies and you kind of articulate things into it, you get a better perspective of it and you have something to follow. So perhaps that is something which we can also do, is articulate an Indian strategy for women's health. And I think we just have to move beyond the narrow definition and recognize that a woman's health value is not defined by motherhood alone, and Soha Health also shouldn't be defined just by motherhood. And I thank all the panelists for their very insightful comments. And I would also like to thank Dr. Pushpa Chaudhary and Dr. Priyanka from the WHO India office, and they were involved in planning this session. And so thank you very much, and thank you to the audience for participating. Thank you very much. Yes, I would request Carla to please give the mementos to all the panelists. This matter, just give it to him, but he knows that there is a four and then we must get a photograph.
talk on this topic of photon counting CT today. Now, photon counting CT for me is a very passionate topic. As a company, we've been working on this technology for around 20 years. It's almost exactly the time that I've been working for Siemens Healthineers, and I joined in the CT area. So it's a topic that I've seen develop over time, and now that it's something that's come to fruition is something for me personally that's really exciting. Right, and throughout the history of CT, we've had a number of really big advances. So back in 1990 was the first spiral CT, where we could continually run the gantry in one direction, but it was limited by a detector technology with xenon gas, which didn't have a great stopping power for X-rays and wasn't particularly dose efficient. So in the late 1990s, when I started coming into CT clinically, we moved to multi-slice and to scintillator detectors. So these are solid state ceramic detectors that can stop a lot more X-rays. And when we took each rotation, we were taking not one slice, but 4 slices of CT. This developed over time to 2005, when the next big innovation came to CT, which was dual source CT. So to take a CT image, you need 180 degrees of data. What we did in 2005 is we added a second tube and a second detector. So the system now only had to rotate 90 degrees to acquire every image. And from a cardiac perspective, that's like a faster shutter speed on your camera. So the ability to stop the heart and get a clear image of the heart was something that jumped forward. Despite all these breakthroughs though, there are still enormous technical issues that come to jumping the next level, right? And some of the things that limit CT is that we've started to reach the limit of spatial resolution, the small elements within the human body that we can detect. And now trying to drive up higher spatial resolution comes at a big X-ray dose penalty. We also have some patients that remain unscannable, whether it's from calcium load in the coronary vessels or from stents that are hard to image. These patients just can't be scanned on traditional CT. We also miss some information in scans, so there's an opportunity now to get more functional data into CT, which is something that we can't with many conventional CT scanners. And measurements are tricky on conventional CT. So we measure the Hounsfield densities within an image, and when we use different strength of X-rays, those numbers are not consistent. So those limitations are there, and they're based on very physical characteristics, right? So it's just hard to rotate a gantry faster than we do at the moment. We're down to about 0.25 seconds, and physically it gets difficult to rotate that huge mass faster than that. We also can't make the detectors significantly wider because we start to get image artifacts into scanning as we do. And also we struggle to make the pixels within a conventional CT scanner smaller, because the smaller we go, you start to get a dose penalty and the dose efficiency of the system starts to drop off. So that leaves us with a big limitation in CT. But with photon counting CT, we really have developed a radically new detector and a completely new approach to CT, which brings in the new era of photon counting. And we were really pleased to get the invitation to speak today, looking really at what the implications are of this new technology on our patients. A couple of things that it does. With photon counting CT, we now look at equal energy contribution from both high energy photons and lower energy photons. So with any X-ray beam, the actual information in the image as the X-rays pass through the patient is actually in the lower energy X-rays, because they're the X-rays that some are absorbed and some are transmitted as it goes through the body, and that differential absorption is how we develop an image. Photon counting also brings substantially smaller pixels, so much, much smaller detectors, and I'll talk in a moment how we managed to do that with the technology. There's also an intrinsic spectral sensitivity, so different materials in the body, whether it's calcium, whether it's injected contrast material, they behave in a different way from high energy and low energy X-rays, and with that we're able to get much more information out of CT scanners than we ever could before. And also we now, through this process, we eliminate the electronic noise, which means we can reduce the dose significantly further. So how does it work? A little bit of physics if I can, and I find it interesting physics, so bear with me for a couple of minutes, right? But since the 1990s, all CT scanners have worked with the same style of detectors. And it's represented here. So what you have in these larger grey boxes is the detector material, which for us is gadolinium oxysulfate. And then you have these septum, which separate the different areas. And on the bottom, you've got a photodiode. So the way that it works, when X-rays come and hit the detector, they're converted into light. And the amount of light that it gets converted from each X-ray is proportional to the energy of that X-ray that comes in. Right? That light is then detected by these photodiodes, the orange parts at the bottom, and gets converted into an electrical signal which we can then use to reconstruct an image. Right? So that's the way CT has worked for as long as it's been around. There are some limitations to this. So when X-rays hit these photodiodes and it makes light, there's a glow in that detector. So if another X-ray comes and hits that while it's still glowing, the system doesn't differentiate between those two X-ray incidents. And you see this here with the smaller circle being a lower energy photon and the bigger circle a higher energy photon. These get combined into one electrical signal in the system. The other thing that happens with these detectors is that you get a bigger electrical signal for a higher energy photon and a lesser electrical signal from a lower energy photon. And remember, I said earlier that these lower energy photons is where our real message is when you're looking in CT scanning. So that's a limitation of this technology. Now with photon counting CT, we change it completely. So instead of a scintillator material in the detector that converts X-ray energy into light, we now use a detector which converts X-ray energy directly into an electric signal. So now we have this cadmium telluride detector that we use at Siemens Healthineers. And as different to before, when an X-ray is now incident on the material, the conversion is not to light, but it's directly to electrons. Along the bottom of the detector then we have these pixelated anode, these small squashed grey ovals, and these then detect that electrical signal and we use that directly to make the image. So a few advantages straight away. You'll notice we no longer have to use these septum between the detector material. That means that straight away it's more dose efficient because if an X-ray is incident on these septal areas, it's not counted in the final image. Also, these pixelated anodes are substantially smaller, like around a tenth of the size of a conventional CT detector. So that's where we drive the spatial resolution. The other key advantage, and why we call it photon counting, is each of these individual photons now is detected. They're individually detected, and the strength of that photon is then individually detected as well. And it's that differentiation which we use to make a lot of the new ways that we can image with photon counting CT. Okay, so a couple of the benefits. I did talk about the spatial resolution. So these pixelated anodes, they're tiny as compared to any conventional CT detector. And that gives us the opportunity to drive a much higher spatial resolution, so seeing smaller things, but without a penalty of dose. Another key element with this is because we're measuring the strength of each of those X-rays, we're able to set a threshold in the detection such that we can eliminate electronic noise from the system. Doing that just allows us to scan at lower doses. And in a moment, I'm going to talk a little bit about the impact of photon counting on pediatric patients, where it's super important. So this elimination of electrical noise means that we can reduce dose significantly. We also get this spectral resolution. So in a moment, we'll look at calcium in coronaries and see how we can specifically now say that is calcium and that is part of the blood vessel, and we can switch each of those things on and off in the image to look at something different. And then also we get an equal energy contribution. So the key here is that these photons that are around the right energy to be at the edge of where a certain substance absorbs more radiation, we can really focus on those to be able to drive a much higher contrast in the images without a dose penalty. And they're the four really key elements that we've managed to bring. Now that's physics. In a moment I want to talk about really the impact on patients. But the physics itself I find pretty interesting and something that I've enjoyed following. And we have been following it at Siemens Healthineers for more than 20 years. So back in 2003 to 2009, when there was a lot of
science being done on how these detectors work, a lot of work being done on how we can maintain them in temperature changes and humidity changes because they're quite susceptible to different environments. And this took us all the way through to 2012 when, as a company, we believed there was really something in this and made the acquisition of a company called Aquarad, who produced this detector material in Japan. It was 2014 to 2018 when we started to install prototypes of photon counting systems. These were systems where we had one conventional detector and one photon counting detector, and we did a lot of work and a lot of study over many years to work out how to do this in the best possible way. And then 2021 we finally launched the product, the Naotom Alpha, and now we have over 100 of these systems installed worldwide, quite a few of them right across Asia Pacific. And a key point that I will come back to, in 2022 we started building a new detector factory in Germany, and this is key for our ability to scale this technology such that more patients around the world can benefit from it. Okay, so what are we doing? We've got the quantum technology. This is the photon counting concept, and we're marrying this with dual source CT for the speed. And this is the thing that's really redefining CT, being able to get all of this spectral information, but at the fastest speed of CT that's ever been delivered. And that's a real game changer for us in CT. What we're seeing is also that in the scientific community, there's a big ramp up in interest in this. And you start to see a drop off of papers on conventional CT and a real acceleration of photon counting based CT. So that this area of study and research is ramping up at such a pace because the types of things that we can do with technology, we're really just at the start of how this is going to impact CT and medicine. Okay, so how does it look in practice? So here's 3 images that are conventional CT images. So on the left-hand side, we've got a coronary image, and you see this, calcium bloom here, and a small cross-section imaging on the bottom where you can see this blooming around the calcium. When we look at photon counting CT, what we're able to do now is really sharpen up the edge of that calcium and really enable us to see what is really the lumen of the coronary artery. And this is key because many of these patients with calcium can't be scanned on conventional CT, and the only other option for them is to go and have conventional angiogram with the cost of it and the impact on patients. In the middle, we've got a very low dose chest scan. So it's quite noisy, but it's extremely low dose. What we're able to do now at even lower doses is really sharpen this up. So you start to really see the structures of the lung. And now that we're getting to lung CT at doses similar to X-ray, it's a real potential game changer in CT imaging. And on the right-hand side, a conventional CT scan of a brain. It's an angiogram of the vessels in the brain. And if you look at this section here, there's a stent in the brain, but it's hard to differentiate because it's near the base of the skull. There's a lot of bony structures. Now with photon counting CT, we can see inside these stents and really get an image of what's going on in a clinical area that we've never been able to do in a great way before. Cardiovascular CT. I spoke before about how we can say specifically what's calcium and what's not. So on the left you see a fairly well calcified vessel. What we're able to do is just switch the calcium off the vessel now and really look at just the lumen. In the middle we've got a body image. This is a virtual non-contrast image, and there's a lesion in the kidney at the bottom here. What we're able to do with photon counting CT now is look at spectrally where is contrast material going. So we can see here we've got larger activity at the posterior area of this lesion, and again that information can be crucial to radiologists for diagnosis. And on the right-hand side, a pulmonary angiogram. So it's sometimes tricky to pick small pulmonary embolus in some of these images, but now we can bring this spectral information looking at the perfusion within the parenchyma of the lung. And here you see this deficit here of perfusion, and it can be very useful in guiding the radiologist's eye to something that might be there from a pathology perspective.
what we're talking about, I think with photon counting, and we're right at the start of it, we're really talking about a profound clinical impact. So this is something that's going to change the way we manage patients and change the way patients interact with CT. And one example, this is a study from 2016 that looks at coronary patients in Germany. So this is the number of patients that are ineligible for coronary CT angiograms because of the load of calcium in their vessels. Right, so 16%, it's not a small number, and what it means is we will potentially open up cardiac CT for a big range of patients that instead will have to have the trouble of going to hospital, the issues of recovery from traditional coronary angiogram. The cost goes to the system or to the families, and the recovery time can be much larger. Instead, these patients can now become eligible for a fast, non-invasive CT test to look at their coronary angiograms. And here are some examples. So traditionally, a lot of groups say when you have a calcium score above 600, you're in an area where coronary CT angiogram may not be useful. So often we do a coronary calcium score before we do a coronary angiogram, and if you get a very big high score, some places will stop the examination because the patient's better off to go to a traditional invasive coronary angiogram. So here we see a calcium score of over 1750, which is very high, but the ability with photon counting to reconstruct down to just 0.2 millimeter thick slices means that we're able to reduce the blooming on these calcium lesions and see directly into the lumen. You see the difference here with this upper lesion here, this calcified lesion. It's quite a lot bigger, and that's because of the way CT works. It blooms on the side of these lesions, and they appear bigger than they really are. When we look at really thin slices, you see that it is much smaller in these images and gives the doctors an ability to make a diagnosis. Similarly here, you've got a score of only 1100, but it's all in two areas. So we've got these two highly calcified lesions in the right coronary artery and near the bifurcation on the left-hand side. And this would most probably render this patient ineligible for CT if conventional CT was the way to go. But we see here really clean images of the coronary arteries. We can see this lesion here, 25 to 50% maybe in the right coronary artery. And despite them being ineligible for conventional CT, they're able to be diagnosed on this system. Another example of the pure lumen. So here we have a number of calcified lesions, but it's hard to quantify what the real lumen is in that coronary angiogram. When we switch off the calcium, what we can see is directly in. So we can now really quantify this lesion here. We can see it in cross-section very clearly, and the clinicians are able to give this patient a clear number for the severity of that lesion. It's not just coronary calcium which causes trouble when it comes to cardiac CT, it's also stents. And so traditionally, when we're looking at follow-up of patients who have had stents, traditional coronary angiogram is the way that many of these go. With the photon counting CT though, we're able to really look inside the stents. So again, with the very, very detailed detectors that we have, we can reconstruct down to 0.2 millimeters, and you can see here we can clearly follow the inside of that stent in a way that just can't be done with traditional CT. Another example of multiple stents, and here we can see in the more proximal stent a clear and pretty severe lesion, which again we perhaps wouldn't be able to be identified in conventional CT. Another example with many stents, and here I wanted to point out a real distal stent. This stent here is tiny in the distal right coronary artery. Right, so the detail that we get on this system is incredible, and the impact on these patients shouldn't be underestimated, because a lot of these patients now come in for routine follow-up. They can have a CT, they're out the door in a matter of minutes, back to doing what they'd normally do, as compared to the recovery from a conventional angiogram. There's also studies about the real impact on patient management. So here we have the quantification of stenosis. So we have this blooming of this calcified lesion, and from the systems this is considered to be about a 50% stenosis, right? And that's at 0.6 millimeter conventional CT sort of images.
In the middle, we can reconstruct down to 0.4 millimeters, which can only be done with this system. And now we start to see that this lesion size has been classified smaller. When we get down to our 0.2 millimeters, when we use a sharp kernel, now we start to get to the real lumen of this, and we're seeing a 30% stenosis. And what this sort of impact of this ultra high resolution coronary CT angiogram is showing is that patients are starting to get reclassified into less severe buckets of CAD-RAD scores. And this is quite significant because as patients get considered to be less severe in their disease, the management changes significantly. So a CAD-RAD score of 1 or 2 becomes quite simple management, medication management. A CAD-RAD score of 3 might be functional testing, and then it's 4 and 5 when patients then go on to invasive coronary angiogram. So when you're having from this ultra high resolution scan being able to classify patients correctly into a lower risk bucket, it just means the flow on to additional testing for that patient and for the healthcare system is reduced. And we see from studies that this can be quite significant. So looking at this high res, we're seeing up to half the referrals for invasive coronary angiogram than we have seen in other areas. And also these are US numbers from a study between the US and Europe, but we see that this has a profound effect on the costs within the healthcare system too, of not having patients go to follow-up tests that aren't needed, to look at the implications of coronary angiogram, where there are some risk factors. All of that has a cost in the end, and photon counting CT can really affect patients in a way that these sorts of things can be avoided. I'm going to step on from coronary angiogram and talk for a moment about a very difficult cohort of patients. A patient, it's a great group, but they're tricky, right? Many of us in this room would have kids, and we know that they don't always do exactly what we ask them to do at the exact same time, right? So the other thing is kids have high heart rates. It's very, very difficult for CT to image high heart rates, and they're very dose sensitive. So we have to be making sure that we're reducing doses to the lowest possible amount. And this is a good quote from Catherine Owens from Great Ormond Street. Children are really the ultimate test of a CT machine. And I think that's a great way to look at it, because the best that we have in CT, we really need to set aside for children. High heart rates, they don't sit still, they don't always do what we ask them to do. They're often uncooperative. not your kids.
She has 3 boys.
Yeah. Okay, so what we see first of all, there's many studies that have come out that have compared the dose in photon counting CT to conventional CT. And what we're seeing is a range of numbers, but all in these cases fairly significant numbers on dose reduction. And for pediatric CT, that's a real win for this patient cohort. We're also seeing with the way systems are being produced that because we can run the CT scanner directly from the side of the CT scanner and can use iPad-like technology to set up scans, the clinicians are able to spend much more time directly with the patient. And so this is a heat map of where the radiographers running this system are spending their time. So we see a bit of time here. The red is larger time. They're spending more time away from the patient in the control room. Since we implemented this technology that we can set up all the scans next to the patient, what we're seeing is that the clinicians can spend much more time right next to the patient and just step out for the time that the scan's actually taken. And for pediatric imaging, this is a really important step because it enables them to spend much more time on the care of that patient. So here's a couple of examples. This is a pediatric CT scan with a cardiac donor heart from an adult. This is tricky. You've got an average heart rate close to 90. You also have patients that are small. The structures are small, so you need a very high spatial resolution. And what we see here is really crisp, clear images of the coronary arteries and all of the surrounding vessels. So really superb imaging for this child. Another example with higher spatial resolution. So this is a 15-year-old child. This is conventional CT on the left. It's not a bad CT scan at all. On the right, we see just much sharper images of the lung at around half the dose that was used for the image on the left. So really big implications for patients.
and also speed is important. So for a child's chest, we're now well under a second in acquiring these images, and the table moves particularly quickly. And I've seen it quite a few times when we use this flash spiral mode, which is it can scan an adult chest in well under a second. That for a child, when the table moves, it moves so fast they tend to just stop for sort of half a second, and that's enough for the CT scanner to have scanned through the heart. So here we see a particularly low dose system. It's on a very small child. Beautiful VRT images of the lung, and a great example of the impact for imaging on small children. This is an area where, when I was working in CT, it was a major problem. So these are the temporal bones of the inner ear, so the three smallest bones in the body, and one of the most difficult areas to image because they are so small and we need such intense spatial resolution. And when this system first started coming to market, there's a lot of beautiful colour images, there's great images of the heart, but when I saw the images of the inner ear, this was where it really hit home to me that spatial resolution was going to make a massive difference. So these tiny bones in this part of the inner ear, this is on a 1-year-old patient. This is a relatively low dose scan, but really exceptional imaging of the inner ear, which is not possible with conventional CT. Also for implants in the inner ear. So here's a cochlear implant on a child, and again, due to the way the photon counting CT deals with metal artifacts and the spatial resolution that you can get in the image, we get really crisp images of these implants in all planes. And again, it can really positively affect the management of these patients with cochlear implants. So there's a lot in the paediatric side of things that we're doing. If you're interested in looking at our focus on paediatric imaging, the QR code will take you there. This was done, as I understand it, by a son or daughter of one of our employees who was happy with what their dad was doing at work. Okay, so just to sum up, right, photon counting, it's a radically new approach to CT, and I think it's important to note that this is not just a next small increment in CT imaging. This is a leap forward like we've not had in many, many years, and it was shown up most with the FDA when they approved the first system from our company. They made a press release about the impact of this technology, so we're really proud of what's happened. We're really proud of the way we're able to get better spatial resolution without impacts to the patient from a dose perspective, the way we're able to now look into coronary areas where we just simply cannot before with cardiac CT, saving that patient from other forms of imaging. But we have a wider vision for photon counting CT. So we would like to see that by 2040 every CT would be a photon counting CT, because the impact of this technology we see is significant. We're going to be working hard as a company to bring down the cost. At the moment, the costs of these detectors are incredibly expensive. We're building new facilities to manufacture these at lower costs. So we do believe that this will roll through all of CT within about the next 15 to 20 years. And I think the impact on patients for that happening are going to be significant. So currently there's only limited access to photon counting CT, but we have also released 2 new systems, so we're starting to see this impact come through. And it's not just patients I don't know who've had an impact from cardiac CT. This is me, because I was planning on getting into some more rigorous exercise, and I was pushing 50. So I visited one of our sites down at the South Australia Medical Research Institute and had my heart scanned on a Naotom Alpha at low dose with, I think, beautiful images, and they gave me the all clear to keep exercising. So I'd like to thank you all for listening to this and the opportunity to speak. We do really appreciate being part of this meeting. We hope that gave you a good introduction about photon counting CT and its impact to patients, and if you have any questions, I'd be happy to take them. Okay. Thank you, folks. Enjoy the rest of the meeting.
Good evening. I request everybody to please take their seats. We'll be starting shortly. Thank you. Good evening, everyone. Welcome to this session on youth voices in the fight against non-communicable diseases, co-organized by UNICEF and Hriday. My name is Radhika Srivastav. I'm the Senior Director at Hriday, which is also the Secretariat of the Healthy India Alliance, which is the India NCD Alliance. It is my absolute privilege to moderate this session powered by the energy and commitment of our young NCD advocates. NCDs are a significant global health challenge, disproportionately affecting young people. The global narrative and response to NCDs is skewed towards adult populations, with limited focus on care and management of childhood onset NCDs. Any comprehensive action on NCDs is incomplete without meaningful involvement of young people. Nothing for us without us. The Kigali Youth Declaration, co-created by youth health champions at the Global NCD Alliance Forum in Kigali earlier this year, underscores the urgency of addressing youth concerns and taking action against NCDs, including mental health conditions. This session aims to present the Kigali Youth Declaration to a broader audience and perspectives of the young people in the context of non-communicable diseases. The session will motivate participants, hopefully, to advocate for inclusion of youth expertise and perspectives in NCD policies at the upcoming UN high-level meeting on NCDs and mental health. I would like to introduce to you the chair and panelists of this session. We have a vibrant youth-led panel. Either they are young by age or they work towards empowering youth, who may not be so young, but do work with young people. So to get things started, I'd like to invite Renee Ekpini, Regional Advisor Health, UNICEF Regional Office for Southeast Asia, Nepal. Thank you.
Thank you.
Thank you. Yes. Oops. I'd also like to invite our presenters and panelists. Shitanshu Dhakal, mental health advocate from Nepal. Welcome, Shitanshu. Nomika Khanna, NCD advocate from India. Saburi Chopra, NCD leader from India. While we wait for the representative from the government of Bhutan, I'd like to invite Princess Padmaja Kumari Parmar. My apologies. I'll finish with the introduction. Princess Padmaja Kumari Parmar from Friends of Mewar, and Hari Prasad Pokhrel, who's the Program Manager, Nutrition Programs, NCD Division, Department of Public Health, Ministry of Health, Bhutan. Ariana Raitsima, Health Specialist, UNICEF Regional Office for South Asia, Nepal. And Georgia Varisco, Chief of YUVA, Youth and Adolescent Development, UNICEF, India. Welcome, everyone. I would now like to hand over to the chair of the session, Renee, to provide an overview of the session and the objectives.
Thank you very much.
Yes, sir. Mike, yes, please.
Okay, I'm not going to give a speech here. I think I'm very happy, very delighted to be part of this conversation this afternoon. And I would like to welcome you all to this very important session here. The session, it's about youth, but it goes beyond youth. It's about the voices of the youth. It's about how the youth could actually contribute to the fight against non-communicable diseases. So it's my pleasure to chair this session, which is being organized in close collaboration with Hariday. And I would like to acknowledge this partnership, which has been very important for us, UNICEF in the region, to move this agenda forward. Non-communicable diseases are often referred to as the invisible epidemics. Is one of the main public health challenges that we are facing currently, particularly for the youth in this region and in fact across the world. Princess was in Kigali, where you had the opportunity to meet with the youth coming from all over the world. If you look at the data and look at the burden of NCDs in terms of contribution to the overall mortality, it's about 71%. But the recent data at our level we have been looking at, on the average, you look at, for example, in South Asia, it's around 60%, which is a lot. The current context in terms of the health agenda is how best we can make sure that we achieve results when it comes to what is being seen as the unfinished agenda around the infectious diseases, like the vaccine preventable diseases, but also more importantly, how we collectively can make sure that we address what we see as the emerging challenges. So there is clearly an urgency for us to take action. Most of the time, I have been working in public health for more than 30 years. And most of the time, we forget that what we are doing is not about numbers. It's not about graphs. It's not about PowerPoint presentation. It's about human being. It's about lives. Before I get to the objective of this session, I would like to share with you a personal story. My youngest daughter, she's currently about 50 years old. She has a kid who has autism. This has been a long journey. I am a doctor, pediatrician. I have been in this journey with her. The day this, I don't want to give the name here, but came to the world. They live in the US, a very long one. What I have seen is supporting my nephew require a lot of love, require courage, require strength. There are moments of doubt, there are moments of questioning, but there are also moments of hope when you have the family, when you have the community supporting. And it might be good to disconnect a bit about this environment and think of children, think of young people who are actually fighting these diseases and how best collectively we can support. Supporting is not only about for us attending meetings and conferences and having speeches, it's about how we can support them themselves to take action, to be empowered, to be at the front line. And this is why this session, which is about hearing their voices, is very important. There is a famous writer, I'm Francophone in French, that he wrote that he would like to be the voice of those that do not have a voice. I would say let's empower the youth to be the voice of their own voice. This session has 4 main objectives. First of all, and as rightly pointed out, is a follow-up action of the declaration that we have on NCDs, particularly for the youth, when it comes about fighting the non-communicable diseases. This was a great opportunity. And for us moving forward, particularly in this region, one is to use this opportunity to highlight the importance of the youth leadership tackling NCDs, and also as part of it, mental health, which is also one of the rising challenges we are facing here. Number 2 is to share the key points and recommendations of the declaration of Kigali. I'm referring to Youth Declaration of Kigali. So for us, sharing this declaration, sharing the recommendation, and having reflection on how together we can translate this into action and take it forward to the next high-level event that is happening very soon. It's also very important. And I think the note I have, it's about motivating participants, but we should motivate ourselves to make sure that we really, in a very practical way, engage the youth in this fight on a daily basis. Their voice is very important. The action is the one that we should actually support. And finally, it's very important to move from here, from what we'll be discussing, and make sure that we take this forward. And I'm referring to how we can use this opportunity to strengthen collaboration, to strengthen partnership between youth, but also linking with government, civil society, philanthropics, and broader stakeholders. I'm talking too much, but let me now turn towards the panelists here. We are very privileged to have the insight and for them to share their experience, and sometimes it's personal experience that they will be sharing with us. And extend also my warm welcome to the moderator, Radhika. Thank you very much for serving as a moderator for this session. And thank you to all the panelists. Let me go to the list of panelists here, and pardon me if the pronunciation is not exactly right, but Shitanshu Dakal, thank you for joining. Namika Kana, thank you, I got it right. Saburi Chopra, thank you. Hari Prasad Pukhrel, thank you. Princess Padaja Kumari, this is the second time you're meeting today. Yes. So bridging youth with communities. And thank you very much for our young advocates raising the importance of making sure that youth action, youth voices is part of the overall community response. And finally, Ariane, I should list you too, and Georgia Varisco, so UNICEF family from the regional office and the country office here. So I'll stop here. I have no doubt that this moment will be very important in terms of sharing our experience, but also agreeing on how best we can move this forward, the conversation here, and stay as key members of this fight. And what I would like to say is it should go beyond meetings, should go beyond conferences, making sure that we bring it home. Every person, every community member we're meeting, we should actually tell him that we have all to fight together against NCDs among the youth. Thank you. I'll stop here, and you have the floor.
Right. Thank you so much, Renee. Not just speaking from the UNICEF perspective, but also sharing your personal story, which is so powerful. So thank you so much for that. We now move to Ariana. Ariana, you've been working with young people for several years now. You have also been involved in the co-creation of the Kigali Youth Declaration. So we'd be very delighted if you could share with us about UNICEF's regional priorities on NCDs and mental health, and what is UNICEF's vision to amplify action on youth leadership for NCD action. Over to you.
Thank you, Radhika. Just for the people standing there, there's plenty chairs here, and we do not bite. So welcome, very welcome. I'll share the strategy, well, the interventions that UNICEF as a region envisions. The theme of this meeting is scaling access to ensure health equity, and that's exactly what UNICEF is supporting. It's UNICEF's agenda. Historically, we focused on communicable diseases, pneumonia, diarrhea, but increasingly, we realized that we have achieved a lot of progress there, and what is lacking behind is non-communicable diseases. NCDs is a big umbrella for many diseases and conditions, and we even like to call it NCDI, non-communicable diseases and injuries, and we also add mental health under the same umbrella. So there are different work streams under this big umbrella. So these conditions, many are rare, fortunately, although not as rare as you think. So we talk about severe childhood onset NCDs like type 1 diabetes in children, congenital heart disease, rheumatic heart disease, blood disorders, and also mental health conditions in children, like the example Renee gave of autism. So to achieve universal health coverage, children living with these conditions must have access to treatment and care. And that is what we are working on. And we have identified 5 pillars. The first one is policy and governance. So we advocate and support governments to include childhood NCDs in child policies and frameworks. Children are often absent in NCD policy and guidelines and mental health policy and guidelines. The second pillar is integrate services for decentralized care of severe and chronic NCDs. So as of now, in many situations, children with severe chronic diseases have to travel to a tertiary hospital, and we support implementation of PEN+, that's a WHO model that addresses severe childhood onset NCDs, and the model tries to bring care and treatment as close to the people as possible. So currently in most countries, that's a district hospital. In some countries like Bangladesh, they try to bring it a level down. Quality of care, of course, has to be ensured. The third pillar is strengthen community engagement and social behavioral change. These children, when they are diagnosed and under treatment, they need to go back to the community, and there is often a stigma. They need support. They go back to school. Imagine if you have type 1 and you need insulin, your environment needs to know, needs to handle that. Any other condition that you have, the environment needs to know and support, and not look at you as a special child. Digital tools is another pillar to inform health systems and also improve patient experience. But Maja was talking in another panel yesterday about her pump, and she said, if it bleeps, it's not my phone, it's my pump. So there are many technologies that will not, that can help improve patients' lives. Another pillar is health financing. Of course, these models, treatment and care do not come for free. It costs money, so it needs advocacy, it needs showing governments how much this actually costs, but we need to look for opportunities and pathways to fill the UHC gap for NCDs. And lastly, UNICEF also supports implementation research to improve models for NCD care delivery for childhood. So that is a lot of focus on children born with childhood onset NCDs. The second work stream is prevention. Prevention of adult NCDs, hypertension, diabetes type 2, cardiovascular diseases, often starts when people have already developed bad habits. So it's our mission to start prevention much earlier in schools with promoting physical exercise, healthy lifestyles, to work on healthy food environments with our colleagues from the nutrition team. And again, the SBC, social behavioral change component, is important there. Then mental health, which we put under the same umbrella, but has, again, some different approaches. UNICEF and WHO have developed guidelines, service guidelines, training modules, programs. I support my friends, helping adolescents thrive. It is a big problem in the region. Suicide among young people is among the top causes of mortality in this region. So what we do is roll out these models, these training, and I support my friends and try to embed that in existing policies. So not make it a project, but talk to ministries of education and say, look, this is the problem, it's really important. Can it be included in the curriculum? And the same pillars, as I mentioned, for childhood onset NCDs like cardiovascular diseases and etc., diabetes type 1, apply to mental health. So it's important that young people's mental health is included in policies and guidelines, integrated in services. We have adolescent-friendly services. We know what to do with children with behavioral issues. The community is also very important, and stigma, and the colleagues will talk about that. It of course needs financing, and lastly implementation research. So we look for partnerships with the private sector, with other agencies, and we try to listen to what young people want, and that's why I want to thank Saburi and Shitanshu and Naumika for having prepared this session together, and before that, having been very active in the Kigali conference that you will hear more about. Thank you.
Thank you. Thank you so much, Ariana. And we acknowledge that UNICEF has been such a strong partner and a friend to all the young people. And on behalf of all the youth leaders, we are very, very grateful for UNICEF's support. So thank you so much. Moving now to the most important stakeholders in this room, our youth advocates, Shitanshu, Saburi, and Naumika. They will provide you a snapshot of the Kigali Youth Declaration, which you've been hearing about again and again, and of course, what is its relevance for national, regional, and global NCD and mental health agenda. Young ladies, over to you.
Thank you. Thank you, Renee, Ariane, and Radhika. Namaste, everyone. This is Shitanshu Dhakal from Nepal.
And I am Saburi Chopra from India. We are here to walk you through the Kigali Youth Declaration from the Global NCD Alliance Forum 2025.
The Global NCD Alliance Forum 2025, held in Kigali, Rwanda, convened over 700 delegates from 66 countries. This forum served as a platform for strategizing and uniting efforts ahead of the UN high-level meeting on NCDs and mental health. A significant outcome of this gathering was the launch of the Kigali Youth Declaration, emphasizing the importance of integrating youth perspectives into global NCD and mental health strategies.
60 youth from 42 countries came together in the Global NCDA Forum 2025, where we co-created and launched the Kigali Youth Declaration, the representation of youth voices for a call to action on NCDs and mental health. We had been working on this Kigali Youth Declaration since November of 2024 through multiple online meetings.
Now we shall take you through our journey via snapshots and videos of the NCDA Forum.
The Kigali Youth Declaration is a pivotal document crafted by young leaders from over 40 countries during the Global NCD Alliance Forum, held in Kigali, Rwanda in February of 13 to 15 of 2025. This declaration underscores the critical role of youth in addressing non-communicable diseases and mental health challenges globally.
This Kigali Youth Declaration, it was born out of the hopes and determinations of young people and young leaders. This was crafted not just as a document, but as a need for equity, a call for action, through multiple meetings involving the youth to address the urgency of NCDs and mental health challenges, which are the heart of this global movement. Through this, the unwavering role of youth is powerfully expressed.
The Kigali Youth Declaration aligns with global efforts to combat NCDs and improve mental health by emphasizing the inclusion of youth perspectives. It addresses gaps in current health strategies and advocates for policies that are more representative and effective. This approach is particularly pertinent in low and middle income countries where young people bear a significant portion of the NCD burden.
So, the Kigali Youth. The Kigali Youth it's not working. It is working. Okay. Okay. The Kigali Youth Declaration was co-created by young people in the global NCD community, highlighting the urgency of addressing the youthful concerns by taking the action against NCDs, including that of mental health. And to start with, I will be making you very much acquainted with an acronym that was very famous, that is LEAD. So, herein, L stands for leveraging investments for a healthier future. E stands for enforcing policies to prioritize prevention. Then, A stands for advancing accountability and institutionalization of youth participation. And D means driving change through collaboration and community engagement.
This Kigali Youth Declaration holds particular significance in our Southeast Asia region, the most populous region globally, which is home to over 26% of the world's youths. This region also bears one of the highest burden of NCDs among both adults and young people, with many countries categorized as low and middle income. Given these dynamics, action in Southeast Asia region is not just regional, it's global. Meaningful youth engagement here can significantly shift the trajectory of NCD and mental health worldwide. This Kigali Youth Declaration, it directly complements WHO and UNICEF's regional priorities, which emphasize mental health, prevention of NCDs from early life stages, and youth-centered healthcare system. It calls for integrated youth-led solutions that are rooted in community realities and designed for a lasting impact.
We must ask ourselves, why is it essential to meaningfully engage children, adolescents, and youth with lived experiences of NCDs and mental health conditions? Because these are the voices that bring unparalleled insight into what it means to grow up navigating the health system that don't often reflect the specific realities of young people. The current systems, while evolving, have traditionally been more adult-centric. Yet young people are often the ones who live with these conditions for the longest span of their lives. The Kigali Youth Declaration recognizes this. It doesn't just mention the importance of youth participation, it places it at the heart of the solution. while the declaration rightly highlights prevention, it also calls attention to the need for accessible, youth-friendly services. This was echoed in conversation during the Kigali Forum, where a key gap emerged: the underrepresentation of youth with lived experience in decision making. Their contributions go beyond personal stories. They offer practical insights that can shape systems to be more relevant, empathetic, and effective. The declaration calls for institutional mechanisms that ensure that our voices are not just heard, but integrated into the very processes that shape health responses. It acknowledges that our leadership is not a token gesture. It is essential to designing systems that are inclusive, grounded in reality, and capable of a lasting impact. Thank you.
Since we've been talking about non-communicable diseases and mental health with young people at the center of it, so now it is a question time for the audience. I will pose a question to the audience regarding the same topic, and anybody who knows the answer or wishes to volunteer to answer should raise your hand, and we will take 2 answers from among those who raised their hands. And I highly request our audience to please participate in this and support the young people and their voices in their fight against NCDs and mental health challenges. Okay, so the first question, it's already been displayed, is what are the small actions youth can take to promote mental health in their communities? Any volunteers? Okay, yes, please.
Hello. So youth can make the people and their communities aware about the stigma and the myths associated with mental health and mental health diseases. So that's the one thing that youth can really do.
Thank you. Yes, please.
So hi everyone. As a person living with type 1 diabetes, I've been living with this condition from the last 10 years, and I very well understand the importance of having, mental health support. When I was diagnosed, I'm not ashamed to share that I fell into depression, and for 2 years I had no one until and unless I found a community in diabetes, and that's where I learned that, youth can really connect with each other. Once you meet someone with whom you can relate with whom your story can resonate with, that's where the support and change happens. And that's what I'm trying to do through a diabetes support system through my NGO to help people and connect with youth.
Thank you so much.
Thank you so much. Thank you for sharing your story. And when you talk about collaboration and connections, I think that is what all of us at the Kigali Forum realized the importance of. So our next question, very quickly, is that if you could design a program to support children with NCDs, what do you include in it? What would it include?
Okay, so hi everyone. So if I had to decide or design certain programs, so it would firstly include the communication effort to make things at ease, at comfort. The second would be the method of remedy, that what solution we can provide. The third bit would be, of course, the family engagement and the nearby engagement. It can be a family, people in relation or people in surrounding, so that they get a comforting environment to survive, because they are children. It would impact their mental health if they have uncomfortable situation. So this 3 would be a primary thing, and then of course there would be other steps to be taken care of, which would be other stakeholders, which can directly indirectly lead to any action or non-action. Yeah.
Thank you.
It's hard to build on Kartik, but I'm going to design, I would put the child at the center, not the disease. And it would be about everything a child needs, including the child.
Thank you, Cynthia. Thank you, dear audience, for your participation. Now I would like to hand over this podium to Radhika.
Thank you.
Thank you so much, Nomika, Shitanshu, and Saburi. I don't know if we have much to say beyond this, but yes, we do have some time in our session, and we have other resource persons, so we will definitely move on. We will now start with our panel discussion. Our focus has been on promoting an intergenerational approach. This is something which we acknowledged in Kigali, where we bring this intergenerational knowledge and skill exchange, where we acknowledge the fact that the older experts have much to learn from the younger experts and vice versa. So it is not that one is a student and the other is a teacher. Everyone is a student here. So with that in mind, we have a short panel discussion where each of these panelists will provide insights into some of the key domains that you have heard about till now. So we'll start first with Nomika. Nomika, as a young person with a lived experience, what motivates you to be a strong advocate for NCD prevention and control, and also for mental health?
Yes, wonderful question, Radhika. And as a strong NCD advocate, I feel that living with I would say that getting the diagnosis of NCD, I've been through many NCDs. For example, diabetes and epilepsy, and even neurosurgery and hypothyroidism at various points of my life. And each diagnosis added a new medical label in my life. And I feel that by the amplification and the leveraging investments and disseminating and collaboration, as one of the buddies mentioned here, that I formed something, and one of you mentioned here that by taking caregivers into consideration along with the patients, and there Slivia mentioned there, I hope I'm pronouncing your name right, that taking the center not on the patient but on who the person is. That I feel that is a better thing.
Thank you, Nomika.
And I do feel that as long as NCD prevention is concerned, we can also take into account various other considerations, for example, mental health. All of these things, for example, type 1 diabetes comes into consideration with the diabetic distress. As Seema ma'am mentioned in some of the previous ones, that I feel like it's going out of control, and I also discussed it with her. So yes, at times, since I'm a person living with type 1 diabetes, I do feel that many a times things get out of control of your hands. And that is why mental health should definitely be considered as a component in your life. That's it.
Do you want to share your PPT now?
Oh yeah, definitely.
Okay. Oh. Okay, so there's a bit of a technical issue. We'll come back to it shortly. Thank you so much, Nomika. Padmaja ji, we'll move to you. Given the experience that you have as a person living with, as well as someone who works with communities, why do you feel it is important to engage young people living with NCDs if the needle on NCD action needs to be moved? And it's not just about talking the talk, but walking the walk. So how do we make meaningful engagement of people with lived experience a reality, and what are perhaps some of the challenges that you see, and how can they be overcome? Thank you.
Good evening. Am I audible? Yes. Yeah? Okay. Good evening to everyone. Big thanks to Hriday and UNICEF for having me here, and having me here in my capacity of lived experience. I've lived with type 1 diabetes for the last 40 years. What's most heartwarming for me in this panel is to not just be around all my fellow panelists who are very inspiring themselves, but to see all of you here. What a diverse group of people. We have industry here, thank you. We have organizations and international institutions, thank you. We have young people. I mean, all of you are here because you want to make a change and you want to make a difference. And that really motivates people like me to be able to do that. So as far as not taking an action is not an option for me. Having said that, to come back to your question, Radhika, I think I want to focus on what Saburi mentioned earlier. The reason to have people like ourselves who have lived experience is not just because of our personal stories. I can sit here and give you 8 hours worth of stories of what happened just yesterday. As Ariana was saying, my pump was beeping and all of that. It's fine, it's good, it'll make 5 minutes of good conversation, but that's not what drives me. The reason I'm here is to be able to add that part of the personal story with something practical. So some other child doesn't have to die, right? They don't have to not wake up from a hypoglycemia. I'm here to be able to put those aspects together. I can't do it without you. I can't do it without the industry. I can't do it without institutions who have louder voices than I do. I can't do it without my fellow panelists who are here. So I thank you for giving me this opportunity, but I also do hope, which I've been asking for any other platforms that I get invited on, that please leave from here today with some call of action that speaks to you, something that you want to do. There's a lot of stigma around type 1 diabetes. We're not disqualifiers, we're not outliers. As a matter of fact, we are Olympians, we're mothers, we're engineers, we're good solid people, we're friends. So get out there and say one thing that would help remove one myth around type 1 diabetes. Whatever that comes to your mind, something that drives you to be able to penetrate and impact someone else. I had a couple of other notes, but I do feel that the youth that went before me has done such a phenomenal job, and while I still have your attention, I should pass it on to the next panelist.
Thank you so much. To Mr. Hari Prasad Pokhrel, you represent the policy side of things, like being a government representative. So how do you think policymakers can leverage the potential of youth and support to advance their priorities and needs towards NCDs and mental health? And any examples that you would like to share? Thank you.
Thank you. I think that's a very important question. So I'll just put in perspective from what we are doing in Bhutan. So NCD, like any other country, we are also facing this increasing burden of non-communicable disease in the country, be it mental health or other typical non-communicable diseases. So we try to engage youth, we empower them, provide training, we include them when we are doing these training materials. So this is how we try to include them, and then we have a holistic policy which says that we should look at health through the life course approach. So meaning that we have to have interventions from before they are born to childhood, to adolescent, to adulthood and elderly. So just to give an example, recently we were doing this standard key messages for adolescents, youth and adolescents. So why we are doing this is because there is an infodemic. So there is a lot of information in the internet, and youth, adolescent, they have access to all this information. Some of them may be incorrect. So what we are doing is trying to have this standard key messages, trying to standardize the messages. If somebody is advocating for diabetes, what would be the message? So that's across the country, we speak the same language, use the same message. If you are trying to talk about hypertension, we use the same key message. So what we did is we have what is called as the Y peer network. Basically it is the youth peer network, and they have representation in schools, in the universities, technical training institutes. So we, a team of led by the Ministry of Health, from the various colleges and institutions, these youth participants were invited, and then like the key messages were developed. We asked them, what kind of messages do you want? And then we let them design their own infograph. We do not lead them. So they design in a way which youth can understand and advocate. And then like finally, when this is, we are still in the middle of the work. So when this is finalized and endorsed, So this will be shared through the various social media platforms, because youth have access to all the social media platforms, and we try to reach out through the youth using the social media platforms, using their networks, and then like they deliver the same message to the community, to the population, to their relatives. In Bhutan, we are very small, just 700,000 people, and basically everybody is related in some way or the other. So basically everybody knows everybody. So we are a very small community, and then try to standardize the messages so that we speak the same language across the country. So this is how we are trying to empower our youth and adolescent through the enabling policies. Thank you.
Thank you so much. And you know, it's commendable what from the government side you're doing to engage young people and you know, help engaging them in co-creating health promotion messages. So congratulations on that. Coming back to UNICEF, Georgia, you are the chief of Yuva, and perhaps you know, covering a population of young people which is comparable to no other nation. What do you think you know, UNICEF's vision to amplify youth voices on NCD action? And please also share a little bit about, you know, moving from grassroots to global. So it's not just meetings like this where a privileged few of us can come and discuss and feel inspired. How do we take these messages to the grassroots and of course then make a global impact as well?
Great. Thank you very much for your question. Thank you for having me here. It's a pleasure. And I'm really speaking as a believer in the power of youth to really change the trajectory of our global future. For now, I think we're all in agreement that NCD is no longer an issue that affects adulthood. It's very much an issue where young people can play and are already playing an important role. I was listening to the session earlier, and I heard Kartik talk about his vision and how young people are making change. And he spoke about the fact that young people, wherever they are already making change and are making change and impact in their communities. So I think the question here is how we can support young people bringing that change at a global scale. There's been really good example. An example from UNICEF Indonesia has been around working with young people, building their capacity to advocate for young people. And they've used this opportunity to really look and address the issues related to smoke-free areas. And then as a result of the work done together, they've gone out of their way to really advocate with the government to promote and campaign for smoke-free areas, which led to, I think, 326 out of 514 districts nationwide to have established local regulations for smoke-free areas. So this is really an example as to how when engaging young people in a meaningful way and in something that matters to them, change can happen. At UNICEF, I could say that we have a three-pronged strategy. The first one is really putting young people at the forefront, I think, of awareness and mobilization. They have the reach, and they have a reach that we would never have, whether it is within their families, within their communities. So how we can work together with young people to help them reach at scale in their community. The second, I think, you know, young people are digital natives, and how we can support young people to further explore youth-led innovation that can have impact globally. So this is another great area where we're seeing a lot of innovations happening, whether it's going from AI solutions to early diagnosis. These are innovations that are coming from young people, many of them who are experiencing themselves, that have lived through experiences, as you said. And the third part is really around youth-led advocacy and how we can, whether it is on the streets, in campus, in the digital campaign area, how we can really support the young people to have their voices raised and be advocates that are being listened to, putting youth issues at the forefront of agendas. We've seen the Kigali Declaration. I think this is a really good example of young people coming together and saying, we have a voice, we understand the issue, and this is where we feel that we can contribute to the issue. I would definitely encourage everybody to have a chance to read it and also to endorse this declaration. I went on there yesterday, and I think 273 people have endorsed it. I think we can do better. I think we can do more. And I would really encourage you all, if you really do believe that young people can play a role in this, this is a great starting point. So read it, endorse it. And I would also encourage everybody to start taking action. Start taking action. Tell your stories. Tell us where you are making impact. And I think from UNICEF, we are really here to support having your voices elevated and really helping you amplify reach so we can reach that scalable impact. Thank you.
Thank you. Thank you so much, Georgian, for that call out to endorse the Kigali Youth Statement. Our team is circulating the QR codes. You saw it on your screen. If you don't have Wi-Fi access right now, there's a copy of the Kigali Youth Statement at the back on the table. Please feel free to read it, and we hope that these numbers will amplify. Shitanshu, coming back to you, everyone's talking about the Kigali Youth Statement. You, as a representative of the 60 youth who were there at Kigali, what are your plans to amplify and operationalize the Kigali Youth Declaration? And what is your long-term vision to strengthen a coordinated youth-led response to NCDs and mental health? So it's not just about getting more and more people to endorse. What according to you, means to meaningfully endorse the statement? Over to you.
Thank you, Radhika, for this question. So as a medical graduate and UNICEF mental health youth advocate from Nepal, my commitment in amplifying and operationalizing this Kigali Youth Declaration deeply lies in my clinical understanding and grassroots of my advocacy experience. So first, I believe in bringing the declaration home and translating the global goals into locally relevant actions. I aim to and I expect to get support to work with youth networks, to work with medical students, community health workers, to raise awareness about this declaration and to integrate its recommendations into youth-led community projects, particularly around mental health literacy, school-based interventions, and early screening for NCDs. Secondly, operationalizing the Kigali Youth Declaration means building the capacity of young people. We need to equip young people not just with passion, but we need to empower them with tools of leadership, persuasive communication, knowledge, and involve them in decision making. Through platforms like UNICEF, Toastmasters, and medical associations, I aim to train young people in advocacy, storytelling, leadership, and communication so that us young people, we are able to speak not just from our emotions, but also with impact. And this is particularly important in advancing mental health, especially in countries where mental health is underfunded and misunderstood. Now, thirdly, talking about youth-led research and policy engagement. So as young people, we need to move from being the participants to becoming the co-creators of the solution. I aim to champion and co-create youth-led research on the intersection of mental health and NCD in undeserved areas like rural Nepal, where, if we can do that, then we'll be able to create a concrete data with which we can further proceed our advocacy for policy reforms at global and national level, and also about targeting on investments. But this can only be done when we have active support from our stakeholders, policymakers, institutions, and all other people who can help us and keep us going in this youth-led engagement and research. Fourth thing, and one of the most important things, is a sustained global network
So sustaining a global youth response like the one we saw in Kigali is very, very crucial. And continuing that, not just on a global level, but also at regional level like in Southeast Asia, where the youth population is very huge and the burden of NCDs and mental health is very high, is really, really important. So once we're able to do that, we should be committed to cross-border collaborations, to regular follow-ups, and leveraging the digital platforms to share our stories, to share our advocacies, and to share resources. The Kigali Youth Statement should not just be limited as a statement on paper, but it should translate and it should live through actions in every corner of the world. And fifth and the most important point, accountability and inclusion. So none of these matters if we do not have accountability and inclusion. The voices of young people must not just be heard, but it should also be considered and taken into decision making. This way, I would want to advocate for including youth voices in policy making, in regular tracking of the progress of this Kigali Youth Declaration, and to include the marginalized voices. That include voices of girls, voices of indigenous groups, and most importantly, the voices of people living with chronic mental and physical health conditions. So Kigali Youth Declaration, it is not the finish point, it is not the end line, it is just a starting point. And our generation, we have the knowledge, we have the tools, and we have a global network to drive and lead that transformative response to NCDs. And I am fully committed to supporting it, not just locally and nationally, but also regionally and globally. So thank you. Over to you.
I think we already have a young decision maker in the making. So yeah, I hope you get on the seat of power very, very soon. So all the best, Shitanshu. So we want to circle back to Nomika. Nomika, you wanted to share your story. So that's now ready. We had a technical glitch earlier, but you can, yeah, it's ready now.
Okay. So,
go ahead.
Okay. As a child with NCD and a lover of dolls, I used to worry more about packing my glucose strips than dressing up my dolls. Moreover, while my friends played with the toys, I was learning how to cope with those hypoglycemic and hyperglycemic situations. I believe that childhood should not come with syringes and size. Rather, it should come with inclusion and equity. In lieu of that, I have written a poem. I think you're presenting, Versa? Yeah. So, through storms and silence, we found our flame. Okay, let me just open this up in a better manner. With hope in hand, no longer tame, we rose from scars with voices strong to lead the truth where we belong. So here is now at UN HLM 4 and see the youth we are and who we chose to be. They are not just youth lived experiences in old hospital reports, but hearts that speak at global courts. We rise anew, not torn apart, but born again with a braver heart. The storms, they were truly loud, but they made us see that they woke the power in you, us, and me, and everybody around. Thank you.
Thank you so much, Nomika, for those powerful words. We now kept some time in the audience. Our youth delegates decided that we wanted to save some time and put everyone on the spot and ask pertinent questions around youth engagement. This is an open house. This is actually an organic part of this session because we didn't want it to be scripted. We do have the session to be formally closed, but we wanted to ask the audience if you would like to share, whether you come from a civil society organization, or whether you're a youth advocate, a lived experience advocate, a representative of the private sector, how do you think you can work with young people? If you don't, when we are particularly asking those partners who have not yet actively worked with young people, and the intent is that if we have through this session sown a seed of maybe you trying to think in that direction, the objective, the short-term objective of this session is achieved. So anybody in the audience would like to share their thoughts and comments? Yes, Divakar. And we'd also like the older people to also, so the not so young experts, the not so young experts.
I got
yes,
it.
Yes, yes. So yeah, you fit the bill, Divakar.
Thank
yes.
you. No, so very inspiring subject, of course, and I couldn't stop myself sharing a little story about me. So hello, my name is Divakar Mittal. I work for a company called Novo Nordisk, and I take care of corporate affairs for India. So I'm a single parent, and I have an amazing son who is 13, and he has a condition called autism. When he was 2.5, we discovered this, and initially I didn't accept it as a father, and I'm a corporate guy, always traveling, working around the world. But slowly, it was very complicated for me. During COVID, I lost my wife, who was very young that time, and I became a single parent actually, and I had to take care of him. So I was on my own. What happened is I was in a social experimentation in Washington State University, and for few days, for parents who have autistic child, they were brought together. And while we were discussing various aspects of life, one of the evening I discovered through the person who was doing something really striking. And we discovered that special child are born only to special parents. So that's something triggered me so much that the whole perspective which I was carrying with me changed into a mission. So that's my personal story. And of course, after that, I kind of started having a different view. So what I want to suggest, based on my experience of living with my son, who lives in Gurgaon, in a very nice school, which is meant for such kids in a very holistic manner. They are trained, they are coached, they have independent, coaches, and he's doing so well. He's a runner, he does cycling,
Wonderful.
he's swimming and everything. So what I've learned is, and this is my suggestion to the youth, is talk your heart out, because in our community, in our country especially, we don't speak up. We tend to suppress ourselves, maybe because our society is changing, etc. So that's something which I've learned and which I tell everyone. Second thing is, what I'm realizing, school health is very important. Intervention in school health is very, very critical. And we at Novo Nordisk, we are strongly advocating that aspect, that how do we get inside the school, and how do we train, how do we coach, how do we create that environment right from the beginning, when the character is forming of the kid or the youth, they start seeing health as a choice, not just as a chance. So these are some of my things which I want to share.
Thank you so much for sharing this story. Yes, Anika. Yeah. Anika, we'll go to Anika first and then come back. Yeah. There, Saurabh.
Hi, thank you so much, Radhika. And thank you to all of you for sharing such inspirational stories. It's really nice to see you guys in action. My name is Anika Singh. I'm a social artist. I work with arts for public health and social change messaging. And I represent my organization, Voice with a Y, which stands for Vision Opportunities for Youth and Community Empowerment. I also run a foundation called Returning to Love, where we create safe spaces for people to come together and express themselves through arts, through performing arts and visual arts. So my message and wish and hope to find partners here in this audience is, I really believe in the transformative power of arts for public health, messaging for mental health. We've developed models, and I really want to take this forward, this vision of how we can actually not just change behaviors, but transform behaviors of people around NCDs, around mental health. So, our logo for Returning to Love has a butterfly. So what does a butterfly represent? It's like when you cannot go back to being a caterpillar. That's what transformative behavior means. When you cannot go back to, there is no other way then. So, for me, it's more like an appeal here that let's do something together. I have a lot of ideas of, working with dance, with theater, with music, through films, and I would love to have more people as part of the team.
Thanks.
Thank you.
Sir, please go ahead. Here, okay. Sorry, we'll come back.
You can take this.
Okay. So yeah, he's on the other side, so I wanted him to hear him.
All right, thank you. Yeah. I don't know which side, but
Sir, the expert side.
I'll take that. Okay. My name is Ram Krishna. I'm from this organization called Samatvam from Bangalore. We support hundreds of children with diabetes. Okay. So firstly, all the young people in the room and not so young, congratulations. It's been a fantastic experience listening to all of you here. My story really is that my son was diagnosed as T1D at the age of 2.5. So that was all of about 27 years ago. Now, I think the one message that I have not heard in this room is for people to acknowledge and the families to accept that this condition is very special needs a certain amount of fundamental strength, okay, which is, for example, if I have to talk about myself, I think we were somewhat privileged in terms of economic whatever income level. Number two is that we could also tell relatives and friends, you can take a walk. We don't care what you think of our child. But however, this is my message to everybody else. So we could basically say, I don't care for you, right? Now, I think, we struggle with this at Samatvam. A lot of families, even at, when children have been with T1D for decades, they can't go and tell people. It's a condition that they keep it in the closet. There's several risks around it. At the school, children will not get attended to even if the child has a low or a high. The child is not very safe if it's playing on the field. The child is not particularly safe if the child goes on a field trip. There are lots of risks, right? Now, there's a big problem with girls with T1D, basically because the parents are paranoid about the fact that the message goes around and what will happen to the girl later on and so on. Now, as the child grows up, we've confronted that problem with my son, which is that lots of good-looking girls who want to marry him come around, and at some point in time, the bombshell is thrown at the parents and also at the boy, saying that, T1D, no, sorry, thank you very much, right? So this is a condition that you have to battle at all stages of one's life. When you're a kid, you're at school. As you adult, you got other problems. And then, as you become marriageable age, you got problems. You become daughter-in-law, son-in-law, you got problems. Middle age, maybe life has already caught up. I mean, that's the biology. You can't fight biology ultimately, right? So how do you actually give somebody, the family, the confidence that this should be acknowledged in the open, right? See, to say social media will solve the problem, no, I think it's oversimplified. A video and say that, this is my condition is not going to solve the problem.
Yeah.
The problem is a lot deeper. So, I like the youthful exuberance and the energy and the, the verve and the attitude that the young people bring. But you have to be a lot more nuanced to address the real problem, okay? I've been the elephant in the adjacent room. With that, I'll leave you. I'm sure we all will figure out. We're all very intelligent people. I'm sure you'll figure this out.
Thank you, sir.
Thank you.
Thank you.
Good evening, everyone. I'm Dr. Siddharth Potukuchi. I am emergency physician from NIMS University. So I just wanted to tell you about the experience that we face in emergency room. So there are a lot of people from nearby villages who come with the problems of diabetes, type 1 diabetes, and they come with cardiovascular problems. So what I have seen is these villages have a very little knowledge. So the imposing about the knowledge is something very, very important in the regional level, and where the educational system should include even some of the training programs where they get the students to the emergency room and show how serious these problems can be if it was ignored. So early diagnosis and avoiding the ignorance and quick action after the diagnosis is something that I would be imposing, and I would be requesting all the youth to come forward and take up this action of coming and visiting the emergency rooms and include that in their curriculum, which can help a lot of people, not even in the early ages, even after the diagnosis, for the persistent treatment, which could be a very key role, is something that I would impose being a physician. Thank you.
Thank you. That side. We need to go that side now.
I have one quick point to make. I don't want to hold the microphone for too long. I know I'm falling into the politicians category, not wanting to let go of the microphone. Okay. I just want to draw your attention to the standee that you're standing in front of. The
yes.
right-hand side.
I know it.
A point right on top, which is, I actually pointed that to someone yesterday. Any of these conditions, actually, the medical side is critical, that we all acknowledge. But I think, the most critical element really is understanding an empathetic healthcare. In this case, if there is a mental side which is being brought up, it is not because the medical side has, failed. It is just because I think they've not been understood. Our Dr. Srikanta has one, criteria for people who say, who hear the Stephen D condition. When somebody says that I take 3 shots a day or 4 shots a day, you have no understanding of what it means, right? The only way you can understand is that we bring a vial of, distilled water and get everybody to take 1 shot before you start the meeting. That is Dr. Srikanta's, working guidelines. Any meetings with the dietitian and the nurse and all the doctors here in the room to discuss Stephen D, you have to take 1 shot in front of him. And then you can start your sermons, okay? Just think about it. I don't think, there are too many doctors like him around, so I can't prescribe that as applicable to everybody around here. But, the measure of empathy is that you take 1 shot and then you can give sermons to everybody else, okay? Thank you.
Okay, so we have thank you, sir. We have last 10 minutes. So just maybe 1 or 2 comments from the participants, and then we need to circle back to the chair. Yes, please go ahead.
My name is Ved Prakash Gautam. I'm the country lead for child protection in Children's Investment Fund Foundation, SAFE. Listening to the discussions now, I see a lot of overlap between what we do in child protection and what we are dealing with here with regard to mental health. I just wanted to bring data before this house. I know we have been discussing something a little different till now. there was this Crime in India report by National Crime Record Bureau by the Home Ministry in India. And in 2022, 160,000 self-harm leading to death was reported in India. 160 out of that 160,000 deaths were due to self-harm. More than 10,000 cases were of children who were below 18 years of age. Now, it needs to draw more action than what we see around in India.
Yeah.
We are aware of a Mental Health Act 2017, and I don't have to comment on the status of the implementation of that act. Mr. Pokhrel is from Government of Bhutan. It would have been wonderful to be having somebody in this room from the Health Ministry in Government of India who could have told us how best we can make that act more enforceable, and how do we make mental health interventions in this country more scaled up for young people and children. I just wanted to draw that attention.
Sure. Thank you. Thank you. Yes, this Karthik, right?
Yeah.
Okay.
So the thing was, I think that address what sir mentioned about that how it can be influenced into the government decision-making process.
Yeah.
Me, someone who have been engaging into the global policy-making processes, we have been discussing this KYD usually like
Kigali Youth Declaration.
Yeah, we had a meeting last month and we were discussing because we are working toward United Nations Environment Assembly in 7th session, and there's something we are proposing toward youth engagement, which is the usual engagement. What I understand so far working for 4 years in the international policy making space is that we create a soft movement. Like we create a declaration, we try to incorporate, we try to put a language proposals into the ministerial declaration and then the resolution, which is globally accepted in a treaty, in a formulation. Then it comes to the national level, again a lot of soft movements being built, and then after I think a decade it comes into the action. So it's a big timeline we work in, and that's what, you know, interagency collaboration happens. So even why I just raised my hand was that, of course, KYD, I have read it earlier even. So it would be really relevant that if we can have, of course, the endorsement done, just not by individuals, but by the organizations, which will be a strong point to take it ahead. And then, of course, taking this KYD into other spaces like of UNIA, we host Youth and Movement Assembly. So before even hosting the assembly, we have mentioned into the ministerial declaration in the second paragraph of the declaration, which is being done by the presidency of the UNIA.
Right.
You know, so that's movement takes. So it took us around 6-7 years to come at this juncture where we are able to push that, and then we are able to influence the negotiation, which will be happening in the December later this year. So I think that kind of synergy is very required in the policy space, and then of course the funding and the finance, and a lot on the communication part, which will lead to bridge the gap between the solution and the problem.
Right. Thanks. Okay, last.
Hi. Okay, my name is Colin. I'm from the Singapore Health Promotion Board. I too was diagnosed with type 2 diabetes since the age of 17, so this is a very important discussion. So thank you for that. So I just want to bring another perspective to the discussion. So while it is very critical to bring youth living with NCD, like some of us here, into the global conversation, I believe the larger challenge is actually this. How do we actually shift the mindset of the broader youth population? The majority, which is the majority who don't yet to see NCD as their issue. So youth or young people often feel invincible. Health issues seem very distant, a future problem for them. So my question here is to the panelists and also to the audience, how can we actually make NCDs part of the youth priority agenda before illness actually strikes? So what behavioral, social, and systematic levers such as peer influence, your family, social connectedness, or cultural movements even, can we even activate to build a youth movement around NCD prevention beyond just those already affected like me and some of you are here? So in short, I would just like to bring across that it's not just about reaching those who already understand this risk. It's about activating those who don't. So the next question is, how do we bridge that gap? So thank you for much.
Seema, you want to answer?
No, I just don't want to answer that. I want to say I'm hearing a lot of different people saying things like there's UNICEF working with youth, there is organizations working with youth. To me, the only thing that will work is the word he ended. Who's a bridge? I know Padmaja likes to serve as a bridge for various organizations to come together. And something that Saburi mentioned to me, influence.
Yeah.
To be an influence to bring. We can't work in silos.
Yeah.
There has to be a bridge. Everybody can't be saying, I'm doing this for youth, I'm doing this with youth, I'm doing
Exactly.
this with youth. It has to come together as an ecosystem and have more people like her who are saying we form that bridge to do that.
Well, absolutely, absolutely. So coming back to this question, any of the panelists who would want to comment specifically? Georgia? Of course, go ahead.
I don't think I have the answer, right? You just raising a very important point. As a mom of a 17 and a 12-year-old, what I can say is that I've seen a lot more now in young people that they value, at least what I'm seeing, they value healthy lifestyles. And I also seen many of them being very outspoken against smoking and tobacco. So really understanding the issues and being even my 12-year-old, 11-year-old, she's championing that with me, with her peers. And I think what's interesting is you talked about a social movement, right? A global movement. And I think that we are seeing pieces and pieces of it. Sometimes on social media, you have some young people that are becoming the ambassadors. I think that there are a lot of interesting initiatives also within the education system where they're connecting more with the healthy lifestyle agenda, the nutrition agenda. So as you say, there are a lot of areas, and I like her point is how do we then understand how to connect the dots to make sure that that agenda it comes across in a more holistic way and all the partners are speaking to each other. I'm the chief of YUVA. YUVA is a program that supports young people. It's mostly around skills building and the transition to employment with the view of how do we support the young people in India, 300 million, with access to those skills and expertise to flourish in the future and have access to opportunity. But something that YUVA does really well is really the partnership platform. Yeah. So bringing together young people, bringing together the government, bringing together the industries, bringing together the foundations. And so what are all the stakeholders? And what's really working well, I think, is really thinking about the issues together and everybody seeing how they can bring in their knowledge or know-how, the finances, whatever, to go towards the same direction. Maybe a setup this way would help move the needle forward in a holistic way, because I do think there's a lot happening. It's just maybe happening in silos. I don't know if this is helpful.
Thank you, Georgia. So before I hand it back over to Renee for the closing remarks, any of the panelists, you've heard a lot of discussion happening. Any last thoughts, comments? Yes, Padmaja ji.
I just want to take a minute after hearing all of you to turn the tables a little bit, especially with type 1 diabetes. Listen, I really appreciate and want your support and understanding and all of what we've spoken about. But I also want all of us, and maybe I say this on behalf of my friend Jyotsna, who I know is also a T1D, that we have some responsibilities too. And support us to take care of those responsibilities. Don't feel sorry for us.
Yeah.
We got this, right? And we want you to know that. And yes, there are certain things we have to do. We make, I think, hundreds of decisions a day. I don't even know. That number keeps fluctuating every time I read it on social media, but yes, I know we make a lot of those choices, but we can, and we are okay. So let's just have a proper understanding of this condition. Let's not discriminate. And at the same time, let's empower those, especially those who are newly diagnosed, with what they can do. So I just wanted to bring that up.
Right. Anika, you have a comment? Yeah.
Just I would like to continue what Padmaja said. I'm Monica Arora. I am president of the Global NCD Alliance and affiliated with PHFI and Hriday. So yes, this discrimination has to go, and I always say these in meetings, we are all people living with NCDs.
Yes.
There's actually no discrimination, because even if we do not have a condition, we are taking care of someone in our family who has NCDs. I'm sure everybody sitting in the room can agree with that. There's not a single family where we do not have a person living with NCD. So let's work towards it as a family, and we have to collectively look for solutions which are respectful without any discrimination. Thank you.
Thank you. So we're on time. I'm handing over to Renee, our chair, to talk through his reflections of the session and, of course, what are some next steps. Over to you.
No, thank you very much. I'm not a very disciplined sort of. So I'm taking the liberty to reflect, or maybe to summarize what I've heard in this room. It's a very small room, but I can feel the intention, I can feel the will, I can feel the commitment, I can feel how personal experiences are very important. I have written some of the things that I heard in the room here, which is more important than me coming in with numbers and the traditional narrative. Not taking action is not an option. Not taking action is not an option for any of us in this room. We have to take action. Thank you. I go all of this from you. Huh? Some of the children do not need to die due to our inaction. Some of the children do not need to die because of our inaction. And this one is coming from you. We know the issues. We, young people, I mean young people too. We know the issue. We have a voice. We can contribute. Moving forward, and Cynthia is gone, but I think one of the things that is important that we should get out of the room with it is we have the collective responsibility to get the C at the center of the NCD.
CDs.
Children at the center of NCD. It goes beyond only the children. It goes to the communities, because we are active members of the communities. We are change makers of the communities. And to summarize some of the points that came out from the Kigali Declaration, keep it very simple, not very complex language. We can take action by leading, by having the lead behavior, leveraging investment. It's about enforcing policies. It's not about developing policies. It's not about disseminating policies. It's about enforcing policy. It's about advocacy. It's about driving action. And for that, we have to give the lead to the youth. We need to put the youth perspectives as one of the priorities and make sure that we are not just receiving services, we are not getting the narrative from all people like me here, but hearing from them, supporting them, empowering them to move things forward. It's about co-creation, working with them to come to action. It's about networking. And someone in the room mentioned the importance of collaboration, partnership, multi-sectoral contribution. It's very important. It's not only about the health sector. It's about education. It's about child protection. It's about all the sectors of the society. It's an all society approach. And maybe ending up with some of the things that this one I got it from you. Yes, I changed it a bit, but I think it's still the same. Just to conclude and highlighting, emphasizing the importance of moving forward. Moving forward, first, it's about, for us, this should not be only about this session. It should be how, when you're getting out of this room, we take action. Action in terms of bringing to the forum the opportunities that we have in terms of advocacy, but also at home, in our workplace, at school, in the street. Whoever we encounter, we should make sure that this is brought to the attention so that we all take action. And beyond that, I know all the advocates here will take this forward in terms of how we make sure that during the next fourth high-level meeting at the UN General Assembly, this is actually sharing again with them and sharing the reflection that we had here. Having said that, I would like to thank you all. I'd like to thank the moderator, the facilitator. I would like to thank all the panelists here. Maybe I should go to the help. Thank you, Shitenshu. Thank you, Namika. Thank you, Saburi. Thank you, Ari. Thank you, Padmaja, Princess. Thank you, Ariane. Thank you, Georgia. And last word, through storms and silence, we found our strength. And I'm adding this. And we have a strong voice. And together, we can win. Let's get together and move this forward together collectively, because nobody should die. Some of the children should not die. And no action is not an option for us. Thank you again, and let's keep it moving.
Thank you so much to the chair and all the panelists. Before we leave the room, we would like to take a group photograph with everybody, and if everyone can hold a copy of the Kigali Youth Declaration, we would be very happy. So we don't have copies for everyone, but we can share. Okay, great. I was seeing you with the... Okay. Thank you. Yes, of course. I mean, it's okay if you're not on health. Youth advocacy is just so powerful. I'd love to be in touch with you when you know. Sure. Yes. Absolutely. Yes.